Good morning to all my respected teachers and dear colleagues. I welcome you all for the second day of IACTS SCORE 2021 program. The former US Secretary of State, Colin Powell, has said, "There are no secret to success. It is a result of preparation, hard work, and learning from failures." I now request Dr. Prasanna Sima sir to guide us through the complex course of CAT studies and angiograms.
Okay. Now, why do we do cardiac catheterization? It is to build up the picture of the heart. I told you now that whenever you are seeing the investigations, we are trying to build up information about the patient. So one must not forget that the cardiac catheterization is a tool, and we are trying to use that tool to get more information about the heart, and in this case it is both anatomically and physiologically. Next slide, please. Next slide. Now, any study has got certain components. For example, if you are saying echocardiography, you will have to think of certain components. You never try to read anything in a haphazard manner. So similarly, in a cardiac cath, there are certain things that we have. The first is cath course. That is, how does the cardiac catheter pass through the body, through the heart? This gives a lot of clues. We will be discussing that. Next is oximetry. Sorry for the spelling. Then the hemodynamic studies and angiography. So if you are asking, if you are asked a question about the cardiac cath, or what is a cardiac cath, or even if you have to report a cardiac cath, you have to do it in these 4 steps. Very vital. See, if you follow a protocol, you will not miss anything. Okay. Next slide, please. Now, cath course. Now, can anyone tell me why is a cath course shown and why is it done? Can you tell me?
To find any anatomic defects where the catheter course is going.
Yeah, but I can, anyway, I'm going to inject, no?
Yes.
Anyway, I will inject dye.
Yes,
but why am I not doing it? Why still we pay attention to the cath course? See, let us assume that the child is 3 kg or 5 kg. How much contrast can you give? 3 kg child.
So 5 ml per kg.
5 or 6 ml per kg. So how much will you give?
So if
18 ml.
18
Before,
ml.
and suppose you want to inject into the LV or RA and do so many injections. Where do you have enough contrast to do it? So you're going to cause contrast overload.
Yes.
Contrast toxicity. Patient can go into renal failure, volume overload, lot of issues can occur. So you want to minimize the amount of contrast. So wherever you can get an information without wasting contrast, if I can show something which is diagnostic, I don't have to keep doing that. So this is like in a game of bridge. I say 2 of hearts means I know that I'm trying to build a heart suite. The other fellow, my other member says, I want 4 of spades. He is building up a spade suite. So you will try to give him the spades and you will try to take the hearts from him. So, same way we are trying to signal that, oh, this is the thing, this is the thing, this is the thing. Next slide, please. So it is to reduce the quantity of dye, as I said, and diagnostic cath courses are self-explaining. Next slide. So now, how do we read a cath course? Now, first we have to see whether it is an arterial catheter or a venous catheter. Remember, arterial catheters never have an end hole. Simple thing. If you can see a hole at the end of the catheter, it is not this thing, and usually it is a pigtail. Now, why do we not have end hole catheters? Anyone knows? Why do we not use end hole catheters? No, nobody knows. It is because you can get intramyocardial injection or you can dissect because you are doing a pressure injection. So now you imagine that you have an end hole and you poke it there and it will directly go and it will inject into the myocardium, cause fibrillation, or it can go into the aorta and it can dissect. Whereas if you have a side hole catheter, and the 2 commonest catheters are a pigtail, which is like a pigtail round, and it has got, and so it doesn't directly inject. And the other is an NIH catheter, National Institute of Health catheter, which is having a tip which is closed, but it has got a side hole. Now, the next thing that you have to see is from where is it going? Is it overlapping the spine or on which side of the spine? How does it course and what is the diagnostic course, if any? Next slide, please. So this is the exercise. So we will focus on the exercise. I need students to come here. So this is an interactive session and you need to come with me and do this. Now I will give you a cath course. This is the cardiac silhouette.
Yes.
This will be the spine.
Yes.
So now I am taking a catheter which is going like this. Describe.
Sir, the cath course is from the femoral vein, right femoral vein into the IVC, into the RA, and through the tricuspid valve into the RV.
Okay, so this is the simplest course. Now the same course I will change. Can you please focus here? Here. So this is the first course. So this was IVC. It is a catheter going to the right of the spine and it is coming like this. Now I will change this and make it like this. Now it is no longer going like this.
Yes,
instead of going like this, now this, others can come. All of you have to wear the mask. I need not have to tell you this. You see me mask and goggled up.
So
Okay.
The coronary sinus.
Coronary sinus, why? It has gone higher up,
Yes.
but it has entered inside.
Into the
Yeah. Give the mic.
Yes,
Students come, all of you should not stand like an harem. So it has gone through the interatrial septum and it has the LA and it has come like this. Okay. Understood?
Yes.
So I need not tell anybody that there is a ASD or a PFO through which it has traversed. Now I will give you another this thing.
So ASD, sir, through the IVC into the RA, through the ASD into LA into the pulmonary.
Okay, I'll make it. Sorry, I'll put it this way. See, what is the thing that you are seeing here?
LSVC, sir. LSVC.
You have seen something. See, the moment it crosses this thing,
Right.
that means it is something which has got a communication between the neck and the.
Yes.
What are the things that can have got a communication between the neck and the?
LSVC.
It can be the cerebral vessels or the veins.
Veins.
So something has entered here, but it has to enter like this. This is through the coronary sinus, and it has this. Okay.
LSVC.
So now, so you see, I don't. So if I want to show a left SVC, I will just place it like this, and I will not take any photograph. I mean, I will not take any contrast. I don't have to inject into the this thing. Now another thing is now we will do a little bit more difficult thing.
PDA.
This is called as the
Hairpin
closed pin. This thing. Can you tell me how it is going?
So IVC into the RA.
RA.
RV into the PA through the PDA into the descending.
PDA, it has gone to the aorta and it has now
descending
thoracic aorta. So I have pushed it down. Whereas if I were not now, if I do this, or rather like this, that was called as a closed hairpin bend.
Yes.
Closed hairpin bend. Okay, like a lambda or what. Okay. Whereas here it is like this, open hairpin bend. So if I were to alter the angle wherever I go, this will continue to be like this. Whereas here it would look, if I were to go in a particular angle, it would look cross. But as I turn the machine, it will open up. Now this is opened up. So where do you think it would have gone through this open hair?
AP windows.
Not an epid. Again, I will say RV, through V, not PA, through VSD. There is a VSD.
Yes.
It has gone to a malpose aorta and it has. No, it may not tetrad. It is just a VSD. Is it not? Need not be tetral. Don't surmise more. It has gone through a VSD, through a demalposed aorta, and it has come in. Okay. So there are a lot of diagnostic cath courses. Now, suppose I have one coming like this, and I have, what is this catheter? Pigtail catheter. And the two catheters are running parallel to each other. Two catheters have entered into this thing. They are not touching each other. One is an arterial catheter and one is a venous catheter, and it has come in like this. And they are running parallel. When I see two catheters running parallel, no, this is typical of CTGM. Because the plane of the septum is altered, they can run parallel. Normally, if I were to pass an arterial catheter like this and a venous catheter like this, they would cross each other. Means the plane is like not like this. This is the plane has become a phase. They will appear as if in the anti-frontal projection, they would look as if they're crossing. But here they're not crossing, and whatever I do, I cannot make them cross. That means to say the septum is lying aphase here, which is the condition where it lies in that condition is in a corrected transposition. Now we will give you a little. I put a catheter like this, and this is the shadow of the heart. And nowadays it is less done, but come what may, it is not touching the outer limit of the near the lid. Now what do you think this is? I put a venous catheter. I put it here. Where is it? IVC? RA. Now I keep poking like this. Huh? No. Huh? Thickened pericardium, because the pericardium is so thick it cannot touch. So outer border and this thing, if it is wide, more than 5 millimeters. So in the olden days, when you wanted, if they were doing a cath for constrictive pericarditis, then one of the things that they would do is place the catheter. Now I will put a catheter like this, and it goes out.
So supracardiac,
PAPVC. It is just a PAPVC. It has gone from RA, SVC, into the pulmonary vein. If I have a catheter which is going like this and
ASD.
Yeah, because it has gone into the
left pulmonary.
Gone outside the cardiac silhouette, it has to be through the pulmonary vein. Then see, there are some classic ones.
Check. Hello.
TAPVC.
What type of
supracardiac TAP?
Can you tell me the course?
Sir, IVC to RA.
IVC to RA.
Through the SVC. Through the innominate vein. Through the vertical
vein. What
vein.
is called as the bridging vein?
Yes, common chamber.
No, not common chamber.
Vertical vein. Then common chamber. Then into the pulmonary.
Then it has been pushed to this way. You can push it to this way. You can actually push it like that, like that, like that. So there are multiple cath courses. They are there in every textbook, but these are the some of the things which we have given. We can keep on talking about these cath courses, but you realize that these are some standard ones which are there. Okay. Clean the board, please.
Yes.
Okay. Yeah, can we have the next slide, please? It is vital that you people participate in these things because, quick, please. Is that the next slide? Okay. Now, hemodynamic study is an important thing. For this, we need to know some normal values. We need to know the normal waveform. We should be able to draw the pressure trace. I want a student to come here and draw. Come. What is the normal LVEDP? and RV-EDP. Come. Unless you know the normal values, what is the normal LV-EDP?
10 to 12.
10
to 12.
So you should say not more than 12. What is the normal RV-EDP? Not more than 8. You remember that. It should not be more than 8. Now I want you to draw a atrial trace. Atrial trace. Okay. A. You want to have a C and X descent means down, and V and Y is down. See how you draw also. Now I want to ask you. I want to know if it is a LA trace or a RA trace. Assuming no ASD, how do I differentiate between the LA trace and the RA trace?
The RA pressure will be 0 to 3. LA pressure will be little high, sir. 5.
Let us say that, but by looking at the trace, can I tell? I'm not sure whether I'm in the LA or in the RA. By looking at the trace. Okay. What is the LV-EDP?
10 to 12, less than 12.
Less than 12. So what is the compliance of the ventricle? LV higher than the RV or lower? Is it less compliant? Is it stiffer?
Stiffer.
When does the blood go from LA to LV?
In the diastole.
Diastole, which wave?
In the
V wave.
V wave.
So what should be the wave in this thing? It will be higher V wave compared to a higher A wave in the RV. RV, the ventricle is compliant. It can relax and this thing. So when it is filling up, it fills in, pops in. So the V wave is not very high. Whereas you have a stiffer ventricle and so on. So you have atrial trace. Now ventricular trace. Draw a ventricular trace. No, draw it down here. Or else better still, we will make it now draw a line here. You may have to draw 2 or 3 times. Now draw a ventricular trace. Draw atrial traces. Where will it be? If this is the baseline, where will the atrial trace be? Where will the atrial trace be? If this is 0 to this is 120, this is 0. Illamma, it is somewhere here.
5.
This is 120, this is 10. Let us assume. Now draw atrial trace. You have to quickly do. Then we can do. Keep drawing. Keep drawing. No. Atrial trace. Going on. Now I push the catheter into the ventricle. Now, how will it go? Other students, come. All of you stand. Parde mein rehne do.
Dr. Prasanna, can we see the board, please?
Yeah. Please show the board. They are actually focused on the board. It's not.
No, we can hardly see anything actually. And let him draw the arterial and the venous trace all in the one picture only. You know, the atrial trace and the arterial trace. I think he's trying to do that.
Can you focus some light, Satish? Can you focus some light on the board and you can plan some?
Can you please put?
It's better now. Thank you.
Right. Now mark the ventricular trace.
Reaches 120. And base will be this one.
No.
Will it really look like this? What are the components of the ventricular trace? It goes up, I agree. And it goes up to what? To the systolic of that ventricle. Then it
dicrotic notch.
No dicrotic notch. Dicrotic notch does not exist for the thing. Then it comes down. Now tell me what happens here. We need dark pens. Okay, now it has come here. Now what happens? Now what happens? Does it just turn like this? You know, you don't know. It goes below. What is that called as?
Diastolic
No,
dip.
that is called a dip diastolic.
Diastolic.
There is a dip diastolic and then it comes up. It goes down like this, like a spring it goes down and it comes. This is called as a dip diastolic. Then it comes back to a level. This is called as the end diastolic pressure. So it goes up, comes down, bounces down and comes like this. This is called as the dip diastolic. And then this is called as the end diastolic. Now the next one comes like this, goes down like this. Now go to a arterial trace. Draw arterial trace now. You pulled it up, it goes up. Now what happens? And draw the next one. As I'm
It slips to 80.
not so, you think 80, you should have a sense of proportion. It will be here if that is 120. Now can you tell me what are the waves? What are the waves here? So you will see that no longer is there a dip diastolic, but it will go up. Now what is this wave?
Upstroke.
Called as percussion wave,
Percussion
tidal wave.
tidal
What is this called as? Dichrotic notch. If there is a notch in this place, what is it called as?
Anacrotic.
Anacrotic notch. Now remember, so if I do this, like this. So the same thing. So you have to know, looking at the wave, you should be able to tell whether it's an atrial trace, ventricular trace, or a great arterial trace. Okay. Now, slide please. Only one student should not be there. Others come. Come. Keep showing. So now we have done, we have talked about the traces. Now the next thing is, what is zeroing of a transducer? Whenever we draw this thing, see, this becomes important. Are we doing a hemodynamic study in the recovery, in the OT? Don't think that hemodynamic study is only the preserve of the what do you call it, cardiac cath lab. We are doing cardiac cath in the OT. We are doing cardiac cath in the recovery. We will give you exercises where I will show you how we are doing it in the recovery. Now, what is zeroing a transducer? Now we have to go quick. Zeroing a transducer means what?
Getting the transducer to set it to the atmospheric pressure.
To set it to atmospheric. So you should know what it is. They can ask you in DNB in the ICU rounds. I may ask you zero this transducer. What is damping of a transducer? Can you show me what is a damped trace? I will show you. See, you must know whenever you are using something, what are the errors in the trace. So this, let us assume, is a arterial trace. Now, how does a damped trace look like? Come, draw.
Amplitude will reduce.
The systolic will come down, diastolic will, no, you're making camels here. Dromedary camel. So the systolic will come down, the diastolic, and it will be a blunted trace. When does this happen? When typically, when does it happen? Give me one example where the trace is damped.
Arterial line is
when is it damped?
Positional.
When it is kinked or if there is air bubble. Why air bubble? Because air is compressible. So instead of transmitting it, it just compresses the air bubble. Otherwise, the fluid filled manometer will transmit the pressure. Now, what is hyperdamping? Hyperdamping is when it goes higher and lower. When does hyperdamping occur? When you are having a catheter width, for example, you should see, previously they used to get spiral type of catheters, I mean tubings. So if you have a tubing which is oscillating, it can whip and hyperdamping can occur. There are many reasons for hyperdamping, but I am giving you just one example. Next slide, please. Sorry, show that slide. What are we have to discuss? Can you give a double screen? Now, how is a cath study done? Now, what do we do when you're doing a hemodynamic study? You pass the catheter in, you go as distally as possible, and then you start pulling back. So the trace is typically called a pullback trace. So here we have shown it going like this, like this, like this, like this. But actually the study is you push it as far as possible and keep drawing. You keep drawing. You also take the samples. You want to do it quickly, no? You have a sick patient. So you pull back trace. So you'll have an arterial trace, ventricular trace, and then come back to this. And then you can do some certain provocative maneuvers, which we'll discuss a little later. But so that is that. Then the most important thing is, many times we want to compare two pressures. Typically, they are what we call as peak-to-peak gradient. For example, I have a block and I want to, I will measure here, I will measure here. The peak-to-peak gradient gives a gradient across whatever I'm doing. It can be a valve, it can be some narrowed area. So this is called a peak-to-peak gradient. Ideally, peak-to-peak gradient should be done with two catheters simultaneously. But that means I have to poke twice. So many people will pull back across and then take the gradient. And then they measure peak of this to peak. Let us assume that there is a ventricular trace. And the next thing is like this. So here I got in the distal ventricle, I got this high pressure. I mean, proximal ventricle, I got this high pressure. This side, I got this much. This gradient versus this gradient is the peak-to-peak gradient. Typically, historically, peak-to-peak gradient was what was being used. But the issue is that peak-to-peak gradient is an instantaneous gradient. But unfortunately, sometimes when pressure is transmitted from one area to the other, when you are not, what can happen is that for example, if you have the aortic valve in aortic stenosis, if I were to draw the ventricular trace like this, and I draw the the arterial trace like this, you will see that the peak here does not correspond to the peak here. So then they started doing a little bit more this thing, and they found that rather than taking the peak, if you integrate the whole area, the integration means what? The area under the curve, that corresponds to the mean, will give you the mean mean gradient. And even if I take this and integrate, it was correlating better. So modern day machines, cath machines, can actually give the integrated mean gradient if you ask for the software. But cardiologists may not always do it, but that is more accurate than the instantaneous peak-to-peak gradient. Now we have already EDP, where is it measured? We discussed the dip diastolic, and then now I want to know what does it correlate with? What does the EDP mean?
Correlates with the LVEDP, correlates with LA pressure.
Should correlate with the LA pressure, provided
no stenosis across.
There is so the EDP cannot be, the LA pressure cannot be lower than the EDP. Understood? So if I know the EDP, LA pressure has to be higher, because always water, remember, in cath, water always goes from high pressure to higher level to lower level. You cannot have blood flowing from a place of lower pressure to higher pressure unless it is being pumped. And when the mitral valve is open, the atrium and the ventricle are acting as one chamber, and you cannot have a higher pressure in that. The next thing is,
we have 30 more minutes, sir. 30 minutes.
Okay. Now the balloon occlusion pressure. What is balloon occlusion pressure?
Put a balloon and place it.
Yeah. Now what are the, now my favorite question is, how can you do pulmonary capillary wedge pressure? What does it reflect?
LA pressure.
LA pressure.
LVEDP.
Why is it possible?
Sir, because from pulmonary capillaries to LA, there is no.
There are no valves. Okay. Okay. The next slide. Keep the slide on, please. So And then another thing that you must know is the transpulmonary gradient, which is from the between the basically you're trying to find the LA pressure to the pulmonary artery mean. Okay, next slide. We may have to skip some things quick. So this is what is called as a Vigorous diagram. Everybody has to know to draw it. In the exam cardiac cycle, you have to draw a Vigorous diagram. You should know the correlation between the ECG, the ventricular trace, the aortic trace, atrial trace. Okay, Vigorous diagram is there in every book. Your physiology book has it. Next slide, please. And I'm not going to go through that. Now, we have specific examples. How do you differentiate between ASD and a PFO on hemodynamic study? I'm not going to teach these things, but now you have to tell. ASD and PFO, how do you differentiate on hemodynamic study?
PFO will stand right to left.
Hemodynamic study, I only have pressures. I put a catheter here, I put a catheter in LA. How will I say that it is a quick? See, if you want me to, I will stop at 1 hour. No. There are you will write. Remember, see, there are some like when you say Bhagavad Gita opening line, Dharma Kshetra, Kurukshetra, Samaveta, Yudsama, Mamakaha, Pandavasteva, Kimakurvata, Sanjaya. It has to be told that way. Opening line. Similarly, you will write, say there is equalization of. You have to tell equalization of mean and phasic pressures. See, please, ASD is the worst case to get. Equalization of mean and phasic pressures. So, if within, and what do you mean? Within 3 millimeters of each other. So, if I have A wave, C wave, V wave of the right atrium and ACV of left atrium, they should be within 3 millimeters of each other. Okay. So equalization of mean and phasic pressure. Non-restrictive VSD. How do I diagnose non-restrictive VSD? Equal, but how much error? I told you, no, we are not doing simultaneous. Up to what level is it allowed? 10 millimeters of mercury. So non-restrictive. So if it is LV pressure is 90 and this is 84. Okay, it's still because variation will be there. You're not taking it very simultaneously. Now, we have already discussed diastolic dysfunction of ventricles. I told you LVEDP more than 12, this one more than 8. If all the diastolic pressures are equalized, for example, RVEDP is 16, the LVEDP is 16, CVP mean is 16, LA pressure mean is 16. Constrictive pericarditis, correct. Equalization of diastolic pressure. Then the last one is in the hemodynamic trace. I will show you a trace. It goes like this and it comes like this. See? Don't you see that? This is called as square root sign. Square root sign occurs in 2 conditions. One is chronic constrictive pericarditis and the other is it restrictive cardiomyopathy. Now, if the square root plateau is more than 1/3 of the total height, you think of that of CC. Whereas if it is less than 1/3, you think of restrictive cardiomyopathy. If the PA pressure is high, more than 50 systolic, you think of restrictive cardiomyopathy. It's very difficult. Everything cannot be determined fully on CAT. Next slide, please. So now this we will skip, but basically remember, transpulmonary gradient more than 12 means that there is some problem in the lung. Okay, that is there is the PVR is high. This becomes very important in Fontan, Gintan and other things where you should not have a high transpulmonary gradient. If you have a high transpulmonary gradient, patient can, we don't have enough time. Next slide, please. So this is what I was telling you about peak to peak gradient versus mean gradient. Next slide, please. Now we will go to oximetry. How is oximetry done? Anyone knows? Yeah, distally, and then you do a pullback and you keep drawing multiple samples. Now, how is 100% oxygen given in cath? Because you have all done cath postings, so you should know how is 100% oxygen delivered in the cath for hemodynamics too. You have to have a full occlusive mass. You cannot give it with a face mask. So pullback we have done. What is a significant step up? This is a very important thing because we will spend a little time on this. What is a significant step up? See, in 1 hour's time, we have to do quick revision.
Ventricular level 7 and 11 and 11.
So why do we have repeated runs? We will remember, get this table ready. Black pen, blue pen. Okay. Now you have at atrial level, ventricular level, great arterial level, first run, second run, third run. Now second run, why multiple runs? We will come to that. Now remember, you can have 10, you can do this simple method 10, 7, 5, 7, 5, 3, 5, 3, 3. So if I get a step up means I have in the let us in the SVC, IVC, we will come to how to calculate this, which is called as Flamm's formula. We will be discussing that. Let us assume that whatever value is 70%. If I get a step up to, let us say 82, that is more than 10, it is significant. But now we have to tell, how do we determine the saturation in the great veins? Anyone knows? It is, what is the problem? What is the color of the SVC blood from the SVC cannula versus the IVC cannula? How many of you have seen? Which is darker? SVC is darker. Why? Not because your brain is not function is this thing. No. Your brain, it will be higher. No, it is not that. It is because the kidney has, how much of cardiac output goes to the kidney? 20 to 25% of the cardiac output goes to the kidney, not for consumption by the kidney, but for filtration. Similarly, the portal circulation. Okay. So these things will cause this thing to be around 85%, whereas the brain is around 75%. Brain and upper limb are 75%. So now how do you do this? You use what is called as Flamm's formula. There are various formula, but 3 SVC plus 1 IVC divided by 4. So I will, if I get 10 step up, that is significant. But now but the problem is, why in the right atrium you need to have 10 is because the right atrial chamber, there is blood coming from SVC, from IVC, and which is the lowest saturation in the body? Coronary sinus, which will be 45. So depending on where I put it, I may get this. So I have to take a wider thing to determine the truth. Now, cock crows, sun rose. Second day cock crows, sun rose. Third day cock crows, chance of sun rising higher, because the say that, remember, causation is not association. So there's a higher association of cock crowing and the sun rising. So if I get a repeated step, this is called as Bayes theorem. So in Bayes theorem, pre-test probability is determines post-test outcome. So I found once a step up, I need to have a higher this thing. But if I repeat it twice and I find again, oh, it is the truth, so I don't need that. Third time also I get it. Oh, yes, this must be the truth. So first run 10, second run 7, 5, 7, 5, 3, 5, 3, 3 in the great art. So these are the significant step ups. Next slide, please. Oh, sorry, same slide. Come to the same slide. So why multiple runs we have done? How do you calculate a shunt? By determining the QS. You can, what is QP? QP equals what? Cardiac output divided by pulmonary systemic and the pulmonary arteriovenous difference. Whereas QS will be equal to same thing divided by or rather oxygen consumption. Oxygen consumption by systemic AV difference. So QP by QS is equal to systemic arteriovenous difference divided by pulmonary artery. Remember, it goes ulta because it is oxygen consumption divided by pulmonary arteriovenous. By QP by QS eliminates the oxygen consumption. Okay, this you should be knowing. Next, so you what is the pulmonary? Now I'm going to give you what is the pulmonary venous sample normally. 100%. If the pulmonary venous sample is 90%, what do you think? There is primary lung disease. If the systemic arterial now low mixed venous saturation during cath, if the mixed venous saturation is 55%, low cardiac output, very important. And then you should know what is the oxygen extraction ratio. Oxygen extraction ratio is the arterial venous difference by the arterial saturation, and it should be more than 25%. That it becomes very important in Norwood and single ventricle physiology. I think they'll be talking to it in ABG. Next slide, please. We're running out of time, that is why. Next slide, quickly, please. The slide should move quickly. Okay, we can't do an oximetry exercise now, but we will. If there is time at the end, we will do it. Next slide, please. Now, we will do this in the end if there is time. Next slide, please. Now, angiography. How do you read? You have to follow the course of contrast. But now, how do you do it? First, you identify the view. In modern day angiograms, they even write it down. So use your common sense and see the what is written. Otherwise, you should be able to identify the view. See where is the spine. Classical views can be self-expected, and you should have multiple views. Why do you need to have multiple views? Huh? Yeah, they can foreshorten. They can be an eccentric plaque may be missed, and you have to determine where is the stenosis and what is the type of distal flow. You follow that, and you have to know how to do grading of regurgitation. Where grading of regurgitation was described by whom? Sellers, and you should know 1, 2, 3, 4 depending upon the contrast opacification between the proximal and the distal chamber. We don't have time for it, but but you should be aware of it, because this is a quick revision. Next slide, please. Now, coronary angiogram, we are going to do the exercise. This is the important thing. Hiramat, we need the torch. Why is LAD? It gives rise to septals. 2, it goes to the apex and it divides and forms a moustache. Right. Why is OM? No. How do you definitely say OM is OM? OM is recognized by the fact that the venous phase has got the coronary sinus coming. So you should see the whole cycle, and in the venous phase, the coronary sinus gets opacified. Dominance, when do you say that it is a left dominant circulation? When the PD is given rise to this, whereas the right, it is giving to the right. And the implications are, if you have a left dominant circulation, you can have even inferior changes. Okay, same thing happens even in OPCAP. Okay, SA nodal artery, do you know where it is given rise to? The first part of the RCA. You should be able to identify. AV nodal artery comes from where? RCA at where? Crux. You should be able to see that. OPCAB, if you see the AV nodal artery coming from the right, you know that a proximal RCA string can cause bradycardia. Read lesions according to the flow of blood. Next slide, please. Oh, we have to do the light projection. Come. We'll have a coronary angiogram afterwards to read. Now, Hiramat will be holding it like this. See now, how do the things look like? You all don't have to blindly memorize. Now see, if I have it like this, can you see this? The light projection, see the shadow. Oh, this is not bright enough, I think. Now, if you see the shadow, can you hold it? Now, pen, please. So in a in LAO, left anterior oblique, how will the vessel look like? Oh, 1 second, sorry, so now you see the LAD like this. If the RCA will look like this, and the PDA will come like this. So do you recognize this view? Now, if I make it RAO, can you see now how it has become? Now it becomes looking like this. Understood? Next, what I want to really show is not these views because they are very obvious and it doesn't require, but the view which I want you to understand is LAO caudal. Put it, see, can you see the torch is LAO caudal. Now, can you see here? I have left main coming here. I have the LAD coming here. If I have a diagonal, where is it going to come? It will come like this. Sorry, wait a minute. LAD is here. Diagonal is coming. And then this is the circumflex coming here. Can you make out? So, LAD is coming here. Sorry, left main is coming here. Left main is here. LAD is coming here. Circumflex comes there. Understood? Okay. If I go like this, now how is the LAD coming? LAD is now coming like this. Circumflex branch is coming like that. So this is which view? Cranial. We'll be showing you the angiogram. So you realize how this left main keeps changing its position. Can you see here? Left main has come here. This is important. Left main has come here. LAD comes here, and the circumflex comes. Circumflex is coming under the OM. So the last thing will be the circumflex. These will be the OMs. The LAD is up here, and it goes like this actually, and this is the OM. This is the LAO caudal view, which is called as spider view. Now you understood how the spider is formed. We'll be discussing these in the final two angiograms. The other one angiogram which we should do is this. Light put the light. See now normally how is the RPA? Come, I always tell RPA is like Bharye. He sits like this. Well, the unfaithful husband with the hand this side. This is LPA, and this is the thing around the girlfriend. Sorry, it is like this. Now, if I were to put the torch like this, if I put the torch like this, LPA is not seen. Can you see here? LPA is not seen. You can't see, right? But if I were to do like this, can you see there? So this is a caudal view. When I put the caudal view, can you see my hand coming up? Like this, it is not seen. But when I put it like this, suddenly you start seeing my hand. So this in the cath lab, how do I get it like this? I put it up, I move it, but this is called as a sit-up view. It actually the patient is not made to sit up in the cath, but the beam is put up like this, and that's how you give the LPA and the RPA in profile during cath. This is useful in tetralogy of fallow cath. Next slide, please. Next slide. So cyanotic angiogram and coronary angiogram, can we play those two? One student has to read the angiogram. You got it ready? In the meanwhile, when they're getting it ready, just next slide, we'll just see. Next slide, please. I think cyanotic angiogram and coronary angiogram. Can you put the name? So now, remember some of the classic, this is all intracardiac sats are same. Can you get the angiograms ready by that time? Supracardiac TVS, all the saturations are there. All diastolic pressures are we have discussed this. PA saturation more than aortic saturation.
Angiograms are ready.
PA saturation, start loading the angiogram, please. PA saturation more than aortic saturation. In TGA or toxic being. And if you are a gold medalist, what is toxic being? DORV? Subpulmonic VSD pH. So gold medalist will be DORV badlu DOLV, subbiotic VSD pH. Okay, but that's for gold medal. But first we have to walk before we can run. So there are 3 conditions. Can we have the angiogram, please? Yeah, come, boy, read it. Laser pointer is here. Come, 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 come. See, we don't have time.
Your mic came.
Get me my that wire. Start reading.
It is.
Can you see now? I'm going to simulate the thing. I have to keep moving it up and down. First one, start from the beginning.
It's
Run it. When in the exam, when you are given how to read an angiogram, don't talk till you see the full angiogram. Understood? See the entire angiogram. Run the angiogram, please, quickly. Run it. See all the views. Look at the course of the blood. But once you get it, don't stop. Are you understanding what is happening? Okay. Read. Come. Come, 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 come. Bride comes to the. Start reading. Stop. Stop.
This is RAO cranial view. Left system injection, RAO cranial view, showing LAD proximal 70 to 80% stenosis, and good distal runoff is there.
Why do you say LAD?
The mustache shine is there, and it is giving septals here. Then I cannot comment about the diagonal view, diagonal changes views.
What you can see, well, you tell. Next. Anything here? You can only see the middle part. You can't see the proximal part. Everything is crowded up and overlapping here. Can you see that? Everything, I'm trying to simulate the view. Everything is.
See the chat. So what is the question in the chat?
Next. Yeah, we are doing that only. There.
Yeah, you can read them. Yeah, no problem.
This is AP cranial view.
As you clear the chats, please. Don't keep them.
Next. Yeah. Show me. Run it, no? Somebody should control. One of the doctors should control it. So again here. What area are you going to see here?
And this is iliacocaudal.
Now see here. Can you see?
Yes.
How LAD and it's going there?
LAD is going.
The diagonals are coming here. The OM, if it is here, is coming here.
Yes.
And the circumflex. Can you see the superimposition? How it is occurring?
Yes.
The light is coming like this, so because the light is there, I am making it look like that. Can you see here how it is equivalent?
Yes, sir.
LAD, I mean left main. Yes. LAD coming like that, diagonal coming here, and OMs are coming here, and this is the circle. Okay.
Yes.
Okay. So now, what is this to be seen? What do you see here? You see the left main
and proximal lesions of proximal segments of LAD.
Okay.
And
You can't comment on too much on the distal part because all those are not well seen.
Yes.
Okay. And you are seeing. So what are you seeing here?
Here I can see LAD proximal.
No. When you see, you say, I see. What are you saying? Is there left main ostial stenosis?
Cannot see.
Oh, you can see because there is regurgitation here. How do you know that there is left main ostial stenosis? What are the 3 things that when in a cath which indicate left main ostial stenosis? Pressure, ventricularization, just like I told. What happens is you start getting the ventricular trace because just like in the pulmonary capillary wedge pressure, here there are no valves in the coronary system. So you start getting ventricularization of the pressure trace. 2, very obviously what is seen here is there is no reflux of dye. Third thing that happens, patient, what will happen to the patient? Zero blood flow to the coronary. He complains of angina. Okay. So the 3, obviously in the cath, you can't say, looking at the thing, you cannot say that there is angina, but what are the 3 things that happen? You should know. Okay. So this is the spider web. Why I want to do is that you should understand how the spider is formed. Next slide, next. So the different views. I would suggest all of you make this thing, this wire diagram and practice with the light, and you will understand how each view is formed. The tetralogy. Next slide, please.
Sir, we need to finish.
Yeah,
We
just
have
one tetralogy thing and over, out, because there's not enough time. Tetralogy, quick. I just want to show why you have to have the, which is, yeah, quickly show
Can you show the tetralogy slides, please?
one angio view. In tetralogy, what is the classic description? When I give a ventricular injection, what will happen in the RV? In the trabeculated ventricle, when I give in an injection,
it will go to aorta.
I will have simultaneous opacification. See, you have to use these keywords. Simultaneous opacification of the both the great arteries. If I say simultaneous, that because virtually the RV is pumping into both aorta and the. Okay, this we will not do. No, show me the. We don't have time for this.
Tetralogy is not playing, sir.
Not play. Anyway, just 2 seconds. What is this? In the recovery, you see this trace. Quick. You are seeing a deep Y descent. This patient is having significant RV dysfunction, even though the systemic pressure is okay. Next, quick. Quick.
Go to the next slide, please.
Quick. What do you see here? Can you see this anacrotic notch? BP is good, but anacrotic notch, when coming off bypass, this was the case. But when you do the TE, you find dysfunction. So looking at this, quick. What is this? Coming up, down, up, down, up, down. Pulses, alternates. You should immediately see the ECG. If they are running the same, if the ECG 1:1 correlation is there, what is the implication? Severe LV dysfunction, increase the inotropes, decrease the afterload. Next slide. Okay, so your most important thing is you have to understand.
Thank you, sir. Well said by Dr. Martin Luther King. We are not makers of history, we are made by history. Cardiac surgery, as we know it today, is a result of struggles and motivation of our revered forefathers, and it is our duty to know and acknowledge those struggles. I now invite Dr. Krishna Iyer to enlighten us about the history of pediatric cardiothoracic surgery.
Good morning, everybody. I see we are suffering a Sunday morning syndrome. We have less participants in the morning than we had yesterday. But nevertheless, we need to go on with our efforts. And the topic that I'm going to be talking about today is the history of congenital heart surgery. And as was just mentioned, that what we do today has been because our earlier pioneers struggled and did things which were far beyond our imagination for those days. As Winston Churchill said, that those who do not remember history are bound to repeat it. And it's very important for our students to understand how cardiac surgery and congenital heart surgery came to be as it is today. It's also important to know that most of the developments in congenital heart surgery in the early days, or in cardiac surgery as such, started with congenital heart defects, because in those days, there was very little understanding of coronary artery disease. Coronary artery disease was not even identified, let alone be treated. And secondly, since prosthetic valves and valve repair techniques were developed much later, it was only the congenital heart defects which were thought to be correctable in those early days. So it's difficult to complete the entire history of cardiac surgery and congenital heart surgery in a short 1-hour lecture, but I will just highlight the main points. And I would encourage the students to read more about this because that's really going to be valuable in their understanding of the surgical treatment of congenital heart disease. So can I have my slides, please? Thank you.
Good morning, dear students and colleagues. This morning, we are going to talk about the history of congenital heart surgery. Now, although congenital heart surgery may seem extremely advanced today, one has to bear in mind that it is not more than 6 to 7 decades old. And a lot of the developments that have taken place have occurred in the last few decades. But we will focus a little more on the early development of congenital heart surgery, because that was the most challenging phase for the development of this specialty. So we'll break up the presentation into the following subheads. We'll talk about the very early days where there were a lot of thought processes about congenital heart surgery, but could not be implemented in practice. Then we had the era where closed heart procedures were conceived and done. Then we moved on to the phase where intracardiac direct vision surgery could be done, both with and without the use of heart-lung machines. We'll talk about the use of hypothermia and the development of infant cardiac surgery. Then moving on to the neonatal repairs, heart and heart-lung transplantation, and mechanical support in ECMO. So these are the various phases through which the development of congenital heart surgery progressed. Now, the early days, in about the 19th century, where a lot of surgery of other parts of the body was being done, the heart was considered sacrosanct. And it was considered that touching the heart surgically was a sacrilege. In fact, the famous surgeon Bill Roth remarked that anybody who dared to operate on the heart would lose the respect of the surgical community. And such was the belief that the heart was a no-touch organ. But then in 1896, a German surgeon, Ludwig Rehm, sutured a right ventricular stab wound and managed to save a patient. And that changed this entire concept that the heart was no longer a sacrosanct organ. But cardiac surgery still was in its very, very early infancy. And surgical procedures were initially just limited to outside the heart. In 1917, Rehm again, and in 1925, Sorbruch, both described pericardectomy for the treatment of pericardial thickening resulting from pericarditis. In the 1920s, Trendelenburg described pulmonary embolectomy. However, he did it as a closed procedure for patients who developed pulmonary embolism and were in acute cardiogenic shock. But then this was associated with a very, very high mortality. Gibbon, who initially started his work, recognized that the mortality of this procedure was so high because the heart could not be stopped for a sufficiently long enough period to be able to do a successful and definitive procedure. And so he started work on a pump oxygenator. But during the same time, in the 1930s and 40s, there were the beginnings of various closed heart procedures. It was only in the 50s and 60s that open heart surgery actually began to take shape. There were other notable developments which one must recognize, which contributed to the development of cardiac surgery as a whole. One of the main reasons why the chest could not be opened in a patient in early days was that opening the chest resulted in a pneumothorax, and in the absence of positive pressure ventilation, surgery within the thorax could not be performed. And it was in 1909 that Meltzer and Orr described endotracheal intubation and endotracheal insufflation. But it is only in the 1930s that this became an established procedure for the delivery of anesthesia. In 1915, J. McLean, who was a medical student in Harvard, discovered heparin. But it was only in 1933 that Charles Best in Toronto managed to purify heparin. In 1912, Alexis Carrel got the Nobel Prize for his work on vascular anastomosis and organ transplantation in animals. But this was a hallmark contribution to the development of cardiac surgery, because cardiac surgery involved a lot of vascular suturing. In 1923, Elliot Cutler tried closed mitral commissurotomy. In 1925, Henry Suthar tried a finger dilatation of a stenosed mitral valve due to rheumatic heart disease. And in 1930s, there were significant improvements in anesthesia, blood transfusion, and postoperative care. And all this contributed to the development of congenital heart surgery. But it was not until 16th April 1938 that the first successful treatment of a congenital heart defect was performed. And this was by Robert Gross at the Boston Children's Hospital in Boston. Robert Gross was a versatile surgeon, but at that time, he was only the chief resident. And as chief resident, he undertook this procedure when his immediate boss was on leave, and he took the permission from the stand-in boss. And that really opened the chapter of congenital heart surgery. Till 1972, Gross had performed over 1,600 PDA closures. But the man who missed the mark in history was John Strider, also from Boston, who had actually done a PDA ligation 1 year earlier in 1937. But unfortunately, the child died 4 days later of sepsis. And so the surgery was not considered successful, and he missed a place in history. So sometimes chance favors somebody, and somebody else gets a place in history because of a slight misfortune. The era of closed artery thus had begun. And then a series of procedures for various other congenital heart defects were described. In 1944, Clarence Crawford repaired coarctation of the aorta. In 1945, Robert Gross also reported the repair of coarctation of the aorta. But since those days, communications were slow, neither of them had learned about the other person having performed the surgery. In 1945, Robert Gross also repaired vascular ring and described surgery for esophageal and tracheal obstruction resulting from a vascular ring. But the most landmark surgery in this period was the description of the systemic to pulmonary shunt for the treatment of blue babies, resulting most commonly from tetralogy of Fallot. And that occurred on 29th of November, 1944, where Alfred Blalock, working on an idea given by his cardiologist, who was Helen Taussig, and assisted by his laboratory assistant, Vivian Thomas, performed the first systemic to pulmonary artery shunt, which then subsequently went by the name of Blalock-Taussig shunt. I'll talk about this a little more detail in the next few slides. But just to complete the picture, subsequent to this, many other shunts were described. The Pott shunt in 1945, the Waterston shunt in 1962, and then the Cooley shunt in 1966. These were different types of systemic to pulmonary shunts which unfortunately, because of the fact that they resulted in a much larger shunting of blood from the aorta to the pulmonary artery, resulted in a much higher morbidity and mortality, and therefore they very rapidly fell out of favor. But it was the Blalock-Taussig shunt which still today remains a very commonly used procedure for the palliation of congenital heart disease. The procedure was modified in 1981 by Mark Delaval from the Hospital for Sick Children, Great Ormond Street. And he modified it by interposing a graft instead of using the subclavian artery itself. So this was the first Blalock-Taussig shunt which was performed on November 29th, 1944. This is the view of the operating room. Again, it's a historical picture. And you can see Dr. Blalock operating with his assistant Vivian Thomas standing behind him. And these were the two after whom the procedure is named. Alfred Blalock on the left, who is the surgeon, and Helen Taussig on the right, who was the cardiologist. And history states that the idea that Helen Taussig got for this procedure emanated from the fact that she observed that children with tetralogy of Fallot who had a murmur of a patent ductus arteriosus were less symptomatic and were less blue as compared to those who did not have this murmur. And so she concluded that patients with tetralogy of Fallot who were severely blue could have relief of their cyanosis if an artificial PDA could be created. And that's when she approached Alfred Blalock with this idea that could he create surgically a PDA to benefit these patients. And thus the Blalock-Taussig shunt was made. And at that time, the unsung hero was this gentleman, Vivian Thomas, who worked as the laboratory assistant for Dr. Blalock. But unfortunately, because he was Black, he did not get due recognition those days. But in more recent times, that recognition has been given to him. And that's his portrait, which hangs outside the Alfred Blalock Clinical Science Building at the Johns Hopkins University. And now it has been recommended that the Blalock-Taussig shunt should actually be called the BTT shunt. That means the Blalock-Taussig-Thomas shunt. Subsequently, there were many other procedures described in the subsequent years. I can't list all of them, but the important ones are listed here. In 1946, Sellers described closed pulmonary valvotomy. In 1947, Dr. Russell Brock from Britain described an instrument with which he could perform an infundibular resection in patients with tetralogy of Fallot and thereby relieve the pulmonary stenosis and relieve cyanosis. And this procedure was popularly known as the Brock's procedure and was used for many years and provided relief to many patients. For patients with transposition of great arteries, before the advent of the balloon atrial septostomy, Blalock and Hanlon described in 1948 a closed atrial septectomy procedure. In 1952, Muller and Damon described the now still used pulmonary artery banding for patients with increased pulmonary blood flow and pulmonary hypertension, resulting from an intracardiac left-right shunt. The Glenn shunt was described by Glenn in 1958, and this was a superior cava to pulmonary artery shunt, and was another of the shunts which supplemented the Blalock-Taussig shunt. But interestingly here again, although Glenn is the name that we commonly call this operation, it was actually first described by a Russian surgeon in 1956. Meshelkin was the surgeon who described the cavopulmonary shunt. But unfortunately, since the literature that he published was in the Russian language, it never came to international notice, and Glenn gets the credit for the cavopulmonary shunt. And then we went on to an era where intracardiac surgery for intracardiac lesions was attempted, but the heart-lung machine hadn't been developed then. And so there were various ingenious techniques to try and get into the heart while the heart was still beating and try and repair simple defects like atrial septal defects. So 1952, Gross described an inkwell technique where he sutured a rubber cone to the right atrial wall, then made a cut into the right atrium. The blood actually welled into that cone without air getting sucked in. And then through that, blindly, instruments were passed through the cone and atrial septal defect was closed. So this was called the Gross inkwell technique. Unfortunately, because most of the suturing was blind, it certainly was not a very effective procedure. At that time, a lot of work was being done with hypothermia. In dogs, it had been observed that the maximum limit for stopping the circulation was about 3 minutes before brain damage occurred. And that certainly was not enough for any intracardiac procedure to be done. It was observed at that time that if one lowered the body temperature, then one could prolong this period of ischemia for longer, at least up to 10 minutes, which was sufficient to close a simple defect like an atrial septal defect. So 1952, Lewis and Tawfik described the first ASD closure using mild hypothermia and inflow occlusion. And in subsequent years, they did a series of patients with a 10% mortality. But then again, the quest for developing a pump oxygenator which could support the circulation while intracardiac repairs could be done was on. And it was only in May 6, 1953, that Gibbon performed the first successful closure of an atrial septal defect using a pump oxygenator. So this was yet another landmark event in the history of congenital heart surgery. At the same time, Lillehei, working at the University of Minnesota, developed an ingenious technique called controlled cross circulation. And by 1955, he had published a series of patients in which he had repaired a wide variety of congenital heart defects using this unique method of cardiopulmonary bypass. In the 50s and 60s, then subsequently, there was a rapid development of pump oxygenator technology. As new knowledge came in that was implemented into the refinement of these pump oxygenators, and the concept of cardiopulmonary bypass evolved. The name of cardiopulmonary bypass was actually given by Denton Cooley to this system of conducting open heart surgery. And then became a phase of development of oxygenators, which were initially reusable, but then moved on to the development of disposable oxygenators, bubble oxygenators, and then membrane oxygenators, and then oxygenators for long-term mechanical support. And that led to the development of extracorporeal membrane oxygenation for the long-term support of the circulation. But this is just a glimpse to see how challenging the initial attempts at performing intracardiac surgery using those antique heart-lung machines. And there were various surgeons working in various parts of the world on trying to develop a heart-lung machine. But you can see the results here, that between 1952 and 1954, these 6 surgeons had made about 18 attempts at performing intracardiac surgery using a pump oxygenator. And of all those, there was only one success, and that was that of Gibbon. The only patient out of the 6 that he operated, there was only one who survived. And this history registers that this was such a disappointment to him that he thought that this system would never work. And actually, he gave up developing the pump oxygenator and then went the other way and formed a society which actually discouraged further development of the heart-lung machine. Such were the challenges of cardiac surgery those days. And this is a picture of Dr. John Gibbon with his pump oxygenator. You can see how big the machine was. This is somewhat reminiscent of the computers of the early era. But then this was the beginning of cardiac surgery. And it was thanks to people like Gibbon that today we are able to do what we are able to do today. So this is to show the contribution of Dr. Walton Lillehei. And this drawing shows how the controlled cross circulation was effective. The infant being of a small size and requiring a much lower cardiac output, one of the parents was chosen to be the donor for the pump oxygenator system. The femoral artery and the femoral vein of the parent were cannulated, and then through tubings, which ran through a sigma pump, were connected to the child's aorta and the right atrium. And with that, part of the parent's oxygenated blood was driven to the child while the heart was stopped and the intracardiac procedure performed. And he uses to repair many types of heart defects, including tetralogy fallow, pulmonary atresia, atrioventricular septal defects, ASDs and VSDs, etc. And this was remarkable for those days because this was the first time that many such defects were actually repaired. But the problem was that here was a situation which potentially could result in what they call as a 200% mortality. Because for the sake of trying to save one individual, there was a potential that two individuals might die in the process. And therefore, it never really took off because work on developing pump oxygenator was continuing. And it actually, interestingly, continued very nearby, just 90 miles across at the University of Rochester and Mayo Clinic, where Kirkland was working on his own oxygenator. Subsequently, Dr. Richard Duvall came up with the concept of the bubble oxygenator. And so the development of open heart surgery continued. Interestingly, in the initial years, the entire open heart surgery in the whole world was being done in two centers, which were just 90 miles across. Dr. Walton Lillehei and his group at the University of Minnesota, and Dr. John Kirkland at 90 miles across at his own center there at Mayo Clinic. So now we go on to the historical developments of some of the common congenital heart defects. It's difficult to really cover all the historical developments of each individual defect, but I'll just go through the important landmark developments in each of these congenital heart defects. So let's start with the atrial septal defect. In the late 1940s, there were attempts at external closure. That means blind suturing of the atrial septal defect going across between the two atrial chambers and trying to close the atrial septal defect from outside. So there was Murray's external suturing, Bailey's atrioseptopexy, Sondergaard's pursing suture, etc. Then, as I mentioned, in 1953, Lewis and Tofik described the first successful closure using hypothermia and inflow occlusion. 1953, Gibbon did the first successful closure using pump oxygenator. Subsequently, of course, with the development of more refined pump oxygenator systems, ASD closure became a fairly standard surgical procedure. Till 1974, when King and Mills described the first percutaneous closure with an occlusion device. And of course, that now has been refined many times over. And so now the vast majority of atrial septal defects are closed today, not surgically, but by the cardiologist in the cath lab using an occluder device. Ventricular septal defects were initially palliated, as I mentioned. The initial description of PA banding by Muller and Daumann in 1952. It was in 1954 that Lillehei and Warko did the first successful closure with direct vision using controlled cross circulation. In 1956, Kirkland and Duchenne described the first series of closures using a mechanical pump oxygenator. In 1957, Lillehei described the right atrial approach for closure of the ventricular septal defect. Prior to that, most of the closures were done through the right ventricle. And in 1969, Okamoto from Japan and Barrett Boyce from New Zealand described the use of deep hypothermia and circulatory arrest for closure and demonstrated the superiority of primary closure in infancy over a two-stage procedure, which included a pulmonary artery banding followed by VSD closure. And then in 1988, Locke et al. From Boston Children's Hospital described the transcatheter device closure of ventricular septal defect. Coming on to atrioventricular septal defect, here again it was Lillehei, who in 1955 described the first successful repair using direct closure using controlled cross circulation. In 1962, Maloney et al. And Garbode repaired the atrioventricular septal defect with a single patch with resuspension of the atrioventricular valve leaflets. This was called the body for the single patch technique of repair of AVSD. In 1975, Trussler et al. Described the two-patch technique, where the VSD was closed with a separate patch and the atrial septal defect with a separate patch. And this is still one of the commonest techniques used for the repair of AVSD. And in 1999, Graham Nunn from Sydney described the modified single patch technique for the repair of atrioventricular septal defects. Coming on to total anomalous pulmonary venous connection. First described in 1951, where a partial repair by a closed method, anastomosing the common vein to the left atrial appendage, was described. This did not allow for closure of the atrial septal defect within the heart. In 1956, Lewis and Warko again, using hypothermia and inflow occlusion, described the first total repair of total anomalous pulmonary venous connection. In 1956, again, Burroughs and Kirkland described the first total repair of TAPVC using cardiopulmonary bypass. In 1967, Dillard described the repair in infancy using surface cooling and circulatory arrest. And in 1971, Barrett Boyce et al. Described repair in neonates and infants using surface cooling and limited cardiopulmonary bypass. A lot of the surgical procedures in those days, you could remember, were performed using various degrees of hypothermia. The hypothermia could either be surface induced, which means by using cold packs and ice around the body, or using cardiopulmonary bypass to cool the patient. Tetralogy of Fallot has a long history with multiple landmark developments in between. As I discussed earlier, in 1945, Blalock-Taussig was the first successful palliation with a subclavian artery to pulmonary artery shunt, first description. 1948, Sellers and Brock, palliation by the closed pulmonary valvotomy. In 1954, Lillehei described the first successful repair without prosthetic material using controlled cross circulation. In 1955, Kirkland et al. The first successful closure using pump oxygenator. 1957, Warden and Lillehei described patch enlargement of the right ventricular infundibulum. Before that, the right ventriculotomy was closed directly. In 1963, Hudspeth et al. Described the transatrial approach for the repair of tetralogy of Fallot. In 1966, Ross and Somerville described the right ventricle to pulmonary artery extracardiac homograph conduit for tetralogy of pulmonary atresia. And in 1969, Sir Brian Barrett Boyce et al. From New Zealand described primary repair in infancy using deep hypothermia and circulatory arrest. Coming on to transposition of great arteries. In 1950, as I mentioned, Blalock and Hanlon described the closed atrial septectomy for palliation. In 1953, Lillehan, Barco, and Baffes described a partial repair of the transposition by using a partial atrial switch, also known as the Baffes procedure. In 1966, Rashkind and Miller developed the balloon atrial septostomy, which became a lifesaver for many, many neonates born with transposition of great arteries and intact ventricular septum. In 1959, Senning described the first successful atrial switch operation. 1963, Mustard described the atrial switch operation using an intra-atrial pericardial baffle. In 1969, Rastelli from the Mayo Clinic described repair of transposition with ventricular septal defect and pulmonary stenosis using an extracardiac conduit. 1975, Jatini from South America described the first successful arterial switch operation in transposition with ventricular septal defect. In 1977, Yakub described a two-stage arterial switch for transposition with intact ventricular septum. At the Boston Children's, Casneda in 1984, and Radley Smith and Yakub, Krogabor, etc., described the pulmonary arterial switch in the neonatal period. And in 1989, Jonas, again from Boston Children, described the rapid two-stage arterial switch operation for transposition with intact ventricular septum, presenting late with a regressed left ventricle.
So going on to single ventricle, it was in 1971 that Fontan and Baudet described the right heart bypass for tricuspid atresia for the first time. And this subsequently became known as the Fontan procedure. However, simultaneously, in South America, Krautzer working on his own described the atriopulmonary connection for tricuspid atresia. So most people now like to call it the Fontan-Krautzer procedure for single ventricle. Initially, the procedure was described for tricuspid atresia, but subsequently in 1987, Puga et al. Described the utilization of this procedure for many other forms of single ventricle. In 1988, Marc Delaval from London modified the technique to reduce the complications of the direct right atrial to pulmonary artery anastomosis by describing what he called the lateral tunnel Fontan. And this became known as the total cavo-pulmonary connection. In 1990, Marcelletti from Italy modified this again in the form of the extracardiac Fontan, which utilized a straight conduit interposed between the inferior vena cava and the right pulmonary artery. Working in Boston, Nancy Bridges et al. In 1990 described the use of fenestration of the lateral tunnel in order to reduce the complications of the Fontan procedure. And in 1993, Norwood and Jacobs, again from the Boston Children's Hospital, described the two-stage Fontan, where the first stage consists of a bidirectional cavo-pulmonary shunt, and the second stage converted into a complete Fontan circulation once the IVC was connected to the pulmonary artery. Notable in the management of single ventricle, especially the hypoplastic left heart syndrome, was the description in 1985 by Leonard Bailey, who performed the first neonatal heart transplantation at the Loma Linda University in the United States. And this was again a landmark event because subsequently it remains one of the most successful procedures for the hypoplastic left heart syndrome. Although the numbers are less because of the availability of donors, however, Leonard Bailey's contribution to the treatment of hypoplastic left heart syndrome remains notable. Coming to landmarks of congenital heart surgery in India, I have just lifted some of the important landmarks. The first PDA ligation was performed by Dr. B.R. Billimoria at Masino Hospital in Bombay, probably in 1950. Exact date is not documented well. The pot shunt for tetralogy FLO was performed by Dr. Rebetz in Vellore in 1951. Dr. Rebetz was one of the pioneer thoracic surgeons in India, and he worked at the Christian Medical College, Vellore. He also performed the first pulmonary valvotomy using inflow occlusion in 1953. The first coarctation repair was described by Dr. P.K. Sen from Bombay, another cardiac surgical stalwart. And he also described the first ASD closure under hypothermia in 1956. Aortic valvotomy under hypothermia was described by Dr. A.K. Basu from Calcutta in 1959. And the first ASD closure using a heart-lung machine was done by K.N. Dastur in Bombay on 16th February 1961. That same year, in May 1961, Dr. Gopinath at the CMC Vellore did the first VSD closure using a heart-lung machine. The first tetralogy FLO repair was described by Dr. Padhi from Wanless Hospital in Meerut in 1963. The first Senning procedure in India was performed by Dr. K.M. Cherian in Chennai in 1979. And he also performed the first arterial switch for transposition and ventricular septal defect. The first double switch operation in India was performed by myself in 1983 at the All India Institute of Medical Sciences in Delhi. So these were some of the important first operations in India. A couple of interesting slides which I borrowed from Dr. Tom Carl. And he, in one of his presentations, had listed that if you were actually to compress the entire development of cardiac surgery to one day, then these were the various time frames at which most of the development would have taken place. As you can see from the original description of a heart defect by Gallen, to the time that the first open heart surgery took place, it was about 10 hours, 10 to 11 hours. And the entire subsequent development of cardiac surgery to where it stands today took the subsequent 12 hours. So you can see the interesting timeline of the development of cardiac surgery, that a substantial development has taken place in the last few decades. But however, most of this development has or stands on the shoulders of the initial pioneering surgeons who were daring enough to perform surgeries with very, very limited resources. And then again, this was a questionnaire that he sent out to 100 surgeons, asking them what they considered as the most important landmark events in the history of the development of congenital heart surgery. And the responses are tabulated according to the number of surgeons who gave the particular response. So you can see that these were the interesting collection of so-called landmark events which surgeons felt were the most important in the development of congenital heart surgery. And not surprisingly, CPB technology got the maximum number of people responding to. The Blalock thoracic shunt stood second, the development of prostaglandin third, the arterial switch operation fourth, the atrial switch operation for transposition fifth, cardioplegia sixth, echocardiography, then the Fontan-Kreutzer operation, then some conceptual items like database concept, Pioneers, Courage and Vision, the Norwood operation, etc., etc. So you could see that these were some of the game-changing events in congenital heart surgery. And this has been a continuum over the last few decades, allowing us to do what we are able to do today. So with that, I will conclude my presentation. And I'd like to thank you for your patience and participation. Thank you very much.
Thank you, sir.
So that was a broad overview. I understand that it doesn't cover the entire history, But for students, it would be very, very exciting if you read several of the novels that have come out based on the lives and biographies of these great pioneers. For example, there's a book called King of Hearts, which is a biographical book on Walton Lillihei. There's another book on Dr. Cooley, which is called 100,000 Hearts. There are other books which describe the great and historic life of Denton Cooley and his mentor. There's a book called Walk on Water, which is a biography of Dr. Roger Mee. So there are very many of these books which give a very interesting twist to the history of congenital heart surgery and written in a very interesting way, which can be really quite inspiring. Some of the slides which I have shown on the individual procedures were taken from the chapter on history of congenital heart surgery, which I've written for the textbook of history of cardiac surgery. And I will put that PDF version on the IACTS website so that the students can have a look at it in a little more detail. And now I'm open to questions from the students.
We'll have the tea break later. We'll just start with Dr. Sampath Kumar's talk. Over to Dr. Sampath Kumar, please. We'll be talking on evolution of valvular bioprocesses.
Good morning, everybody. I'm very happy to be here at the IACTS SCORE. I've been attending this physically last couple of times that they did it, but this time because of this pandemic, we are doing it virtually. I'm still glad to be on this panel, and thanks to IACTS to include me in this faculty. My lecture has already been recorded and we can start with it. I will wait until the presentation is over and then we'll talk about, take on any questions.
Sure.
Good morning, everybody. It's such a privilege to be back with the IACTS SCORE. I think this is the first time that we are doing it virtually. I hope you can see and hear me clearly. The topic I'm going to be talking to you today is evolution of bioprostheses. The reason of choosing this particular topic is that bioprosthesis is not very commonly used in India. The nomenclature came from Eki Senning. He's from Karolinska Institute in Stockholm, Sweden, and he coined the term. Bio means that you are using a biological tissue. Prosthesis is the framework on which this biological tissue is mounted. That's the picture of Eki Senning. He's from Karolinska Institute in Stockholm, Sweden. Now, why do we need a bioprosthesis? In 1953, Hufnagel introduced a prosthetic valve that could be implanted in the descending thoracic aorta of patients who had aortic regurgitation. It was very successful. It was done without cardiopulmonary bypass, and it was done without sutures, which is fantastic. We are now coming back to the same thing again. Subsequently, Albert Starr, Nina Braunwald, and some others designed and produced a mechanical valve made of metal and cloth. Cloth for sewing rim and metal. Unfortunately, these bioprostheses made a lot of noise, created a lot of complications from thromboembolism, thrombosis, stuck valve, either the disc or the ball, and created a lot of problems for the patients. And they started changing these mechanical valves, seeing the complications. So in the meantime, there were other pioneers who decided that mechanical valve is not an ideal prosthesis for replacement of diseased valves. So they thought of bioprosthesis. As I said, Eki Sining was the first who coined the term and who also took part in developing bioprosthesis. But why do we need bioprosthesis? We need bioprosthesis because there is a need to avoid anticoagulation for life. Bioprosthesis, because of the biological tissue, does not require oral anticoagulation for life. Secondly, we need to reduce or avoid thromboembolic complications, which are very common both with the ball and cage valves as well as the disc valves. Patients were getting annoyed from the noise of the mechanical valves, and they would be very, very upset if they didn't hear the noise, or their partners would be very upset because they are hearing the noise of their heart. The noise could be heard even about a meter away, especially with the ball and cage valve. So it was very annoying, and it produced psychological problems for patients. So one of the reasons why bioprostheses were invented or discovered and made was to avoid this noise. The other more important part was to get better hemodynamics. They wanted a central flow of blood, which could provide laminated flow or laminar flow from the left ventricle into the aorta or from the left atrium into the left ventricle in both positions. So they wanted a laminar flow and better hemodynamics with less gradients and not so much turbulence. And so the bioprosthesis was begun to be used. What were the tissues that were used for bioprosthesis? The pericardium was the most common, and people use bovine pericardium as well as equine or horse pericardium. Now, pericardium is a very versatile tissue, and autologous pericardium was also used, but it was not used as a prosthesis. It was used as a freehand sewing cusp. Carlos Duran from Spain first used this pericardium in a 3-cusp format so that they could repair the valves rather than replace it. But he developed a technique by which you could replace the aortic valve with 3 cusps made of autologous pericardium. Even this autologous pericardium was not fresh pericardium, but it was treated with glutaraldehyde. So also the bovine and the equine pericardium, the need for using other animal pericardium was that a large quantity, larger size of pericardium was available to make more valves, and the fact that it had much better handling quality. That means it stayed quite soft as well as mobile, and it was easy to stitch. So they chose the bovine pericardium, and some also used the equine pericardium or the horse pericardium. Apart from pericardium, valves themselves, complete valves, were used. Now we used porcine valves. The first Hancock valves as well as the Carpentier valves were made of porcine valves. Now the porcine aortic valve has a peculiar anatomical feature that makes it difficult to use the entire porcine valve because there is a shelf of muscle just under one of the cusps, which causes an obstruction in the outflow wherever it is used. So in order to mitigate this problem, they needed 2 porcine valves to produce 1 bioprosthesis. That means they took 1 cusp which did not have the muscular shelf. And so they could take 2 cusps from 1 valve which had no muscular shelf and one cusp from another valve. So similarly, they could produce two bioprostheses from 3 porcine valves, discarding the cusp that had a muscular shelf underneath. So to overcome this, the homograft was also used. That is, antibiotic preserved homografts of from humans who had donated their hearts. Now, it is difficult to imagine how a homograft would be used in the mitral position. In the aortic position, it was quite common to use a homograft, and these were not stented. Both Donor Ross and Sir Brian Barrett Boyce began using the homograft, and I will come to that a little later. Others, like Zabini in Sao Paulo in Brazil, started using the dura mater, human dura mater, which was harvested at autopsy, and it was treated with glycerin, 10% glycerin, in order to make it non-antigenic. And it was, although it was autologous, it required to be preserved in some chemical in order to make it usable. Then they use fascia lata. Fascia lata is a wonderful tissue. It is autologous again. It did not require any treatment with a chemical, but the problem about fascia lata was durability. So you're going to see the chronology of use of these tissues. Ionescu in 1960, along with A.K. Senning and Donor Ross, used both pericardium, bovine pericardium, as well as fascia lata to configure these bioprostheses. It was very important to see these bioprostheses mounted on a frame. And the frame had to be made earlier and sterilized, and surgeons had to stitch these valves in the operating room, or like the Ionescu Shiley valves. The Shiley company took over the design of the porcine valve, which was used by Ionescu. And so they could implant the valve directly, and it was available off the shelf. But the homograft and the fascia lata valves had to be stitched in the operating room on a frame. Donald Ross from England and Sir Brian Barrett Boyce from Auckland in New Zealand used the homograft in 1960. It is all for the same reason, as I mentioned earlier in the presentation. The idea was to use a tissue that would last long, use a tissue that was autologous or homologous, and use a tissue that did not require chemical treatment. So the homograft was used in the aortic position in the scallop subcoronary technique, which is unstented bioprosthesis or stentless bioprosthesis. Whereas in the mitral position, they had to use a stent and stitch the homograft to the stent and implant it in the mitral position. In the All India Institute, we implanted a few of these, and also in the KEM hospital in Bombay, a large number of these antibiotic preserved homografts mounted on a frame were used for mitral valve replacement in the early 1970s. Although Ross and Brian Barrett Boyce began this procedure in 1960, they found that over the years, the bioprosthesis degenerated. Alain Carpentier from Paris in France began using the porcine valve. The entire porcine valve, as I explained earlier, was mounted on a frame and was implanted in the mitral as well as in the aortic position. So this was a stented porcine valve in 1970. Subsequently, they shifted to the pericardium, bovine pericardium, and this was made in 1980 and underwent several additional changes to make it more long-lasting. Here's a picture of Ionescu. He's the first one to have published his results with the bovine pericardium stented valves, both for aortic and mitral positions. This was made by Shiley Laboratories, and it was available off the shelf in different sizes. So this was the first commercially available bioprosthesis which came into use in 1960. Ionescu also, along with Donor Ross and Eki Senning, used the fascia lata to fashion a similar stent-mounted valve that was made in the operating room, and it was made just before the patient was put on cardiopulmonary bypass. And it was designed in order to make a competent valve. Unfortunately, the bioprosthesis made from fascia lata was not very durable, so they had to give it up. But the bovine pericardial bioprosthesis, which was introduced by Ionescu in 1960, was very successful. But again, bioprostheses have a limited durability. There are other pioneers. I am sure many of you and almost all of you should have heard or seen Donald Ross from England, from London. He's the one who devised the Ross procedure, and he's also the pioneer in using the aortic homograft, both as a stentless bioprosthesis for the aortic position and a stented bioprosthesis for the mitral position. Then came Sir Brian Barrett-Boyce from Auckland in New Zealand. Fortunately for our country, Sir Brian has trained a large number of cardiac surgeons from India. That is the fortunate part of it. The unfortunate part of it is many of them who came back never used the technique of using the homograft either for aortic valve replacement or for mitral valve replacement, which was unfortunately the lacking on our part. Sir Brian Barrett-Boyce himself, when he visited the country, was very clear in his mind and also suggested that the homograft valve was very suitable for Indian conditions and for the rheumatic heart disease patients in India who were very young. The important thing was that this valve could last for maybe 10 to 15 years, but had to be changed again. So this was one of the things that prompted and promoted bioprosthesis use in our country. And of course, Professor Alain Carpentier, a very good friend of mine from Paris, he introduced the porcine bioprosthesis, which is a stent-mounted bioprosthesis, way back in 1970. Now the thing is, the difference in the bioprosthesis before and the bioprosthesis afterwards is the chemical treatment. Professor Carpentier used formaldehyde for a while, but he found that the formaldehyde was very toxic to the tissues. Although it did the cross-linking and it was good enough for making the tissue suitable for stitching and suitable for function, it did not last long. So they changed from formaldehyde to glutaraldehyde. Now, glutaraldehyde was introduced in 1976 for a totally different purpose. It was meant for sterilization. It was also meant for stabilization of tissue, and it was also meant for preservation of tissue. All of these three functions of glutaraldehyde was very, very useful for making bioprosthesis. We did not use glutaraldehyde in bioprosthesis because the homografts are preserved in antibiotic solution, and they are wonderful, and they have very good handling characteristics. whereas the porcine valve as well as the pericardial valve needed to be preserved in glutaraldehyde. Now, what kind of treatment was required for these tissues? The treatment that was required for these tissues was necessary for three particular conditions. One, it had to become immuno-incompetent. That means it should not produce an immunologic reaction once it is implanted in the patient. Because this is from an alien animal tissue, it would definitely produce a reaction, an immunologic reaction, and to avoid that immunologic reaction, you had to have chemical treatment. But that was not required for homografts, as I have mentioned. Now, there were many processes that were tried. They first tried freeze-dried valves. Freeze-dried valves had a serious problem because when you thaw the valve, many of them developed cracks. And so the discard rate of these valves was very high. And so it was not possible to maintain an economical production of these bioprostheses with freeze-dried valves. Radiation was used for sterilization, but radiation also destroyed the tissue characteristic. So much so that the radiated valves did not last for more than 4 or 5 years, and that was not satisfactory at all. Then they used formaldehyde. Formaldehyde was very toxic, but it did produce and did preserve the tissue so that it was possible to make these valves. But formaldehyde also produced a very serious complication after it was implanted of calcification of the tissues that was used for mounting and making these bioprostheses. So it was given up after some time. Then we, as I mentioned earlier, Zabini in Sao Paulo in Brazil used glycerin, 10% glycerin, to preserve the human dura mater and even alien dura mater to make these valves. He had extremely good results for 8 to 10 years after the implantation. Therefore, it became very apparent that all the bioprostheses until then were not satisfactory as far as long-term survival, both of the prostheses and also of the patient, because once they degenerated, they produced thromboembolic complications, stenosis, regurgitation, and complete congestive heart failure in these patients. So then came the introduction of glutaraldehyde in 1976. Glutaraldehyde was not formally introduced into bioprosthesis or into medical use. It was only meant for leather industry, where they used it for converting skin into leather and preserve it in that status so that it would be useful functionally. Glutaraldehyde was also a good chemical for sterilization of tissues and for preservation of tissues for long term. That means once you have tanned the tissue, once you have tanned the skin and other tissues, you could preserve it in glutaraldehyde for a long period of time. But then glutaraldehyde was very toxic, so we did not use a very high concentration. It was only 0.625%, which was found to be ideal. It was not too toxic and it could be washed off easily. So 0.625% glutaraldehyde, which is now currently commonly used in most bioprostheses. So that is how glutaraldehyde got introduced into bioprosthesis making. You have now heard about the tissues. Now this is about stents. Stents were of different types. Rigid stents, which were made of alloys, especially the alloy, which is stainless steel, copper, and one other metal. or the titanium stent, or the stainless steel stent. Now, all of these were very rigid. And as you can understand, in the normal internal milieu of the heart, the flow of blood requires that there is a pulsatile flow of blood. Because of that, these rigid stents caused a problem of obstruction, turbulence, and increased incidence of thromboembolic complications because of rigidity. Also, the rigidity caused inflexible cusps. And over a time, the likelihood of degeneration of the tissue was higher with the rigid stents. So we needed to have a different kind of stents. And then came the flexible stents. This is an algiloy wire form stent, which was quite commonly used in those days. And this is an acetyl stent. And stents were made from Teflon, and they were flexible. And the polymer that was used was Teflon or Delrin. Either of these polymers were used to make a stent. And it was important that the stent's posts had to be short and had to be properly designed. So once the design was made, a huge number of stents were produced, and they were shipped to many hospitals. And like I said, we used to use a human aortic valve, and it would be sutured in the operating room to these stents to make a valve, and it could be immediately implanted into the patient. It came in different sizes, suitable for both aortic as well as mitral valve replacement. But it took time to produce a valve in the operating room. Also, these stents were used in commercially available stented bioprosthesis, particularly the Carpentier-Edwards valve, as well as the Ionis-Kushayli valve. Now, these were either porcine valves or bovine pericardial valves. So therefore, these flexible stents offered a better hemodynamics and did not produce the problem of obstruction or thromboembolic complications. Now, Robert W.M. Freita from New York is one of the pioneers in this particular area of bioprosthesis, and he made a valve with bovine, with equine pericardium, that is horse pericardium. It was called the Quattro valve, and that principle was later used in producing the currently available, commercially available valve, which of course did not come anywhere close to the pericardial valves or the bovine pericardial valves of Carpentier or of other companies, or the Hancock porcine valves. But Robert Freita was one of the pioneers in producing bioprosthesis. Then came Carlos Duran. Carlos Duran also used the fascia lata as well as the autologous pericardium to fashion a valve, but it had to be done on the table, and it had to be cured with glutaraldehyde in order to be able to suture it. It was only suitable for the aortic valve, and he produced a large series of valves that were implanted and a good outcome in these patients. Subsequently, he moved to Saudi Arabia in Riyadh and established a wonderful valve surgery program there and trained a number of people who could use the autologous pericardium to fashion an aortic valve. I learned the technique from him when he visited India, and subsequently obtained the necessary molds from him and the sizes from him, and performed these operations in All India Institute. Tyrone David, he's from Toronto in Canada, and he's another pioneer who introduced the porcine valve. it was a stentless valve. The important thing, as I said, was that the porcine valve had one cusp that was being obstructed by a shelf of muscle, and so that had to be replaced by a separate cusp. So the St. Jude company took over the design from him and produced the Toronto SPV, stentless porcine valve, for use and as a bioprosthesis. It was extremely good. It was easy to handle. It was very good for implantation, and it was easy for implantation in the aortic position. There was no Toronto SPV valve that was suitable for the mitral position. So it was difficult for using this particular bioprosthesis in the mitral position, and it was not suitable for that. Then came several other stented bioprostheses, which I mentioned earlier. Ionescu-Shiley was the first one, and the Carpentier-Edwards valve. The Carpentier-Edwards valve was both porcine as well as pericardial. Now, the pericardial valve has undergone many modifications. I will come to that in a few minutes. Then came the St. Jude EPIC. The idea of the EPIC valve was that the tissue, which is pericardium, bovine pericardium, was not to be mounted inside the frame. It was to be mounted inside the frame, also covering the frame, so that it was wrapped around in the frame. So the idea was that the pericardium afforded a blood-friendly surface and did not produce thromboembolic complications. The company claims that it has the best hemodynamics, but we'll see about that. Now, this is the Ionescu-Shiley valve, which was introduced in 1960. As you can see, there is a frame which is used for mounting, and this is the aortic valve, which requires that the aorta, the internal surface of the aorta, will make the sinus portion and the aortic valve cusps, and they will have sufficient space for full excursion and opening of the valve. That was the idea with which this particular valve was designed. Now, this became very big, and as you can see, they were all obstructing both the aortic outflow tract because of the frame, like here, this portion. Now, this is the stent, and this from here to here is what actually allows the blood flow to go. So almost at 2 to 3 millimeters on either side or circumferentially was causing an obstruction to the left ventricular outflow tract in all the prostheses and bioprostheses. It is not confined to it is confined to these stent-mounted bioprostheses, but not to the unstented or stentless bioprostheses, like the homograft or the Ross procedure or the Toronto SPV. The reason why Tyrone David developed this valve was because of the hemodynamics in the stent-mounted valves that cause obstruction to the left ventricular outflow tract. This is the Carpentier-Edwards porcine stented aortic valve. Now again, as you can see, the stent is much larger. There are 3 posts, and all 3 posts are fairly wide. And it is important that when you implant it, you should not obstruct the coronary ostium. That is one of the problems with the implantation of bioprosthesis that has made it unpopular. Now, the stentless bioprosthesis were the Toronto stentless porcine valve, the Quattro valve, which, as I mentioned, Robert W.M. Freita was also interested in doing this. Now, an Indian surgeon called Barua produced a porcine bioprosthesis. Unfortunately, it was done with very clandestine, illegal methods, and it fell into disrepute almost immediately after it was implanted and was not produced commercially at all. Now, this is the St. Jude Toronto SPV, which is stentless. Now, what you are seeing here is a piece of cloth that is stitched in order to make the prosthesis implantable. The entire thing is flexible and it does not obstruct like the other stented bioprosthesis in the aortic position. It is not suitable for the mitral position. Here is the 3F ATS valve. Now this is peculiar because this is a stentless bioprosthesis. It is made from equine pericardium, that is horse pericardium, and it has 3 pores. The manufacturers claim that it is easy to implant. You need to do a proximal suture line on the aortic annulus and hook up the 3 commissural posts with a suture into the aortic valve, inside the aorta, at the top of the commissular pillars of the native valve. So this obviously does not produce any coronary obstruction, and it allows free flow of blood into the coronaries, but it also provides some of the best hemodynamic results. Unfortunately, the tissue and the manufacturing process was not suitable for long-term survival of this valve. So it was finally almost completely abandoned. It has not been used. Here, the Medtronic Hancock valve. Now, the peculiar thing about this Hancock valve is it's extremely durable compared to the other bioprostheses. I've used this valve. It is very good, and it does produce excellent hemodynamics. And like I said, this is produced from 2 porcine valves, aortic valves. And it can be used both for the aortic as well as the mitral position. And it provides very good hemodynamics and fairly large orifice area after implantation. Effective orifice area with this valve is reasonably good. And therefore, this valve has been successful. And it's called the Hancock 2 because they made some modifications with the stents as well as the use of the 3rd cusp from the bovine, from the porcine aortic valve. This is also called the Medtronic Freestyle. This is a stentless valve, and this is also a porcine valve. And here they have modified it by taking away the muscular shelf from underneath the porcine valve. As you can see, here, this is the portion where there is a cloth. There is a Teflon cloth sutured to produce a sinus. And this is the cusp inside. So this is where the muscle was, and that had to be changed. And this is very good. And this is also used for right ventricle outflow tract reconstruction. And many surgeons like to use this for the Ross procedure, but I don't like it because that doesn't make it the Ross procedure. It makes it a modified Ross procedure. Here is the Edwards Prima Plus. This looks somewhat like the Toronto SPV valve, and it is also a porcine valve, and it is taken from the pig valve and aorta. The idea is that you can replace the proximal aorta also with this, and it gives rise to 2 separate coronary ostia, which can be used for connecting the coronary ostia to this particular prosthesis. It is not very commonly used, and it is not, although it is commercially available, it is not very popular among surgeons. Now here's the Soaring Microflow. Now Soaring Microflow, like the Quattro valve or the St. Jude Epic valve, is one in which the pericardium is wrapped around the stent. Now you don't see the stent because the pericardium is on the outside. The pericardium is shaped in this manner. It is cured in glutaraldehyde and then sutured in such a way that it covers the stent posts from the outside. The idea, of course, was that from the inside of the aortic wall, the endocardium will grow over this portion and make it blood friendly and reduce the complication of thromboembolism or the complication of thrombus on the suture lines. But it needed a number of years to assess this valve, because although it produced good hemodynamics, the stent, which was inside, was the problem in these patients in whom this was implanted. Then we come to the St. Jude epic. As you can see, this is the epic valve in which the pericardium is sutured on the outside of the stent here. This is outside the stent. As you can see, the pericardium covers the outside and also forms the three cusps. And this is a bovine pericardial tissue. The company claims that it has the lowest gradients, but I'm not sure, because it depends on the size of the valve that is implanted. And like all other bioprostheses, there is a portion. Now take from here to here is what actually is in the left ventricular outflow tract. So this portion, about 2 to 3 millimeters in diameter, occupying the inside of the aorta, does produce an obstruction and does produce certain complications like hemolysis, thromboembolic complications, etc., like all other bioprostheses. It is not exempt from that. But because of the way it is mounted inside the frame, it has least gradients when implanted. So this valve is supposed to be hemodynamically better than the other valves. But I do not have much experience with this, but the experience that is published in the articles in journals does not suggest that this is any better in terms of durability or thromboembolic complications or of degeneration in the long term compared to other bioprostheses. Yes, maybe there is a slight decrease, not so significant in the gradients that they have measured in this particular valve for size to size. Now the Carpentier-Edwards Perimount valve came. Now the Perimount valve is very, very nice. In fact, it's one of the most hemodynamically most successful valves. Unfortunately, the problem is about the size of the stent and the suture cusp. Now I have seen that this, you can implant a one size bigger perimount valve, both in the mitral and in the aortic position, compared to other bioprostheses, especially the Hancock prosthesis. But the important thing is that this design of the stent is very narrow. It is not broad. So in the aortic position, it does not create any problem with coronary obstruction when it is properly placed. And it also has much better hemodynamics, and it has a much larger orifice area. Again, this is the area which provides the flow. And compared to other valves, this may be a little less because this entire sewing cuff is very flexible. Then came the Carpentier-Edwards Magna Ease. The Magna Ease is also similar to the Carpentier-Edwards Perimount valve, except that the stent post, as well as the cuff, sewing cuff, have been designed differently. Now the sewing cuff has a curve, has a curvature, which is both suitable for the aortic as well as the mitral position. Also the stent is much narrower compared to the Edwards Perimount or the Hancock 2 valves. And so it is easier to locate this valve inside the aorta or in the mitral position. Now, these are the pioneers in production of bioprosthesis, those who thought of it, those who designed it, and those who made it. And these are all successful bioprosthesis producers. Ionescu used the bovine pericardium way back in 1970. Ross and Barrett Boyce used the homograft as well as the stent-mounted homografts for the mitral position. Carpentier used the porcine valve, stent-mounted porcine valve, as well as the bovine pericardium to produce a bioprosthesis. And it underwent many modifications, especially in the design of the stent, and also to produce a thermal treatment, which made the cusps of this valve much easier to handle and much longer lasting and avoided calcification. It also underwent some treatment for anti-calcification. So the currently available Carpentier Perimount bioprosthesis, the bovine pericardial bioprosthesis, especially the Carpentier Edwards valve, is very expensive, but is one of the best in terms of long-term survival as well as long-term function without degeneration. Perhaps this particular valve may last between 12 to 15 years in patients who are 65 and above. But if you start using this in patients who are 50 because they demand it or because it is a requirement in those patients, then you may not find such long survival of any of the bioprostheses. Duran used the autologous pericardium to use to make the aortic freestyle aortic valve. W.M. Prater used the equine pericardium to produce the quattro valve, which was produced in Brazil, and quite a number of those valves were used and implanted and reported. But again, the long-term follow-up of these patients showed that the degeneration was quite common. Zerbini's Dura-Meta valves was useful and was reported only by him. Very few others use this technique to produce bioprosthesis or to use them clinically. This was, of course, approved by the FDA, but unfortunately, it was not very popular among doctors who were implanting bioprostheses, and it remained mostly very common in the underdeveloped countries. Senning used, as I said, used both the fascia lata and the porcine valve to produce a bioprosthesis, a stented bioprosthesis, and that was the beginning of the bioprosthesis. He also coined the term bioprosthesis. David produced a stentless bioprosthesis, but it became useful only for the aortic position, and there was no one for the mitral position. And that's a picture of Zerbini. He's a pioneer in producing the Dura-Meta bioprosthesis in Brazil. Now, what are the drawbacks of bioprosthesis? We can look at all the advantages. We can look at all the hemodynamics. We can look at the long-term results. But what are the drawbacks or disadvantages? The biggest disadvantage is durability. Now, these valves are unsuitable, not suitable at all for patients under the age of 65. Even the company wants that they should be implanted in patients over the age of 65. But in India, you can see that patients don't survive beyond 63 years. That's the census reports, that the adult male will survive to 63 years. So it is unfortunate that one should not wait until somebody is 65 and he has hardly 1 or 2 years of life to implant a bioprosthesis. So on that basis, we started implanting the bioprosthesis in India in patients over the age of 45. because we presume that it will last for about 15, 20 years. And our studies up to 15 years follow-up has shown that there is extremely good durability in this age group compared to those in the 60, 65 years age group. Similar results have been produced from Cleveland Clinic on the use of bioprosthesis in younger patients. Now in India, the large majority of patients who require bioprosthesis is because they don't want to take anticoagulation. It is very difficult to manage anticoagulation in patients who live far away from well-known and well-equipped centers, and it is difficult to get good follow-ups on these patients. So therefore, it is important that, especially in the younger patients, that you avoid the use of a mechanical valve and give them anticoagulants for life. As you can see, both with repairs and with the use of bioprosthesis, the lifespan, survival, long-term survival is much better compared to the mechanical valves in India. So it is important that a bioprosthesis can be used in patients from, say, 45 years onwards, or in females, or in educated patients who are willing to undergo a bioprosthesis reoperation. Now, the important thing I would like to stress here is that when you use a bioprosthesis in a young patient, prepare the patient for a reoperation. Tell them beforehand that they will need a bioprosthesis change, say 10, 12, 15 years later, but they will have a much better lifestyle because we don't need to anticoagulate them for more than 6 weeks after implantation, and we can only keep them on aspirin or clopidogrel. And they don't need to do prothrombin time every month, and they don't have any problems with menstrual bleeding, and they don't have a problem with childbearing. It is especially useful for such patients, but of course, it must be told to the patient beforehand at the time of the surgery that the bioprosthesis may not last their lifetime. Except in the older patients who are 65 and above, you can assure them that the remaining part of their life, they can survive with the bioprosthesis, especially the Carpentier-Edwards Magna Ease, which has a much longer survival in the older age group patients. The second most important drawback is structural failure. Because of the treatment of these tissues with glutaraldehyde and other methods like thermofixation, anti-calcification, etc., these tissues degenerate. The degeneration is over a period of time. It starts usually about 7 to 8 years post-implant. And it first begins with some calcification, then it becomes it produces tears in the cusps. It can also produce rigidity and obstruction. So they can develop either aortic stenosis or mitral stenosis, and because of a fixed orifice, they may even develop significant regurgitation, both in the aortic and in the mitral position. But this happens about 8 to 10 years afterwards in young patients, and about 10 to 15 years in older patients. So structural failure is a definite complication of bioprosthesis. It is to be expected. If you say that there is a valve which does not have any problems, I won't agree with you, because even the bioprosthesis is only temporary. And as with any other valvular surgery, bioprosthetic valve implantation, valve replacement is a temporary palliative procedure. Now, preservation. Now, it depends on what method somebody has used for preservation. If, like the olden days, it was formaldehyde, or it was glycerol, or it was glutaraldehyde, These are things that were the cause of degeneration of the tissue. So these preservatives are sometimes very toxic, both for the tissues and for the patients, as well as for maintaining the biological properties of the tissues that are used. Like I said, bioprosthesis is not for the young, which is very unfortunate. In India, the large number of patients that require valve replacement with a heart valve problem are young. Young in the sense they are under 30 years of age. Many of them in teenage, between 12 and 15 or 12 and 25. So this bioprosthesis is totally contraindicated in the young because it degenerates very fast. There is an option, of course, to provide them a better long-term survival with a bioprosthesis that does not require anticoagulation, and that is the homograft valve. Unfortunately, not many surgeons are skilled in using a homograft. They don't have a homograft valve bank. There is no incentive for developing a homograft valve bank. And the medical fraternity, unfortunately, the cardiac surgical fraternity does not believe in providing these patients a superior option. Now, what I have found and what we have found, we have observed and published from All India Institute is that the homograft scallop subcoronary implantation for aortic position is extremely good in terms of durability, avoidance of anticoagulation, and the need for much better hemodynamics for up to 10 to 15 years. So after that, it is not difficult to take out the homograft and replace it with a mechanical valve or a bioprosthesis if you have taken precautions. And one of those precautions which I have advocated for 50 years in my life is to close the pericardium completely, to provide a complete cover underneath that sternum, so that when you do a second sternotomy, it is much easier to approach the heart, it is much easier to dissect, and the aorta is not calcified if you have used a scallop subcoronary technique. If you have used a root replacement technique, it is extremely difficult to remove the calcified aorta, aortic homograft in the second operation. So these are the observations that you have to keep in mind, and these are the drawbacks. And I think the bioprosthesis has a very good position in the choice of valves, substitutes for patients, both in India and everywhere else. However, you must keep in mind that if you are going to use a bioprosthesis in a younger patients in an Indian population, you must warn them of the need for a reoperation, and you must take precautions to protect the heart for a reoperation. I think I'll finish here, and I hope I have conveyed the message to you about the evolution of the bioprosthesis as well as its uses and its necessity and its functional as well as hemodynamic performance in patients in whom we have used the bioprosthesis. Thank you.
Thank you. Thank you, sir. In fact, Sampath Kumar needs no introduction. He's a senior cardiac surgeon of a fraternity. For those students who have come new, Dr. Sampath Kumar served as professor and head of Department of Cardiac Surgery and chief of Cardiothoracic Center at All India Institute of Medical Sciences, New Delhi. He also served as editor-in-chief of the Indian Journal of Thoracic and Cardiovascular Surgery, the official publication of IACTS. Any questions from the audience? Shall I just see the chat box? Sir, can you let us know about the differences between stented and stentless valves?
Well, the stented valves have a portion that protrudes inside the aorta. So that portion may be about 2 to 3 millimeters in circumference, will cause an obstruction to the outflow. And that is one of the reasons why there is a higher gradient in stented valves. The stentless valves, the Toronto SPV valve or the aortic homograft, which both Ross and Sir Brian Barrett boys used, have much, much lower gradients, and they don't obstruct because they are not protruding into the aortic lumen or into the left ventricular outflow tract. That's the difference between the two. The second difference is the stents themselves. If the stents are rigid, they develop what is known as a creep, in which the stents sort of come into the lumen and narrow down the outflow tract. Beyond the proximal suture line, there is a portion near the sinotubular junction where the creep occurs. And so there may be a higher gradient in them. And that also causes degeneration much faster. Whereas the flexible stents don't produce that problem, especially if the flexible stent post is shorter in height. So those are the ones that are much better hemodynamically. The Carpentier-Edwards Perimount is one of the valves which has a much shorter stent, but it is stented. So it does produce some obstruction to the outflow.
Can I make some comments, Dr. Herimat?
Yeah, please. Dr. Tendulkar can come on board. Yeah, Dr. Iyer, sir, please go ahead.
Yeah, morning, Dr. Sampath. Very exhaustive coverage of the tissue valves and very, very informative. Just a few comments. I'm not sure whether I missed it, but one of the indications for the bioprosthetic valves in the younger patients, especially younger girls, are those who are intending to get married or are married and want to have undergo pregnancy. So many of them prefer to and actually want a bioprosthetic valve so that they can undergo a safer pregnancy without need for anticoagulation, and then go in for an elective replacement with a mechanical valve once they've completed the family. And the second indications in the younger population is, of course, the use of bioprosthetic valves in the right ventricular outflow, because that's one area where we would not prefer to use a mechanical valve. Of course, there are some series which have used mechanical valve in that position because of the presumed higher rate of thrombosis in that. So patients who are undergoing a conduit replacement, very often we use a bioprosthetic valve there as part of the right ventricular outflow tract for pulmonary competence. So that becomes another indication for the bioprosthetic valve. And likewise in the tricuspid position for patients, for example, in Epstein's, which are unable to repair the valve and you have to replace it, in a pediatric age group, we'd still go in for a bioprosthesis rather than a mechanical valve. So just thought they'll just add that to the.
Thank you so much. I thought I was talking only about adult cardiac surgery. I did not consider pediatric cardiac surgery, where the stentless valves as well as conduits are commonly used in the RVOT reconstruction, including the aortic and pulmonary homografts. I didn't touch upon that because I was talking about the adult cardiac surgery. In any case, I have had a large number of young women who have come and sought particularly bioprosthesis. They've gone through their childbearing period and come back for a reoperation where we have put in a mechanical valve. Some of them are living for 25, 30 years after the first operation. And I have particularly one patient whom I remember very clearly, and I'm sure you also might remember, a 28-year survival of an aortic homograft implanted in the mitral position, which Dr. Prusty had done in 1970, and we took it out in 1998 and replaced it with a mechanical valve in a young Sardar. So it was a very successful bioprosthesis to use a stent-mounted aortic homograft in the mitral position. I see Dr. Tendulkar, good morning. And I also know that in his KEM experience, they have had a large number of these valves implanted.
Yeah. Thank you. Thank you. Dr. Tendulkar, please go ahead, sir. You need to unmute yourself. Yeah,
just wanted to know about this company people constantly talking about. Ours is the latest generation bioprosthesis. So just wanted to make sure that this so-called generation of bioprosthesis is all company made, self-made. There is no official labeling of a prosthesis being of a particular generation, like first generation, second generation, third generation. Because every company person comes and says, ours is the latest generation, like cephalosporins. More the number of Zs, higher the generation of the cephalosporin.
Very correct. I mean, I don't think any surgeon has said that some particular design or change in the model has made any difference either to hemodynamics or longevity of the bioprocesses. It's only the company's claims.
Unfortunately, by the time we get the long-term results of a particular valve, either the company has changed or the model has changed. So by the time they come back with the results, they say, oh no, we have now modified it better and we have a longer lasting valves and becomes more expensive.
Can you open the chat box? There are a few more questions I'll clear. Yeah, they claim that the novel anti-calcification properties in Edward Resilla valve lengthens its life. Is it true, sir?
The long-term follow-up of these patients does not prove that it is very effective in terms of anti-calcification, because calcification does not always start in the cusp. It may start in the base of the cusp. It may start in the stent posts where the stitches are made, and those are the areas where calcification begins. And once it begins, it can spread quite commonly into the cusp. It can cause tears in the cusp, which is what causes the structural degeneration. That is an unfortunate thing. Although they may not produce thromboembolic complications due to calcification, they can produce tears in the cusps, either at the bottom or in the area where it is sutured to the stent posts. And that is the reason why these valves have structural degeneration.
Any specific value recommend in CKD patients, and if so, why, sir?
I beg your pardon?
Any specific value is better in chronic kidney diseases patients?
Chronic kidney disease. Well, what can I say? I mean,
what he means, patients who are on dialysis, hemodialysis. Hemodialysis is supposed to accelerate calcification of the prosthetic valve.
Most certainly it does. It's better you don't put in a bioprosthesis in such patients because the degeneration is much faster. It may degenerate in 6 or 8 years' time instead of lasting 15 or 20 years.
The thing is, I think calcification is irrespective of what material you use, as long as it is non-auto material. I've seen calcification occurring in the Gore-Tex cusps make these handmade conduits with Gore-Tex valve cusps. I've seen calcification with Gore-Tex. So it's not necessarily biological tissue itself. That's irrespective of what decalcification process that you use. Just the very presence of non-living material in that area produces calcifications.
Yes.
There's a question from one of the doctors from KEM. Can I show that, please? Regarding the stentless valve, can you show the chart? Yeah, how to place a stented bioprosthetic valve in mitral position and how does it differ from stentless?
That's a very good question. Now, in the stented prosthesis only can be used in the mitral position. A stentless bioprosthesis is not suitable for the mitral position. There is no such valve made for mitral valve replacement because of the anatomical features inside. Now, the stented prosthesis is a problem sometimes because the stent may be a little too deep, maybe too high, and they project into the left ventricular cavity, and many of them produce rupture of the left ventricle because of the location of the stents. So it is important that you know how to implant these bioprostheses in the mitral position, and also how to implant a particular bioprosthesis. Like, for example, the Hancock bioprosthesis has a very broad stent. So locating it in the right position is important. You have to see that the Hancock bioprosthesis stents are located at the 2 o'clock, at the 7 o'clock, and at the 5 o'clock position, so that the center of these do not obstruct either the left ventricular outflow tract, or they do not poke into the left posterior wall of the left ventricle after excision. The second thing is, even with the bioprosthesis, you must preserve the cardia. The preservation of the cardia is one of the vital importance in the replacement of the mitral valve, because that is one thing that actually prevents ventricular rupture. And secondly, it is important for maintaining the ventricular geometry as well as function. So in mitral position, whether you use a bioprosthesis or a mechanical valve, vital importance is to preserve all the cardia, anterior and posterior. And that also does not cause any obstruction to the function of the valve. Unlike in the mechanical valve, sometimes they may interfere with it. In the bioprosthesis, no such problem occurs.
Any difference in the patient process mismatch if you use a mechanical valve and a bioprosthetic valve of the same size?
Not really. In fact, bioprosthesis may have a better hemodynamics than the mechanical valve.
Thank you, sir.
Mechanical valve is a single disc, then there is a greater problem than if you use a dual disc bileaflet valve.
Thank you. I think we'll wind up, sir, here for this session. We'll have a tea break of 10 minutes. Followed by that, we have the next session by Dr. Parimala Prasanna on interpretation of management of arterial blood gases. We'll rejoin just after tea breaks at 10 minutes.
Thank you.
I now invite Dr. Parimala Prasanna ma'am to guide us for interpretation and management of arterial blood gases. Dr. Parimala Prasanna ma'am is a professor of cardiovascular anesthesia at Sri Jayadeva Institute of Cardiovascular Sciences and Research.
Good morning. I thank Dr. Hiremat and organizers for inviting me to discuss about this common topic. We'll discuss about pulmonary gas exchange, changes in ventilation and oxygenation, ABG versus VBG, as well as mixed venous saturation versus cardiac output, and in different situations, what are the changes in ABG. When we have a report, we have different parameters. Measured parameters are pH, PCO2, PO2, and hematocrit. Based on these, we get calculated parameters. When we have PO2, based on oxygen dissociation curve, the saturation will be calculated. Similarly, when we have pH and PCO2, bicarbonate is calculated. ABG report also shows you corrected for temperature. Most of the time, this may not be very important, but when we use patients use DHCA, at that time, this becomes relevant. The reference ranges between arterial and mixed venous blood gases are here. Mixed venous saturations are lower, and the blood is more acidic due to higher concentration of the PCO2. These are basic steps. First, to check internal consistency. For this, we need to check the H ion concentration versus the pH. And the tables are available where you can correlate whether it is consistent. Then we have to see what is the abnormality, acidosis or alkalosis, and whether it is respiratory or metabolic. Then whether there is any compensation. Then finally, we have to calculate anion gap. Normal pH around 7.4 is a balance between PCO2 and bicarbonate according to Henderson-Hasselbalch equation. So if there is any rise in PCO2 or fall in bicarbonate, it causes acidosis and reverse alkalosis. So this chart tells us about different types. When the pH is normal, it could be normal or there is a mixed acid-base disorder. And the compensations are by opposite method. Compensation occurs when pH tries to come back to normal. First, we'll see ventilation abnormality, acidosis, and alkalosis. So higher PCO2 is always due to reduced alveolar ventilation. And it is because of the partial pressure effects, it is associated with hypoxia. And the threat to life in acute respiratory failure is hypoxia rather than hypocarbia. There are mainly two types of respiratory failure. Type 1 is hypoxic failure, and type 2 is hypoxic and hypocarbic. Clinical assessment is very difficult. There may be rapid shallow breathing, but it is very unreliable, and patient in respiratory distress can have either normal, low or high PCO2. This is one case where a 4-week-old infant underwent surgery for repair of coarctation. On the first postoperative day, ABG showed pH of 7.2, bicarbonate mildly reduced, PCO2 is high, base excess is -6, and the lactate is normal, chloride is high. So though there is a low pH, in this patient, the PCO2 is the main problem, hypoventilation, and the correction of base excess will improve, lactate is normal, so patient can be weaned from the ventilator. Albumin correction is required. I'll discuss these points again later. So this is another patient, a post-CABG patient with COPD is on SIMV. Patient was put on 400 ml tidal volume with 10 breaths per minute and in IE ratio 1:2. And the ABG showed that PO2 is 60, PCO2 is 68. So normal tendency is to increase the tidal volume and respiratory rate to bring minute ventilation from 4 to 7.5 liters. But after 1 hour, the repeat ABG shows that PO2 is 58 and PCO2 has risen now 83. So this is a problem of dynamic airflow obstruction in COPD or severe asthma patients. So we have to, in fact, reduce tidal volume, increase the IE ratio and also maintain the breath rate so that obstruction to the airflow exhalation is reduced. Respiratory alkalosis is a very common finding in the ABG. It is iatrogenic due to improper adjustments in the ventilator, and it can occur as a compensation for metabolic acidosis. So important to prevent alkalosis throughout surgery and post-operatively because it has peripheral as well as CNS effects, and the threshold for that is 20 PCO. Now, oxygenation parameters. There is oxygen cascade. A normal atmospheric pressure is 760 millimeters of mercury and oxygen is 21%. That means the PO2 is around 150, 1/5 of 760. By the time it reaches the alveoli, it comes down to 100, and arterial 4 to 10 millimeters difference will be there from alveoli. The venous blood will have 40 PO2. So this is oxygen cascade, and hypoxia can be graded or divided into different types like hypoxic hypoxia at the atmospheric or ventilation level, diffusion hypoxia in the alveoli, then stagnant hypoxia in the blood, and then tissue or histotoxic hypoxia at the cellular level. Now, ventilation perfusion matching is, normally we have a minute ventilation of 5 liters and cardiac output is also 5 liters. And out of 5 liters, 1 liter is carried as oxygen. Oxygen is around 1 liter per minute, and the tissues will extract 250 ml out of this 1 liter. The remaining will be in the venous blood. There is alveolar arterial oxygen gradient, and this shows us the degree of ventilation perfusion mismatch. Normally, it is best done in the room air, and it is around 5 to 15. And based on this gradient, we can differentiate. If there is normal gradient, it's mainly ventilation, hypoventilation, and widened gradient can be due to ventilation perfusion mismatch, diffusion, or shunt lesions. These will respond to oxygen, but shunt lesion has a poor response. Then PF ratio is also important in an ABG, because in this example, you can see room air patient has a PO2 of 60. Another patient on ventilator has 90, but the FiO2 is now 21 for a room air patient and 50%. So this PF ratio shows that the room air patient has a good PF ratio of 285 compared to the patient on ventilator. Based on this, Berlin criteria are given for ARDS severity assessment. So less than 100 is severe ARDS. Then importance of VBG. So in certain conditions, VBG is enough when we don't have an arterial line to check lactate levels, to measure PCO2, or in a diabetic ketoacidosis to treat this patient. But in some patients, it becomes very significant to do a VBG because it indicates the amount of tissue hypoxia, high lactate, reduced urine output, metabolic acidosis, low SVO2. These are all features of reduced tissue perfusion. SVO2 of less than 40% or venous partial pressure of oxygen less than 27 is critical. Even during cardiac arrest, these findings are seen early in the VBG rather than ABG. This patient, post-CABG patient, has a, this one congenital redo surgery, has a VBG showing PO2 of 21 and saturation is 34. Lactate is 3.2. He is on room air oxygen. In this patient, it is not enough to just manage oxygenation. Patient is in a low output state. We have to improve or increase his inotropic requirements. Different situations need SVO2, and there are so many uses of SVO2. One is we can estimate cardiac output, and in sepsis or weaning failure, there are protocols available. Then to understand, treat arterial hypoxemia and to readily estimate shunt fractions. So compared to SVO2, how is cardiac output measurement concerned? So, because oxygen delivery depends both on output and content, and cardiac output depends on these variables. Also, in a patient, metabolic demand, HP concentration, body size will alter from, will determine the cardiac output. And this cardiac output can change from minute to minute over time in the same patient or in between different patients. And when we have a cardiac output monitoring, in the higher output ranges, the SVO2 changes very little. So it performs better. But the same cardiac output monitor in the lower cardiac output ranges shows a very drastic fall in the SVO2. So this may not be a very accurate monitor for us in the low output states. So adequacy of tissue oxygenation is best done with oxygen extraction ratio. That is the balance between delivery and consumption. It reflects this balance directly compared to a cardiac output monitoring. So normally 1000 ml is the delivery and 250 ml is extraction. 0.25% is the extraction ratio, and SVO2 formula is 1 minus ERO2. So you get 0.75 as the systemic venous oxygen saturation. There is ERO2 critical, that is when DO2 falls, that delivery falls, extraction exceeds a threshold that is identified by evidence of tissue hypoxia and anaerobic metabolism. And this you can see when the delivery is around 1 liter, the extraction ratio is around 250 ml. But if delivery reduces to around 300, after that it drastically falls. That means whatever we deliver will be extracted. That is, at this point is the critical oxygen extraction ratio. Now SVO2 can be used to measure cardiac index. The formula is VO2 index, into divided by hemoglobin into 1.34 and SaO2 minus SVO2. That is, cardiac index is directly proportional to SVO2. If other parameters are fixed, then if you can see, the index is around arterial saturation 0.95 minus if SVO2 is 0.7, then we get 4 liters. But if SVO2 falls by half, then cardiac index also will fall by half. For weaning failure, there are several articles to see how we can guide a patient's weaning based on SVO2. So after putting the patient on spontaneous breathing, SVO2 fall, if it occurs within half an hour, more than 4.5%, it has a good sensitivity and specificity in predicting patients for extubation failure. In congenital heart disease, how best we can make use of these parameters is seen in complex congenital diseases. So the cause for anaerobic metabolism is the imbalance in the delivery and extraction. As you can see, the delivery decreases after surgery from inflammation, pulmonary dysfunction, low cardiac output, bleeding, or anemia. Meanwhile, oxygen extraction also increases with inflammation, fever, pain, and stress response. So normally, we take arterial saturation as a rough index of QPQS balance in single ventricle lesions, around 80%, and SVO2 more than 50%, a QPQS ratio between 0.8 and 1.2 are targets for hemodynamic optimization. But if we consider alone, each of these cannot be used to maximize the oxygen delivery. You can see here, after this range, it drastically falls. The saturation versus oxygen delivery. Similarly, delivery versus QPQS, around 0.8 to 1, there is maximum delivery. And if we increase cardiac output, this can be optimized better. And even saturation, venous saturation has a very narrow range of optimum conditions. And this is around QPQS of 1. So considering all these things, they have come with an oxygen excess factor, or omega. It is delivery divided by consumption. So extraction ratio is 0.25 and this is reverse, around 4. This can be calculated by SaO2 divided by the difference in arteriovenous saturations. Because you can see the delivery of oxygen is a complex function of cardiac output, pulmonary venous content of oxygen, plus the QPQS. So we have to consider this combined factor for monitoring these patients. The largest amount of DO2 variability occurs due to the cardiac output and SVR. So in managing these patients, we can fix the SVR by alpha blockers like phenoxybenzamine and then manipulate other parameters. So monitoring for these patients is best with mixed venous saturation, and SVO2 reduction reflect tissue hypoxia. In addition, we have to monitor serial lactate in these children to know adequacy of tissue perfusion. Now we'll go to metabolic disorders. Metabolic alkalosis can be chloride responsive or chloride resistant due to potassium depletion, or it can be iatrogenic due to excessive soda bicarb administration. Even large amounts of blood products, colloids, or total parenteral nutrition containing citrate, lactate, acetate will lead to alkalosis due to release of sodium bicarbonate. Now, potassium balance and acid-base disorders. This is one child after supracardiac TAPVC repair. Patient was received in the recovery and pH was 7.56, potassium was low. And after 18 hours, the pH has come to 7.41. Patient was put on CPAP and this ABG was taken, but the potassium shows 5.3. This increase is an early sign of impending low cardiac output. So this is an indication that we have to assess the patient more thoroughly, do a venous blood gas, do the echo, check pulmonary hypertension status. These children are prone for hypertensive crisis. So we have to delay weaning in such patients till other parameters are settled. So the potassium will be exchanged for hydrogen ions in acidosis. So we get hyperkalemia, and in alkalosis, the hypokalemia occurs. Hypokalemia is treated when it is between 3.3 to 3.7 by adding in the maintenance fluid. If it is less than 0.5, only if urine output is adequate, then infusion should be given and monitored every hour, and should not increase the infusion more than 0.5 milligauge per kg per hour. Hyperkalemia, we are all familiar with the management. Moderate hyperkalemia, we can give Lasix. And in severe hyperkalemia, calcium gluconate, insulin, and if required, peritoneal dialysis or hemodialysis may be required. Metabolic acidosis. Tissue acidosis is an adaptive mechanism that helps us to survive hypoxic condition, but it has deleterious effects on the myocardium, brain, pulmonary hypertension crisis or worsening of pulmonary hypertension, and lowers SVR. There are various causes. There are two types, high anion gap and normal anion gap. Here lactic acidosis, ketoacidosis, uremia, toxins. And here because of loss in the kidney or due to excessive chloride infusions. So this is a patient who is on high dose of adrenaline and his lactate is 8.7. Though pH is normal, the chlorides are also high. So what is the reason for high lactate in this patient? Lactates can increase because of anaerobic metabolism as well as non-hypoxic origin, which is type B, and the other causes are drug therapy, hypothermia, and CPB. So this is a beta-mediated effect, type B, hyperlactatemia. It's not related to reduced tissue perfusion, and it does not have poor outlook that we see in the shock patients. This increase in lactate is because of excessive glucose entry into the cell and producing pyruvate. But the rate limiting step is entry of this into the mitochondria, which cannot take that high load. So this pyruvate undergoes anaerobic metabolism and lactate is produced. Now treatment is, you can see lactic acidosis, we have to give volume to excrete excess lactate and source control. Diabetic ketoacidosis will give volume and insulin. In starvation again give glucose and volume. Only in renal acidosis, hyperchloremic acidosis, the definitive indication for sodium bicarbonate is there, because excessive sodium bicarbonate can cause volume overload, hyperosmolarity, alkalosis, hypercapnia, hypokalemia, hypocalcemia. There are three thoughts of managing acid-base balance, especially metabolic acidosis, based on three techniques. One is initially described by Boston technique, Henderson-Hasselbalch equation. Then the Copenhagen or base excess was explained. Then finally the Stewart technique. So briefly we'll discuss these things. So in this, you can see the bicarbonate is a function of pH and PCO2. It's a measured parameter. It's like monitoring ECG for myocardial infarction. We diagnose myocardial infarction based on ECG, but we do not treat the ECG. Similarly, don't treat the bicarbonate because it's not just a parameter of metabolic disorder. That is the disadvantage. And relation between bicarbonate and acidosis is not linear, though we can roughly say less than 12 is severe metabolic acidosis. So it is, the limitation is both respiratory and metabolic components will affect, and it is not the cause of acidosis. Now second is base excess and standard base excess. Now it is to know the amount of the acid or alkali we have to add to get the pH to normal under normal condition. And the standard base excess is for the extracellular fluid. Limitations are again, it is not giving us the origin, what is the cause for metabolic acidosis. Even base excess changes with PCO2 and HB. So we have an anion gap. It represents the amount of unmeasured ions present in the plasma, and we have more anions unmeasured than cations. So there are two types. You can see the sodium and chloride are the major ions. The bicarbonate will decrease if chloride increases or if there are additional tissue acids. So when the chloride increases, it's no non-anion gap metabolic acidosis. And if tissue acids are increased, it's high anion gap metabolic acidosis. So it is to determine the addition of acid or loss of bicarbonate. In ketoacidosis, there are more acids added, and in GI loss or renal loss, the normal anion gap is seen. So abnormal base excess with normal anion gap is hyperchloremia and other conditions. Normal base excess with abnormal gap are tissue acidosis and salicylate toxicity. So now we can classify disorders based on the anion gap. This is the initial classification. To diagnose mixed disorders, this is helpful. If the change in anion gap is less than the change in the bicarbonate, that is more bicarbonate is lost, then there is an additional non-ion gap metabolic acidosis. Reverse is for metabolic alkalosis. So this is a 3 kg 4-week-old baby who underwent repair for intracardiac TAPVC and had problems with suprasystemic pulmonary pressures. Patient was on 10 mics dopamine. The ABG showed that there is acidosis. Bicarbonate is 21. sodium chloride look normal. Lactate is normal, but anion gap is high. So here, these patients, we have to be slow on weaning. In fact, patient may require more intense inotropic support and control of pulmonary hypertension. The third principle is steward. Now, even in anion gap, we have used bicarbonate for calculation. But here he says that the variation in bicarbonate is consequence of acid-base disturbance and not its cause. If you can see here, the strong ion difference, the PaCO2, albumin all around 40 will maintain a pH of 7.4 and bicarbonate is 21 in a normal situation. So compared to Henderson-Hasselbalch equation, the pH is determined by PCO2, strong ion difference, and the weak acids present in the blood. The difference between anion gap and steward is the bicarbonate is included for calculation here and not included in steward. So this is called a Gamble-Graham proposed by Gamble. And you can calculate the strong ion differences and weak acid effect. Basically, the difference here is that we account for all the changes that can happen with albumin, lactate, or other acids. And with corrected anion gap, the results can be similar. So we can practically make use of this in mixed disorders situations. Effect of CPB. During hypothermia, the solubility of carbon dioxide in blood increases, so the partial pressure will be low and blood becomes alkalotic. This is the principle of managing the pH and alpha stat. In pH stat, we add CO2 to maintain pH at any temperature at 7.4. But in alpha stat, we allow the blood to be alkalotic during hypothermia. So if you have a patient at 20 degrees centigrade and analyze the sample at 20 with the ABG machine setting, then you will get a pH of 7.65 and 18 PCO2. But if the same sample is warmed and then analyzed as it does regularly, you'll get a normal pH and PCO2. Few problems we may face in ECMO. So veno-venous ECMO. Here there is a 33-year-old male patient on ECMO for COVID pneumonia. Prior to initiating ECMO, his PF ratio was 55, saturation was 82%, despite maximal ventilation. So he was put on ECMO, and 30 minutes following initiation, he had persisting hypoxia, saturation still 82%, despite a circuit flow of 5.5 liters, and post-oxygenator saturation is 100%. The pump speed is 3,500, and this is the drainage cannula, the exit saturation is 78%. Increasing the circuit flow does not improve the saturation. Now, the problem in these patients is recirculation. So in this, the inflow cannula and drainage cannula, they are very near, then the recirculation can happen. But 6 days after institution, this chest X-ray continues to demonstrate severe ARDS. The ventilator settings are peak inflation pressure 25, PEEP is 10, FiO2 40%, rate is 10 breaths per minute, and minimum tidal ventilation. After 3 days, patient was stable with saturation between 88 and 92, and the venous saturation 60 to 70%, and flow, ECMO flow 5 to 6 liters. Pump speed between 3,000 to 3,000 revolutions per minute. After last 12 hours, his saturation has suddenly fallen to 55%. But post-oxygenator saturation is 100. So after 6 days, the saturation falls. We have to think additional problems in the patient, especially sepsis and we have to manage sepsis for such situation. We know arterial ECMO also can have hypoxia. This is an example, 41-year-old patient on peripheral VA ECMO. He presented with ST elevation MI. Percutaneous intervention was complicated with pulmonary aspiration requiring intubation. Despite revascularization, he had progressive cardiogenic shock and placed on VA ECMO. Circuit is running without any problem, but he is hypoxemic with arterial saturation of 82%. What could be the reason? In these patients, the upper body is being pumped, getting oxygen from the native heart. The lower half of the body gets the VA ECMO flows. The low saturation could be due to this dual circulation that happens, and there may be low output or ventilatory issues in this patient. So we have to manage accordingly. Thank you.
Yeah, thank you. We'll have a few questions, madam. Would you please explain the difference between primary and secondary lactic acidosis? If there is secondary lactic acidosis, in what level of lactate can a patient be extubated if all the parameters are normal? The difference between primary and secondary lactic acid, type A and type B.
I'll show that slide again.
Sure.
In primary lactic acidosis in sepsis patients, more than 4 lactate, or even in children when they have low output state, increasing lactate is a concern. But in type 2 lactate hyperlactatemia, we have seen, I gave one example where the lactate is 8, sometimes it goes up to 10, but still we are not worried. If the cardiac output and other parameters, venous saturations are good, we consider, and patient is on high dose of adrenaline, we most of the time say it is type 2. That is because of adrenaline induced beta adrenergic effect and increase in the glucose load to the cell. But this glucose is not taken up by mitochondria. Instead, it undergoes anaerobic metabolism. So this will settle after few hours once we wean the patient from adrenaline. So we need not depend on the lactate for extubation in type 2 hyperlactate.
Okay. Okay.
One question, Dr. Hirama.
Yeah, please go ahead, sir.
I want to ask these boys, Utkarsh and all, that ma'am kept saying about venous sample. From where is ma'am obtaining the venous samples? Question for the students.
Give a mic to the students, please.
From where is this venous sample being taken? Can Utkarsh or somebody, only Utkarsh I know among the 26, can somebody answer this, please?
So from the central venous line.
From the?
Central line, sir.
Central line meaning?
The CVP line, sir.
Oh, ma'am, what he says is correct, or you need a PA catheter for a mixed venous, or this is correct?
Ideally, we should do it with PA catheter tip, aspirated from the PA catheter tip. But since the usage of PA catheters has come down, the problem.
We take the RA sample as a?
So that is why we are taking as near to the central saturation as well. If you do not have any intracardiac shunts or other issues, we can consider the central. That's why SCVO2 is now considered equivalent to SVO.
Thank you so much.
Yeah.
Now I invite Dr. Ali Zamir Khan on board to take us through the assessment, documentation, and thoracic case presentation. Dr. Ali Zamir Khan is consultant thoracic surgeon at St. Bartholomew Thorax Center in London. He is a member of Academic Council of ICTS and recognized teacher. Known for his innovative and engaging teaching
Good
techniques,
evening, ladies and gentlemen.
noteworthy being his back-to-back thoracic classes during the coronavirus pandemic.
Or rather, good morning, ladies and gentlemen. Thank you very much for inviting me to speak at this prestigious forum. Today, I'm going to talk about thoracic assessment and fitness. More importantly, what I want to tell you is techniques to pass an examination. So in the thoracic part of the exam, really there are three main cases that 95% of students will get. The first one could be a tuberculous empyema. The second could be a mass in the lung, which most likely will be a lung cancer. And the third one is a mediastinal mass. So please remember that these are the three main diagnoses that you should play with, and 95% of the cases will pass. If it's a mediastinal mass, it will either be a cystic mass or it will be a solid mass. If it is a cystic mass, the commonest cystic masses will be bronchogenic cyst or a hydatid cyst. If it is a solid mass in the anterior mediastinum, then the 4 T's come into play. That is thymoma, teratoma, T-cell lymphoma, or a thyroid. And if it is a solid mass in the posterior mediastinum, then it's likely to be a nerve sheath tumor. So whenever you are in the exam and you have a case in front of you, there are 4 points that you have to appreciate. Number 1, take a good history. And more importantly, always be able to summarize a history in a single line. Number 2 is do a general and a clinical examination, at the end of which you should be able to tell the examiner what is the differential diagnosis. Once you have reached this point, you are halfway to the passing marks. The next part is the ones where you start scoring higher marks, is when you can tell the examiner appropriate investigations, and more importantly, if you can come up with a treatment plan for the patient. So really 4 steps to passing an exam is a good history with a synopsis, a general and clinical examination with a differential diagnosis, understanding what are the appropriate investigations that you need to do, and based on these investigations, you then come up with a treatment plan. Okay, when you're taking a history in a thoracic surgery case, there are probably only 7 points that you have to put across to the examiner. The first point is the symptoms. And whenever you take a symptom, you just talk about origin, duration, and progression of each of the symptoms. Don't focus too much on the negative symptoms, as in absence of symptoms. Focus on the presence of symptoms so that you don't waste too much time in the history taking. When you talk about past history, you're only looking for comorbidities which will increase the risk factor for surgical management. When you're looking at medication, you're predominantly looking at anticoagulants that the patient is on, which will prevent your surgery from taking place. The medication list is a very good indication of what are the potential comorbidities of this patient. Always include a family history, particularly focusing on cancer and exposure to tuberculosis. These are the 2 points that you need to get across to the examiner. In a social history, what we want to know is smoking and occupational exposure, particularly if you're talking about mesothelioma and things like that. We need to know asbestos exposure. And of course, we need to know other lung diseases that can happen because of the occupation. The most important part of any of this is the performance status. So in the social history, you must include a performance status of the patient, particularly telling us about what is his WHO status, okay? And last but not the least, allergies. So if you concise your history into these 7 points, it should not take you more than 5 minutes to get a very good history, and at the end to give me a 1-line synopsis of the history. Now, as I told you, the performance status is extremely important in these cases because that helps us decide whether we are going to offer surgery to this patient or not. Okay, so just coming back to the symptoms, I want to specify a few things for you. There are only 5 symptoms in thoracic surgery that you have to talk about, really. The first one is a cough. And for each of these symptoms, if you talk origin, duration, and progression, you'll be absolutely fine. The second one is shortness of breath. Again, what aggravates, what relieves, things like that. Just talk very briefly to the point. The third thing is hemoptysis, extremely important. The fourth thing is weight loss. And the fifth thing is chest pain. If you can tell me just these 5 points, and if you are dealing with an infective case, then don't forget a history of fever. That is very important. Don't try to talk too much about negative history, no history of this, no history of that, no history of that. That actually puts off the examiner. What we really want is a positive history, and we don't want to waste time only on history. We really want to get down to discussing what is the treatment plan of this patient. So at the end of the history, you must be able to give me a 1-line synopsis. 76-year-old gentleman, ex-smoker, 20-pack year history, presents with cough with hemoptysis and weight loss. If you can give me this much history, I know exactly what you're talking about. So please always learn to do a synopsis of your history. When you're doing an examination, always mention general examination, and it should be a 1-line crisp general examination which talks about temperature, respiration, pulse, and blood pressure, and jaundice, anemia, cyanosis, clubbing, edema feet, and lymphadenopathy. If you can get these things into your general examination, most of the times you'll be absolutely fine and you'll not miss anything. TPR, BP, and JACOL are the standards for general examination. When you get into systemic examination, you have to do cardiac and respiratory examination as a whole. So first do the respiratory examination, but also do the cardiac examination at the same time, and follow the standard protocol of inspection, palpation, percussion, and auscultation. Okay, so whenever you talk, you have to say on inspection, 1, 2, 3, 4, 5. Again, talk about positive findings. Don't talk about negative findings, preferably positive findings only. And when you're doing a systemic examination, don't forget about obvious findings on the chest wall, looking for tracheal shifts, looking for any unusual movements on the chest wall, swelling, scars, sinuses, seen impulses, or veins, seen veins. These are the standard things that we are looking for on a chest wall. Okay. Once you've done your palpation and percussion and auscultation, don't forget to talk about breath sounds and heart sounds. These are the 2 things which will tell me that you have assessed the patient adequately. So you must know the different types of breath sounds and the different type of heart sounds. And last but not the least, in the systemic examination, don't forget to tell me about lymph nodes, because lymph nodes very much form a part of general examination as well as systemic examination, particularly when you're talking about lung cancer. Also, specifically with mediastinal masses, don't forget to talk about abdominal findings and external genitalia, particularly when you're looking for germ cell tumors, seminomas, and non-seminomatous germ cell tumors. You must have examined the external genitalia in a male specifically. At the end of having done these examinations, what I want you to do is to give me a synopsis of the examination. I want you to be able to tell me in 2 lines what were your most important positive findings. The moment you tell me what are the important positive findings, then the next thing that you have to tell me is, sir, the probable differential diagnosis in this case are 1, 2, and 3. And when you tell me a differential diagnosis, don't forget common things have to come first. Don't tell me about cartilaginous syndrome or CCAM or all these funny syndromes. Common things first. And remember, in the exam, I told you, and I'm repeating it, commonest things will be an empyema or a lung cancer or a mediastinal mass. So please, please, please tell me the common things first. So I expect you to have reached a differential diagnosis at the end of your clinical examination. Never ever give a single diagnosis. Always give a differential diagnosis. Even if you know what the case is or somebody whispered into your ears what the case was, never ever give a single diagnosis. Always give, it could be A, B, and C, and the most commonest thing should come first, followed by this. Now, next step of passing an examination is the ability to discuss investigations with the examiner. Whenever you discuss investigations with the examiner, what you are discussing are two aspects, okay? Number one is operability, and number two is fitness for surgery. So operability means that you can offer surgery as a treatment modality for this patient. So when you're talking about investigations, always start with routine investigations. And routine investigations are usually the blood investigations. And 3 or 4 important ones have to be mentioned. The first one is hemoglobin and white cells, because you need to know, is this guy fit for surgery? Do you need to arrange blood? Do you need to transfuse before surgery? So hemoglobin is extremely important. White bloods and ESR, of course, tells you about inflammatory profile of the patient. The second thing is the renal profile, because you have to do contrast studies on this patient in terms of CT scans and PET scans and things. So renal profile comes into the picture. The third thing is a liver profile, because it tells you about presence or absence of metastases. And any altered liver profile is a strong indicator that something is going on in the liver as well. So when you scan the patient, you don't just do chest, but you do chest and abdomen. And also the liver profile will give you a coagulation status of the patient, because you're going to be operating on these patients. So if you can tell me these 4 routine investigations, I'll be quite happy, and I'll say carry on to radiology, because the next step is radiology. In a radiology, when you talk about assessment of the patient, please do not talk about CT scan straight away. Always start with chest X-ray, because even today, that is the first investigation of choice. And chest X-ray can be AP, PA, or lateral. I'm sorry, I forgot to put PA there. But AP, PA, or lateral, depending upon what is the status of the patient. But commonest is PA chest X-ray. Once you have done that, then talk about CT scans. And if anybody in the exam asks you what type of a CT scan you will do, the safest answer is contrast enhanced CT scan, because 99% of the times we do a contrast enhanced CT scan. As surgeons, we do that. If you're a physician, then you talk about HRCT and things like that. But 99% of the times, what we talk about is a contrast enhanced CT scan. But you do need to know where you do HRCT and where you do a CTPA. Okay, so HRCT is traditionally when you want to understand the interstitial problems in a lung, and CTPA is when you want to understand the vascular problems in a lung. Okay, the next question is PET scan. If it is a suspected cancer, please always talk about PET scan. Whether they do it in your institution or not doesn't matter. All international guidelines nowadays talk about use of PET scan as a diagnostic tool to identify presence or absence of metastases. So rather than the primary tumor, it's more useful for the distant spread of the tumor. And so no patient should be operated for cancer without a PET scan. Again, do not do a CT guided biopsy before a PET scan. Always do a PET scan and then offer a CT guided or an ultrasound guided biopsy. for two reasons. Number one is that the PET scan will tell you which is the best place to biopsy so that you get an answer. And number two, if you do a CT guided biopsy before the PET scan, then you'll get a false positive PET scan because of the inflammation with the CT guided biopsy. So these are the four standard radiological answers which we expect from you in the exam: a chest X-ray PA, a CT scan, a PET scan, and a CT guided biopsy. If in an exam you tell us these 4 points, you will absolutely pass flying colors, okay? When you're looking at the CT scan, if an examiner puts up the CT scan in front of you, do not forget to look for lung window and mediastinal window. Please remember, do not open your mouth and talk till you have seen both the lung window and the mediastinal window, okay? If it's a cancer, then in the lung window, what you're looking for is the primary tumor or any other lesions in the rest of the lung. But predominantly describe the primary tumor and then switch to the mediastinal window and look for mediastinal lymph nodes. Okay. So this is how a primary tumor will look like. And then when you come to mediastinal lymph nodes, there are only 3 that you have to describe. Really, what we are interested in lung cancer surgery, we want to know N2 and N3 disease. So particularly look for paratracheal lymph nodes, look for subcarinal lymph nodes, and look for aortopulmonary lymph nodes. Okay, paratracheal, subcarinal, and aortopulmonary lymph nodes. And I'll show you this PET scan. So this is a paratracheal lymph node. This would be a subcarinal, and this would be an aortopulmonary lymph node. So that sort of helps you to understand which is which. This patient obviously has got N1 and N2 disease and even N3 disease present, but you need to be able to assess a paratracheal, subcarinal, and an aortopulmonary lymph nodes in the CT, in the PET scan. If you have a case which is having a cyst, then just know the basic features of a bronchogenic cyst and hydrated cyst. At least if you know the radiological features of these two, you'll be absolutely fine and you'll be able to describe it to the examiner. But don't forget a few other cysts that are available, like pericardial cyst or esophageal duplication cyst. But commonest exam questions are in radiology on a hydrated cyst, because we love all these signs of the hydrated cyst. You must make sure that you have a look at all the cysts and understand all the signs of the cyst. And of course, look for bilateral cysts. That's quite important. Another common thing within the cyst world is a lung cyst or a lung abscess. Okay, so remember that and try to identify that. So if you actually restrict your studying to only these ones, it will become so much more easier for you to master the various pathologies and get on with it. If you're looking for masses, mediastinal masses, then this would be an anterior mediastinal mass, like a thymoma or a germ cell tumor. Or the commonest one, as I told you, could be a multiloculated collection. So radiology can be pretty streamlined to only these pathologies, and you should be able to answer 95% of the questions that you're asked in the exam in terms of radiology. So we have done the blood test, we have done the radiology, and there are just a few specialized tests you need to know before you complete your investigation profile. One of the specialized tests is, of course, bronchoscopy, because if you are dealing with infection or you're dealing with endobronchial tumor, then a bronchoscopy will give you cultures for microbiology or tuberculosis, and it will also give you an ability to do biopsy. So remember to talk about bronchoscopy in every case as far as possible. Of course, if it's a specialized case like seminomas and germ cell tumors, don't forget to talk about specific serum markers like beta HCG. Okay, that will add value to your diagnosis. So far you are still diagnosing, and you are understanding operability. And last but not least, also look out for serologies for specific things like hydrated serology. So these things are a few specialized tests that you must know. Also, don't forget carcinoid tumors, and they have specific serum markers that you have to look for. So once you have reached this level of discussion with examiner, at this point, there are three things that I expect from you. I expect that you would have reached a diagnosis. Number two, you have confirmed operability. Okay, so this is the point at which now the big boys club starts. Now we want to start talking about fitness for surgery. Okay, so when you're assessing a thoracic surgery patient in the clinic, always remember the philosophy is diagnosis, confirm operability, and assess for fitness for surgery. And whenever you start talking fitness for surgery in the conversation casually, you must throw in these two papers. One is the ESTS ERS Task Force Guidelines for fitness for surgery, and number two is the ACCP, which is the American College of Chest Physicians Guidelines, which was published in Chest. So don't forget to talk about these two and throw it into the conversation. And the most important thing to remember when we were talking about fitness for surgery is that all the guidelines start with a cardiac evaluation. I have seen many, many times people jump into respiratory function tests, but that is not true. All the guidelines, if you look, actually start with cardiac fitness. So whenever you're talking about fitness for surgery, you have to start with cardiac fitness, cardiovascular fitness. And only two main investigations that need to be followed is a pre-op ECG and an echocardiogram. And the third indication is an angiogram. So whenever you talk about cardiac fitness, don't forget to talk about pre-op ECG. And it's always good to say pre-op ECG for everybody. There's nothing to be lost. And then echocardiogram, particularly for patients over 40, 45 years of age, or some positive cardiac findings. And then, of course, if they have had a history of MI, then you need to know what are the, less than 6 weeks, you don't do lung resection. Less than 6 months, you at least need a cardiology opinion. And if you're worried about anything, then you must ask for an angiogram. And remember, heart takes preference over lung pathology, always. Because people don't die from lung cancer, but they will die acutely from a MI. So you don't want to cure the lung cancer and have a dead patient with an MI. So always in an exam, if you're ever asked about anything, you must say cardiac surgery takes preference. If the patient needs CABG stenting, that has to be done first. All other lung pathology can wait. So remember, when you're assessing fitness, first assess for cardiac fitness. Now the next part of the discussion comes in where you talk about assessment for respiratory function of the patient. Now, assessment for respiratory function of the patient is very, very easy. Click on the next button, I think. What you need to do is you need a baseline oxygen saturation. You need an ABG if you have access to an ABG, but the real respiratory assessment is with simple spirometry, a flow volume loop, and a gas diffusion and transfer coefficient. These 3 points, a spirometry, a flow volume loop, and a gas diffusion transfer coefficient, can be done on almost all patients, and they will give you adequate assessment of respiratory function of the patient. So it's very important to do respiratory function. And then on the basis of these 3 respiratory functions, then you decide whether the patient needs further investigation with either a shuttle test, a 6-minute test, or a cardiopulmonary exercise test. Actually, 6 minutes walk test is not so much fancied. It's actually the stair climbing or the shuttle test and the cardiopulmonary. So if you're talking about respiratory function assessment, it's got to be spirometry, flow volume loop, a gas transfer, and then on the basis of these, you decide whether you want to have further respiratory assessment. So know this curve of spirometry, know what is an FEV1, know what is an FVC, and you must know FEV1 stroke FVC ratio. And these are the flow volume loops that you must know. There are various pictures here. And I would suggest, this is not a lecture on flow volume loops, so I won't go into details of this, but you must know these various pictures and understand what represents what is an obstructive disease and what is a restrictive disease. And last but not the least, you must know DLCO. Now, on the basis of FEV1, flow volume loop, and DLCO, what you need to be able to do is to calculate the predicted post-operative FEV1. And the calculated predicted post-operative FEV1 is this formula. Pre-operative FEV1 into 1 minus proportion of lung to be resected. So you must know the segmental anatomy of the lung, and you should be able to calculate how many segments are you going to take out of 19, and then just use this formula to calculate the predicted post-operative FEV1. Same way, you can actually calculate predicted post-operative DLCO. And both of these will help you to decide whether this guy can undergo surgery or should he have further exercise testing. And when we talk about further exercise testing, we usually do it when the FEV1 and DLCO is less than 80%. Okay, that's a level 2 evidence in the ESTS guidelines. Shuttle walk usually is never used alone as a capacity for calculating fitness for surgery. You always add a stair climbing. The stair climbing is the best and the most efficient way of knowing fitness for surgery. If a patient can climb 22 meters, then it really is very, very sensitive. And it's in fact sometimes said to be better than spirometry and first line tests. And I personally ask the patient, can you climb 1 flight of stairs? And can you climb 2 flights of stairs? And if he can climb 2 flights of stairs, usually he's okay for surgery. And if he cannot climb one flight of stairs, then you ask for a CPAT. Okay, so that's quite important to understand. The stair climbing is the more sensitive than the others. The 6-minute walk test is not a very good test, and it has not been recommended in the guidelines. So don't talk about it. It is actually the oxygen saturation drop of more than 4% after the stair test that predicts higher morbidity and the need for a formal CPAT. So you must consider a formal CPAT if the saturation drops more than 4%. Again, a formal CPAT is done, a cardiopulmonary exercise test. It measures a VO2 max, a VO2 peak, and it's very, very predictive, highly predictive of post-operative complications. And these are the numbers that you have to follow. More than 75%, more than 20 mils per kilogram, the guy is fit for a pneumonectomy. Less than 35%, less than 10 milligrams per kilogram, very, very high risk of mortality. And there's not enough evidence at the moment for values for lobectomy for a CPAT, but it definitely tells you a high risk, moderate risk, and low risk of a patient. So 20 and 10 are the two extremes, and then in between it is 15, but the latest papers are now talking about 12. So 10, 12, and 20 are the ones that we look at the numbers for good patient, moderate patient, very high risk patient. Always talk about preoperative rehabilitation in these patients. Don't forget about smoking cessation. So when you're assessing a patient and when you're trying to talk to an examiner, always say that I would like this patient to stop smoking. He might need early prehab and post-op rehab. That is also part of the guidelines. And they talk about reducing morbidity and mortality with these. So the bottom line is when you assess a patient for lung cancer surgery, what you're looking for is the risk factors. And then on the basis of the number of risk factors, you then give a percentage mortality when you do an informed consent for the patient. So if you've got one risk factor out of all of these, then you have a 1.1% risk of mortality or complication. If you've got two risk factors, then it's a 4.6. And if you've got more than three, there is a 10% chance of you having a major complication like needing ventilation, ICU, or mortality. So whenever we do these surgeries or whenever you assess a patient for thoracic surgery exams, the one philosophy we want to understand from the candidate is that surgery is not important. What is important is that we get a live patient at the other side of the surgery. So that is the philosophy when we assess a candidate. We don't want to assess, the finer details. What we want to assess is this guy a safe surgeon? All we want to know is you as a candidate are a safe surgeon. Once I know that, then I'm happy to pass you and get you as a certified thoracic surgeon. Thank you very much for your time.
Thank you, sir. Can I have questions from the audience? Any questions? Can you open the chat box, please? Can you show me the questions? Yeah, okay, fine. Yeah, Dr. Prasthasima has a question on it.
Zamir, you gave a very extensive lecture and it's very wonderful. Now, I wanted one thing. One of the problems that the students face is when they are given a CT scan or a CT scan, let's just say restrict to CT scan. Can you tell them how to read it sequentially? Like how do they approach? Because they tend to just...
Sir, I think there is a lecture on CT and in the series. That's why I did not go into details of assessing a CT scan. There is a whole lecture on CT scans, if I'm not mistaken.
Yeah, it was done, but any particular tips you would give them, sir, for a surgeon, for a resident?
This is a whole topic by itself, to be honest. I do almost a 2-hour class on how to read a CT scan. Now, whenever you read a CT scan, this is directly, I'm addressing students. The important thing to remember is a normal CT first. Okay, you must know a normal CT first. You must know the orientation of the patient on the table, which means that when you're looking at a screen of a CT scan, the head is away from you. You're standing at the feet of the patient and you're looking at the chest of the patient. Always have a sequence of reading a CT scan. I start in the midline and I move laterally. So whenever I see a CT scan, I will look at the trachea first and I'll follow the trachea down to the carina. I'll follow it to the right and the left main bronchus, then focus on one side at a time. I do not identify the lobes of the lung only by looking at the side. You cannot do that because many patients will not have complete fissures. So the correct way to identify lobes and to know in which lobe the tumor is by following the bronchopulmonary segments. So I will follow the trachea, right main bronchus, upper lobe division, bronchus intermedius and things. So whenever I teach people to read a CT scan, I always teach them the anatomy of the bronchopulmonary segment first, and then follow the CT scan from midline to the periphery. The other important point is, as I said in the lecture, do not open your mouth till you have seen the whole CT scan, including the lung and the mediastinal windows and the plain film and the contrast film. So look at all the phases of the CT scan. Don't start talking straight away. The other thing which will irritate the examiner is if you keep going up and down on the scans. One look is what you get. Start with one and go in a sequence and finish it. Don't scroll up and down because that really irritates the examiner. And always, all definition comes from midline to the periphery. And like I said in the lecture, you have to talk about bronchopulmonary segments. All description of a CT scan is based on bronchopulmonary segments. If you would like, I'm happy to do a full lecture on CT scan evaluation. It's a very, very detailed study.
We'll definitely, because I'm resuming my master classes. Definitely, I think in the master
I'll be
class,
happy to do CT scan. I do a very detailed CT scan of the chest for the students.
I think if no further questions, sir, I think we will just break for lunch, a short break. After that, we'll go with the cases, sir. I think.
Hiramat, I hope the lecture was adequate because I tried to
it was very much adequate, sir, and the student
only
was,
for the exam going students. I didn't want to go into too much detail.
The student who has taken the thoracic case will be presenting in that format what you have suggested now. I've told him already.
All right.
So things should be fine. We will be seeing you during the thoracic session as examiners, sir.
Okay, sir.
We'll resume back within 30 minutes. Lunch break is only 30 minutes today. Kindly see that everybody is there on time. Thanks. Thank you, sir. Thank you.
Next, we'll start with the case discussion. It's a valvular case. The next student to face these challenges are Dr. Prerna Singh from Care Hospital of Hyderabad, Dr. Preeti from Jayadeva Institute of Cardiovascular Sciences. The examiner for the session are Dr. Sampath Kumar, ex-professor and head CTVS AIMS, Dr. Sushila Shripad, senior consultant, Narayana Hridayalaya, Rabindranath Tagore, Kolkata, Dr. O.P. Yadav, editor-in-chief, Indian Journal of Thoracic Surgeon and Cardiovascular Sciences, Dr. M.A. Jilani, director, professor and head, GB-PAN, New Delhi. There is a candidate assessment sheet given for evaluation. The time limit is 1 hour and the warning bell will ring at 50 minutes.
Should I start, sir? Good afternoon, everyone. I'm presenting a case of Mr. Sanjay Kumar, 46-year-old male, hailing from Bihar, food shop owner by occupation, presented to the hospital with chief complaints of gradually increasing breathlessness and easy fatigability since 1 year, and palpitation since 4 months. History of presenting illness. Patient is a known case of rheumatic valvular heart disease since 16 years when he had complaints of dyspnea and fatigue of 2-year durations, for which he was operated, after which the patient was apparently asymptomatic till 1 year back when he developed breathlessness and fatigue, which was insidious in onset, gradually progressive, exertional, non-seasonal, and grade 2 NYHA in severity, which has now progressed to grade 3 NYHA. Breathlessness was relieved by rest and not associated with cough, expectoration, or any seasonal variation. Patient also complains of feeling of his own heartbeat since 4 months, which is aggravated on stress and exertion, lasting for around 5 to 10 minutes, and relieves on its own after taking rest. Patient gives history of receiving monthly penicillin injections taken for around 10 years. Patient does not recall any history of fleeting joint pain or high-grade fever during childhood. There is no history of PND, no history of cough and pedal edema, no history of chest pain, syncopal attack, headache, loss of consciousness, convulsions, abdominal pain, lymph pain, or intermittent claudication, no history of recent fever, rash, or painful nodules, no history of arthralgia, arthritis, hematuria, no history of hoarseness of voice, dysphagia, or any pressure symptoms, no history of pedal edema, abdominal distension, nausea, vomiting, anorexia. Past history, there is no significant medical or surgical history. Patient is non-diabetic, non-hypertensive, no history of asthma, pulmonary tuberculosis, or any renal diseases, no history of any bleeding diathesis. Personal history, patient is non-smoker, non-alcoholic, mixed diet, regular sleep, normal appetite, and regular bowel and bladder movements. Family history, there is no similar complaints in the family, no history of any heart disease or hypertension in the family. Drug history, patient does not have any documented drug allergies. As present, patient is on beta blocker, digoxin, diuretic, and acetone.
Can we stop you for a moment? You took a history of high-grade fever. What was that mean to suggest?
Sir, for infective endocarditis.
So in infective endocarditis, the history you take is of high-grade fever?
No, sir, low-grade fever.
Well, you know the answer, then why create a harakiri in the exam? And then how do you take that history of infective endocarditis?
Sir, usually renal hematuria will be there, plus painful nodules will be there. There will be
Oh God, so you take history of painful nodules and renal hematuria, all medical terminologies in history. The basic concepts have been thrown to wind. So some of us may be nasty and may belong to an old frame. So in history, please use patience words.
Yes, sir.
These are small, small things.
I have a suggestion to make. Okay. When you present a case and when you want to pass this examination, remember, this is only a mock examination. So make all the mistakes you want to make now, here, and we can correct it for you. Second, don't go on to highly sophisticated new technology. Talk about fundamentals, what you have to learn to do in order to get your MCH degree. Something like ASD closure, mitral valve replacement, aortic valve replacement, and things like that. And you must know something about those mechanical valves, substitutes, and how to do the operation. Don't talk about valve-in-valve and TAVR and all that. That's going to get you into serious trouble. So these are the two things I would suggest. So we are going to bully you, but don't get worried because this is only a mock examination and you are not going to fail. Also, as examiners, we come here to pass you. We don't come here to fail you. So if you want to fail, it is your own effort to fail, not mine.
Sir, all the examiners have got the email. On the email we have sent Google assessment sheet, sir, candidate evaluation sheet. I request kindly to just fill as the candidate presents. You can always, at the end of the session, you can fill that and submit, sir.
How do we access that?
It's accessible. It's on your email, sir. It's a Google form what we have created and sent to you, sir.
Oh God.
Based on the history, her presentation, clinical examination, differential diagnosis, all these are the criteria what we put forth. And based on that, you can put her marks out of 10, sir. Thanks. Yeah, you
I'd
can
like to
proceed.
give a small comment, if I may.
Remember, you are not audible.
I'm not audible. I don't know. So far, I was okay in the morning.
Your voice is breaking. It's not clear.
Is it any better now?
Tell me, madam.
Better? I just want to suggest to all the candidates, please speak slowly. If you're reading out from a sheet, you tend to be very fast. But if you can remember the case history, have only a few notes with you, then you will present the case better. And the second thing is, when you're speaking so fast, for instance, I couldn't really get the age of the patient. So please tell me what the age of the patient is. And the third thing is, I do not know, I think Dr. Yadava might clarify. Do you have an examiner who examines the written case history now? Because the candidate will not have that written case history. The candidate will have to speak from memory and with a few maybe hand notes. That used to be the case.
Yeah.
The case sheet is marked separately by one of the examiners, while one of the other is taking the actual clinical examination. Is that the case?
Well, ma'am, there are no guidelines there, but the examiner can choose. He can ask the student to give the case sheet and then take away. So students should be prepared to present the case without that, as you very correctly said. And it brings in a flow, which is better without a sheet.
Extempore is always better, that registers properly with the examiners. If you speak very fast while you're reading out, then many things are missed.
Yeah, I'd like to welcome Dr. Mohammad Gilani also as a senior examiner for this session.
One small point I wanted to tell, because she is talking so fast, we were not able to register what she is talking.
Exactly.
And if you want to tell in your medical terms, you should then say he gives a history suggestive of something. Otherwise, if you're not reporting it in the patient's word, you have to use the word history suggestive of Sometimes some examiners say you're an MCH candidate, you don't have to do it in first MBBS level. Then you must use, there is no history suggestive of these things, if you want to use that. Otherwise, you are reporting.
Yeah, please proceed.
So coming to general physical examination.
Can you tell me the age of the patient?
40 years, ma'am.
Thank you.
Yeah. 40-year-old male, known case of rheumatic heart disease with history of previous surgery, most probably CMV, now presented with fatigue and exertional dyspnea of 1 year duration along with palpitations. Now came with the complaints of exertional dyspnea and fatigue and palpitations of 4-month duration, exertional dyspnea and fatigue of 1 year duration, sir. There's previous history of rheumatic.
Summarize it if you like what you are prepared. Not repeat the.
A 40-year-old male, known case of rheumatic heart disease with the post-CMV status, sir, with came with chief complaints of exertional dyspnea and palpitations.
When was the CMV done?
In 16 years back, ma'am, in 2005.
Go on.
NYHA class 3, sir.
You have to mention the quantify it, no? NYHA class, nothing.
Well, let me defend the student. This is history at this particular time. The NYHA class is not to be quantified by the student at this stage. That will come as a part of diagnosis after the assessment of everything.
And she was asked to summarize.
As far as I know, she already said NYHA class 2.
Well,
summarize.
I think that's what she said earlier.
That's why we have to tell them that let's not get overboard. Let's realize that case presentation should be very basic and let's not jump the board.
Go on.
Coming to general physical examination, patient is conscious, coherent, well-oriented to time, place, and person. Patient was examined both in sitting and supine position with the chest exposed. Pulse rate is approximately 64 beats per minute. Patient is in AF with controlled ventricular rate, irregular pulse. BP is 110 by 70 mm of Hg.
Girl, can you breathe between sentences?
Yes, sir. BP 110 by 70 mm of mercury, left arm supine position, respiratory rate 18 per minute, abdominal thoracic time. JVP
Speak slowly.
Yeah, speak slowly.
Yeah, you're going like an express train. We need a passenger train.
I told you breathe between sentences.
Speak extempore, then you will be slow and steady.
Can you not look at that and just talk?
Okay. JVP is normal. There is no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Coming to inspection, chest is bilaterally symmetrical. All quadrants move equally.
Can you stop there? Did you examine the pulses in all the 4 limbs?
Not pulses, ma'am.
Now, did you examine, the madam is asking, did you examine the pulses in all 4 limbs?
Yes, sir. All distal pulses palpable.
You have.
Yes,
and they are of equal in volume. That's what you have to say in your general survey examination. Yeah, go on.
Can I interrupt? You said pulse is 64. At the same time, you said patient is in atrial fibrillation. Do you really want to report just the pulse?
Pulse deficit is, apex pulse deficit is more than 10, sir.
So shouldn't we have come that? So another thing is, let not the examiner extract information from you. You know, you should bring out things which are relevant the first time round. And why peripheral pulsations are so very important in this specific case?
Sir, any thromboembolic episode from because of the AF.
So that's very important.
Inspection, chest is bilaterally symmetrical. All quadrants move equally with respiration. There is around 12 to 15 centimeter of transverse scar in left fourth intercostal space along with an ICD scar. No others, apical.
No. When you say scar, something else should be added to it.
Healed by secondary intention.
Healed by secondary intention?
Primary intention, sir.
Primary intent. Why are we asking that?
Sir, Any possible causes of infection or?
What would be the, as a surgeon, your implication?
Sir, any history of thoracic surgery or lung infection or?
There is history of thoracic surgery. There is an incision on the chest.
You have got a history of closed mitral commissurotomy. Isn't that the scar?
Yes, ma'am.
Then just say that, be confident.
If the patient's wound has healed by secondary intention, what is the surgical implication for the second surgery?
Sir, lot of additions will be there.
Ah, okay.
Apical impulse seen in left fifth intercostal space, 2 centimeters lateral to mid-clavicular line. And then coming to palpation, apical impulse confirmed.
Please speak a little slowly. 2 centimeters, what, outside the midclavicular or inside?
Outside, ma'am.
Outside.
Okay, please speak slowly and clearly. Right. Thank you.
Apical impulse 2 centimeters.
Can you just 1 minute? The examiners, there is a conversation between you, this examiner and the examinee. And what are we trying to do? We are trying to build up a mental picture of the patient and the heart. If you are so fast, we don't get the picture.
Coming to palpation, apical impulse confirmed, apex is tapping time, thrill is present, diastolic thrill present in the mitral area, parasternal heave is present.
In your inspection, you did not mention if there was any precardial bulge or there were any pulsations visible.
No visible pulsations apart from the apical impulse.
There was no precardial bulge?
Precardial bulge was present.
Is there?
Yes, ma'am.
Yeah, but you didn't mention that. Okay, go ahead.
Okay, now, have you contradicted yourself very majorly till now? You said apex beat is 2 centimeters outside. So you are suggesting cardiomegaly, am I right?
Yes, sir.
Then you are talking of a diastolic thrill.
And
what are you leading us to?
And a tapping apex. She used the word tapping apex.
I was coming to it, Dr. Prasima. So then you are talking of a diastolic thrill and a tapping apex. What are you leading us to?
Sir, patient is having both the mitral stenosis and regurgitation lesion.
Regurgitation also?
Yes, ma'am.
Why? Could it not be just a restenosis?
No, but are you understanding Professor Yadav's statement? You are telling us that there is a large heart and you are saying that there is significant reduction of flow to the heart because you use the word tapping. Do you understand the dichotomy?
Yes, sir.
There may be a mixed lesion. We are not challenging that. But with the mixed lesion, do you expect to have a tapping? What does the tap mean?
Palpable as one.
And if you are telling the heart is dilated, that means
This one is not.
you have to evoke what? If you have a palpable S1 and yet a large heart, what are you trying to say? You understand you're at cross purposes.
Yes, sir.
There is some other way, but we'll not talk about that. Continue.
Did you find anything in the pulse that could have given rise to a different diagnosis in addition to mitral stenosis?
Mitral stenosis. Large heart with mitral stenosis. That's why
What about the blood pressure?
Blood pressure.
Sir,
What's the nature of the pulse?
irregularly irregular, sir.
Volume.
Volume.
Low.
Is it collapsing?
Low volume pulse, you are saying. So where on earth can we have a large heart, no? With a tapping apex? If there was concomitant AR, but no. There again, the apex would not be tapping, for your information. Okay.
Percussion, right heart border corresponds to the sternal border and left heart border corresponds to the apex. Coming to auscultation, normal S1, loud P2. There is low pitched mid-diastolic rumbling murmur, grade 4 in intensity, best heard with the apex, at the apex of the heart, with breath held in expiration and with the bell of the stethoscope.
You did not go to the heart sounds, no?
So normal S1, loud P2.
Normal S1
Yes,
and
sir.
loud P2.
Then high-pitched, soft-going pansystolic murmur of grade 2 intensity, best heard with diaphragm of the stethoscope in left lateral position, radiating to the axilla, anterior axillary, mid-axillary line, sir. Ejection systolic murmur present in the pulmonary area, sir. Then other systemic examinations. Parabdomen soft, no organomegaly, no ascites.
No, but before you go to other system, think what other things you should have searched for and auscultated, particularly in this patient.
Sir, for murmur for tricuspid valve, but it was not there, sir.
Did you do any provocative tests for the tricuspid valve? No.
Respiratory system, bilateral air entry present. CNS.
What was the jugular venous pressure, your estimate?
JVP?
JVP is normal, sir.
So what is
GVP is never normal.
Normal.
You can't say that on clinical examination. Suppose the patient was severely dehydrated. JVP is raised or not raised?
Yes. Because we wanted to ask that. That's why the question was asked, did you do any provocative maneuvers? What is the provocative maneuver you would have done?
But,
Has the liver got any connection?
sir, there was no hepatomegaly. And
Sir is asking, see, sir is giving you a clue. He's your best friend.
sir, tapping of on the liver.
Do we tap on the liver?
Sir, hepatojugular reflex.
Hepatojugular reflex is not tapping on the liver.
Pressing on the
So do you think that hepatojugular reflex is I tap the river and the JVP goes up? Sorry, anyone can answer? How long should you keep the hand over the and compress that area? You have to give a sustained compression. Please do not be under the impression it is a slap on the liver.
You said there was a parasternal pulsation. Was there any murmur there? Left parasternal?
Parasternal heave was there.
Yes, you said that. But was there any murmur?
Ejection systolic murmur was there.
No. Parasternal. Madam is asking parasternal. Yes or no? Did you get a murmur? Parasternally. What was that murmur? You're nodding like this. I don't know. Yes or no?
So the systolic murmur that you mentioned, where was it located?
Sorry, ma'am, I did not get the question.
The maximum intensity. Madam is asking, where was that systolic murmur that you auscultated maximally? Was it at the apex? Was it also there parasternally?
Says second intercostal space.
Second is that's ejection systolic murmur, you're saying?
That is the, please don't get confused. Ejection systolic murmur you said in the second space.
Yes,
You said that there was a pansystolic murmur at the apex going to the axilla.
Yes,
Did you also get a pansystolic murmur parasternally or retrosternally?
Sir, retrosternally I could not appreciate. Parasternally it was there.
Parasternally it is there.
Yes, sir.
So did you do any tests for that?
No, ma'am.
Respiratory variation?
The respiratory variation was not there, sir.
Not there. Do you think it's the same murmur which you heard in the mitral area?
Yes, sir.
You feel that it's the same murmur. Okay.
You mentioned that the murmur radiated to the mid-axillary line. Did I hear that correct?
Yes, sir.
Now, when you say something, you must be able to explain what were you aiming at, what were you leading us to?
Sir, severity of MR.
Severity of MR.
Tapping pulse.
So now severity of MR, according to you, is what? With the murmur located in the anterior mid-axillary line.
So usually if it's in the anterior axillary line, it's mild. If it's in the mid, it's moderate. And if it goes beyond that, it's severe.
Now, point that I'm trying to give to you is that you are again, you talk of heart being enlarged with a diastolic murmur and a diastolic thrill. So if the MR was severe, will it not be heard beyond that? So this is where you create problems, that you are not building yourself into a coherent story. And that is what you need to do in the exam. The so-called art of exam is just this. So you should have debated yourself, look, am I contradicting myself? A tapping apex,
tapping impulse.
heart enlarged, mitral regurgitation, mild to moderate because it's not radiating. So something you should alter, even if you find something, and you should be smart in the exam. If something is not fitting in, keep quiet.
Was there any epigastric pulsation?
No, ma'am. Parasternal was there, but like not a clear epigastric pulsation was not there.
What was the grade of the heave?
Grade 2, sir.
Grade 2.
Hello, excuse me.
What is epigastric pulsation if it was there along with a parasternal heave and a pulsation? What would that indicate?
Right ventricular hypertrophy.
Okay. And then?
Pulmonary
I think this murmur is different from the other murmur that you auscultated. Can you do any test, bedside test, to understand whether it is a left-sided murmur or a right-sided murmur?
Ma'am, left-sided murmurs will not vary with the inspiration, and right-sided murmurs, they'll increase with inspiration.
Is that all? Any other test?
Can you provocative test to bring out right-sided murmur? You must raise your leg and give the answer with confidence.
Increased venous return.
Please speak loudly.
How? Increased venous. See, I give you a clue. I am trying to help you. Everyone there are smiling.
The Trendelenburg position.
Huh?
Trendelenburg.
Do you really? What can you do? You raise the leg up. Okay, Trendelenburg, or raise the leg up and increase the venous return to the right heart. The TR will increase. Take the clue. There is always usually one of the 4 examiners is trying to help you while the others are examining. Okay. Pick the clue.
Specify that it was the patient's leg that was to be raised.
Yeah.
Is there any other test where you increase the systemic resistance?
You must raise. You must be bold with your hand and give the answer. To raise the systemic vascular resistance, you must boldly give the answer. She doesn't get the clue. Arey, what is this? What is this called?
Clenching of the fist.
What is that clenching of the fist called? There is a technical term.
Isometric.
Everyone is telling other than you. Isometric hand grip. What will happen to left-sided lesions with the isometric hand grip? You know, you don't know. You read it up. Provocative testing. Okay, next.
The diagnosis.
Ah.
Yeah, go on.
In case of
Was there pedal edema?
no, sir.
Hello, hello. Can I ask something?
Please, sir.
Please go ahead, sir.
Hello.
Yes,
Can
sir.
you tell
We can
me?
hear you.
Okay, can you tell me the reason for this, the systolic murmur in the second space? You said that there is a ejection systolic murmur in the pulmonary area. Can you explain that? Hello, can you hear?
Yeah, we can hear you, sir. She is unable to open her mouth. We are able
Okay,
to.
actually, what?
I think we cannot see the candidate though. I think
There is one window where you can see, madam.
It's a window within a window. We can't see her. Anyway.
Okay, can I know her name? Can I know her name? So I can call
Yeah,
her.
we need to have
Satish,
some
can you make the
interaction.
window of the student directly?
Tanika?
The window of the student.
Close our
Tanika?
window. Keep the window only for the student. Satish.
Flow murmur across the.
Yeah, can you see madam now?
Yes, we can see now.
Yeah.
Kanika, that what I say, ki whenever you see any patients and if any of the findings is you are not able to explain, so there are two ways. Either you cook the history and examination and tell, but that is a risky thing. What Dr. O.P. Yadav has told you can modify and then tell. So that is little risky. If the examiner has examined, then you will be in soup. But you should be, there is a reason you can examine and you can explain it on your own, whatever is getting. I will suggest you stick to your finding, whatever you are getting, and try to explain it whatever you can do. Like like in this case, you are getting that LV apex plate is shifted to the left side. It means there is a LV is dilated, which is not a common finding mitral stenosis. So you can explain it with some other, either they can be MR, which is very common because they will be the mixed lesion, or it can be the some other multi-valvular lesions. So you can explain everything, but you should know what to explain and you should have in mind also. So can you explain me the reason why you are getting the second ejection systolic murmur into the pulmonary area?
Sir, because of functional pulmonary stenosis, the blood flow is increased.
Pardon?
Functional pulmonary stenosis, sir.
Functional pulmonary stenosis in a case of mitral stenosis, that too redo restenosis, it's very rare thing.
In mitral stenosis, circulation is less or high?
Yes, sir.
Less, no?
See, you should not confuse the pH with the pulmonary hypertension and the pulmonary stenosis. Both are entirely different things. Pulmonary stenosis will give some ejection systolic murmur, but what murmur will you get in a case of the severe pH? Can you tell me what murmur will you get in a case of severe pulmonary arterial hypertension? Is it systolic murmur or it is diastolic murmur?
You have to steal the answer from sir.
Diastolic.
Diastolic murmur. What is the name of that murmur?
Huh? Answer loudly, please. See, one of the things is in the exam, you are going to become a consultant. You have to be bold and you have to be clear. I can't hear you. How can they hear you?
You just come nearer to the mic and speak.
Yeah, speak.
Oh, it's a Graham Steele murmur.
Graham Steele.
Graham Steele, very good. Excellent. Excellent. This is the what murmur you wanted, but you try to explain it by the ejection systolic murmur, which is not correct.
Correct.
So now can you further explain why this ejection murmur, some systolic murmur into the pulmonary area you are getting? What is that murmur? Can you tell? Can you explain?
Sir, the mitral murmur only could have been heard in that area.
Mitral registration murmur is being heard in this area. So how will you differentiate? What is the inching technique? What is the inching technique of auscultation? If you say yes, if you say no, then I will tell you.
Say loudly, no. He can't hear.
See the inching, this is the way you have to differentiate because you are getting the same murmur. One murmur is there, but it will be heard in the other area. It is not one murmur is in the mitral area, but it will not be heard in the other area. So if you move away every inch, put your step and keep moving away from the maximum intensity, you will see if it is decreasing, and if it is keep on decreasing, then it is the same murmur which you are listening into the mitral area. But if you are getting the murmur intensity is becoming loud, it means it is a separate murmur. It is not the same murmur. So you can know whether it is the same murmur or it is a two different murmur.
Incidentally, I just want to ask, did you auscultate the aortic area and did you get an ejection systolic murmur? No. Sir was talking of inching. Did you see whether there was a murmur in the aortic area?
No, sir.
Or in the second aortic area?
No, sir.
Oh. Continue.
Carry on.
See, in this examination, even if you make the wrong diagnosis, even if you say if you say it is MS, and if you miss, and actually it is a mitral regression, then also you have not done anything harm to yourself. But the final only 1 marks or 2 marks which is devoted to the diagnosis will be deducted. But it is your approach. How will you be able to explain your findings and what and how you can analyze and you can justify? That is more important. You will get all those marks, but the marks of the wrong diagnosis, you will get 1 or 2 marks. So it is not a crime to make just the very wrong diagnosis because now the examiner patterns are different. Because when the examiners earlier, if you make one blunder and then your YY stops there, they will not ask anything. I think Dr. Sampath Kumar is here, so he will be telling more about this type of examiners when it was there in earlier days.
I
But
told
nowadays it is not there.
I told one of my students that if he doesn't know the answer to a question, to say he doesn't know, instead of bluffing. So when he failed, his wife came to fight with me. And she said, you told him to say, I don't know. And he said, I don't know. And you failed him. So I asked her, do you know how many questions? He said, I don't know. Out of 45, he had said, I don't know to 40. So that is very difficult to pass in a student like that. But if here in this mock examination, you can say, I don't know, and we will tell you why, and we will explain it to you. So it is easier for you to learn and go to the examination with confidence. Don't get nervous. Okay?
Okay. Continue.
Answer diagnosis. Case of valvular heart disease, mostly mitral stenosis and regurgitation of
Valvular heart disease, but etiologically mostly
rheumatic heart disease.
We'll have to justify each statement. Next,
Mitral stenosis and regurgitation.
you have to quantify each lesion.
Severe mitral stenosis with moderate regurgitation.
Severe mitral stenosis with moderate
mitral regurgitation.
And
is it simple mitral stenosis or something has happened to that mitral valve before?
So post CMV.
So it is re-mitral stenosis post CMV. And then?
In NYHA grade 3, patient in AF with controlled ventricular rate with no history suggestive of heart failure or infective endocarditis or thromboembolic episodes.
Can you qualify each statement? Why you said why? What was the first line? You said valvular. Okay. Why you said rheumatic?
So most common etiology for mitral valve disease is rheumatic, and plus patient had history of taking penicillin injections.
And what is the objective evidence according to you that it is rheumatic?
Something was done to her before.
Closed mitral was done. Number one. Number two, currently, what is the diagnosis?
Mitral stenosis.
What are the cause? You are having a mixed lesion, you are saying. Yes. Very rare to have a mixed lesion, and that too a stenotic mitral lesion. Non-rheumatic is very rare, no, especially at this age.
Yes, sir.
Then next, what was the pH?
Yes, sir, with pulmonary hypertension.
How much is the pH? You can't just say he has pH. Mild, moderate, severe. Everything has to be quantified as mild, moderate, severe.
Moderate.
Moderate pulmonary hypertension.
Yes, sir.
Now, can you please tell us why you said severe mitral stenosis? And what did you say? Moderate MR and moderate pH.
Sir, moderate pH because of grade 2
Start to the logical sequence. Severe.
Sir, severe mitral stenosis. Symptomatic patients, sir.
Severe MR is symptomatic. Severe AR is symptomatic. Everything is symptomatic.
Presence of mid-diastolic murmur.
How is the quantification of mitral stenosis, severity of mitral stenosis done?
Duration of murmur, sir.
Duration of murmur.
And narrow S2 and opening snap gap.
Did you mention anything about was there an opening snap?
No, sir.
So in the absence of an opening snap, what should you have done?
Duration of murmur, sir.
Duration alla. What is the surrogate for the S2-OS interval in the absence of opening snap? S2 to?
S2 to presystolic accentuation.
To the beginning. No, not presystolic accentuation. S2 to the beginning of the murmur. No. Was it wide? Was it small? You didn't give any quantification.
Madam, you said patient is in atrial fibrillation. We
didn't get and he got presystolic accentuation.
He did not get it.
So you are getting into more and more trouble.
See, in the examination, please be fully informed. Everything is for this patient. You're not talking theory. So everything is meant for this patient. You have said patient is in atrial fibrillation.
You said that now in what way did you conclude severity then? You have had no statement supporting severity of MS. And then another problem with the severe MS and MR, what chamber would enlarge?
Right ventricle.
Loudly, girl.
Left atrium. Sir.
Left atrium. जीने नहीं देता है, मरने नहीं देता है. Biggest LA is in a mixed lesion. But severe MS, LV would happen. What would have happened to LV?
Normal size. Sir.
Be small. But
Please
you are
speak loudly.
Small
Please speak into the mic.
LV will be small size, sir.
So now you are having a LV which is down and out, right?
Only down, sir.
Only down. You said fifth.
No, I didn't say down at all. He said out.
2 centimeter lateral to the mid-clavicular line. All the examiners were, their ears picked up like this the moment you said 2 centimeter lateral to mid-clavicular line. So there is enough blood flowing into the LV to make it large. You understand that is why Professor Yadav immediately pounced on you, saying tapping, gaping. Why everyone? The moment you said it, everybody's ears in the audience went up. You understand?
Yes, sir.
Carry on, go ahead.
Madam, please. Madam, please tell.
Continue. What is your provisional diagnosis? What is your differential diagnosis, if any?
You have a differential diagnosis, madam is asking.
No, ma'am.
No differential diagnosis.
Give us a complete diagnosis then. Patient is not in congestive failure?
No, ma'am.
No. So give us a complete diagnosis. You started off saying, go on.
Repeat the
Symptomatic
diagnosis.
mitral restenosis.
Yes, yes, ma'am. Mitral restenosis with regurgitation, a probability of rheumatic etiology in NYHA class 3, in AF with the controlled ventricular rate with the moderate pulmonary hypertension with no features of thromboembolic episode, infective endocarditis, or congestive cardiac failure.
And patient on anticoagulation.
Patient what?
Is the patient getting anticoagulants?
Yes, ma'am. He's on Septal.
Why moderate pulmonary hypertension?
Sir, I did not get.
Huh?
I didn't hear the question, sir.
Why did you say moderate pulmonary hypertension?
Parasternal heave.
Parasternal heave.
Loud P2.
Loud P2, which is palpable?
Yes, sir.
Palpable. What does parasternal heave indicate?
Right ventricular hypertrophy.
Or I will tell you, P2 is not. What is the other cause for a parasternal heave in this case? You think? I will tell you the whole chest is moving forward. Book, 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 or rather book, 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 like that.
Yes, sir.
Yes or no? What is it? Other cause of parasternal heave, you must think. You say, do you really get a loud P2 and without a palpable P2, but you get a heave? Usually, do you get it? No. You would have had a palpable P2 and then the heave if it was that. But here, you are not getting a palpable P2, but the heave is there. What could be the other structure? From anterior posterior, can you tell me from the sternum to the spine, what else is, what are the structures there?
Dr. Prasanna, may I request now, because we are short of time and we have to finish the entire spectrum, we have given a sense to the students of what is expected of them. So I think let's move on to how will she address and approach this case.
I'll just answer her question for her. The other thing can be the LA, isn't it? The LA and the RV. So even the LA may be large, giant, LA may be pushing up the whole heart. Okay, continue.
Okay, how will you, Kanika? Now What is your next step? You have made a provisional diagnosis.
So to confirm the diagnosis.
Madam, that's no answer. Come on, go on.
The chest X-ray, ECG, echo.
Okay, what do you want
That
first?
order. Okay, chest X-ray. Do you have them?
We have the other candidates for the investigations parts he can present. Can you show the ECG X-ray and all? Yeah, the ECG is on.
Oh, they are so faint, yeah.
Good morning. I would like to do certain investigations, including the ECG, X-ray, and the echo, to confirm and decide the grade of the disease, to decide about my further management strategy.
What are the findings in this ECG supporting your diagnosis?
Sir, I can see AF with controlled ventricular rate, sir.
Where did you look for the AF? In which part of the ECG?
The rate, ma'am.
Yeah.
In case of irregular
No,
rhythm.
no, no. And in this ECG, which trace did you look for to diagnose AF?
The last line, the rhythm strip.
Yeah.
So
what do you see there? Do you notice the RR intervals?
I'm sorry, ma'am, I couldn't hear you.
RR interval.
Yes.
RR intervals. Do you notice them?
Yes, ma'am.
Yeah.
Irregular
What they
RR
say?
intervals are present.
No, no, no. What do you mean by present?
So
Are
the
they regular,
duration between two consecutive RR intervals are not uniform. So you calculate the number of RR intervals
That's
present
okay.
over a 10
I'm not
second.
asking you the rate. Okay. And do you see any P waves at all?
Can you see P waves? Madam is asking, can you see P waves?
Yes, ma'am. Multiple
P waves.
P.
P.
So you don't see any P waves?
Yes, ma'am. It is not.
Okay.
We do not visualize P wave.
All right.
What do you see in the place of P wave?
What do you see
Don't
in
see
place
anything,
of
you
P?
say don't.
Sawtooth appearance.
No. What is the sawtooth ECG seen in what condition?
P wave gets replaced by some other wave. What is that wave?
Okay, let's go to the chest X-ray. Oh, sorry. What is any chamber hypertrophy you can see from here? Can you tell us the axis rate? You must be, fluent. They have had several sessions on ECG.
Yes, ma'am.
Tell us what the rate is, what the axis is, and everything.
For RVH, R by S in V1 more than 0.7, but here it is calculation came up to 0.6, so it's not indicated of RVF.
Very good. How does it help you in your diagnosis?
Sir, since I'm considering a diagnosis of severe MS, I would expect RA and RA enlargement and RVH. So this, if present, it would have supported.
You can't see a P wave, so how can you tell? But you also see the V5.
Yeah, V5 and V6. What is the ratio there?
Show?
Tall R waves are present.
Yes. What does that mean? How tall is it?
SV1 plus RV5 more than 35 will indicate LVH, sir.
What is it? What do you find?
So here it is elongated, but it didn't meet the criteria for LVH as well.
What other criteria is there? Just the R wave height. How much should it be for LVH?
There are overlapping waves in the later chest leads. Is there any procedure in the ECG that you can take which will give you a better idea? Can you adjust the voltage? Yes?
Does this patient have LVH? Simple.
No, sir.
So she doesn't have LVH, she doesn't have RVH, she has only atrial fibrillation. So how does that tell you she's got mitral stenosis?
And pulmonary hypertension and right ventricular hypertrophy. Shall we move on to chest X-ray?
Yes, ma'am.
Yeah, answers.
Dr. Hiramar, these ECGs, if you can have a photocopied, perhaps they can be seen better.
Madam, at our institute, we do have only soft copies. The photocopies has been stopped 10 years back only. We have a synapse system.
Okay.
That's been recorded. Yeah.
This is the chest X-ray PA view, well centered and exposed. The CT ratio is about 70%. Aortic knuckle is normal. The main pulmonary artery is prominent. Then the left heart border is formed by the RV, and double atrial shadow is present. The carinal angle is widened, both of which are suggestive of right atrial enlargement. Moving on to the lung field.
Carinal angle is enlarged and biatrial shadow is suggestive of right atrial enlargement.
What pushes up the left bronchus?
Left atrial.
Left atrial enlargement.
So how do you say it is left atrial enlargement or right atrial enlargement?
Pointer is it?
What is the criteria for ARIA enlargement? How much from the midline? How many spaces?
5, sir.
Right atrial enlargement. How do you say? How much distance from the midline and how many spaces?
3 spaces and 5 centimeters, sir.
So is it there? It is more than 3 spaces.
Yes, sir, it is.
It is easily 5 centimeters. I have no difficulty whatsoever in saying that this patient has got right atrial enlargement.
Yes, sir.
And how big is the left atrium? Can you mark the left atrial shadow here? Can you go to the X-ray and mark the left atrial shadow?
Go there. Pointer. Pointer kodappa.
Don't get worried, you're doing okay.
No, that's a torch. Take the mark it. Is that upper part? Then go further. No, don't go up. Mark it, no?
Yes.
Okay. And right atrial shadow? Carinal angle? Okay. Specific to this case, something about the left atrium, which you don't see?
The LA appendage will not be there because post CMV here.
It is not there.
We would see it otherwise.
Do you see any kind of a mustache?
Yes, sir. The lung fields I wanted to describe. Increased vascularity and there are Curly's lines also. I'm not able to appreciate in this X-ray, but the physical X-ray I could see Curly's B's lines.
Yeah, there are in this one.
And
okay, go on.
Prominent veins are present.
The veins
and
are
here there are, that is milk splatter appearances.
Peribronchial, not milk splatter, peribronchial.
Peribronchial cuffing.
Don't mistake, milk splatter is what Dr. Tendulkar told, no?
Yes, sir.
You also always mention about the costophrenic and cardiophrenic angles. You should always do that, huh?
Yes, ma'am. Costophrenic and cardiophrenic angles are free and clear.
Okay. What next?
So what is
another point which you have to all mention? Is there something peculiar in this X-ray? which has got implication for post-operative management. The diaphragm is pushed down.
Yes, sir.
How many rib spaces are seen?
1, 2, 3, 10, more than.
So what does this patient also have?
I think the counter posterior ribs, it's okay. No.
The ribs have become
COPD.
transverse.
Yes.
Emphysema is there.
COPD of it.
That is to add to your problems.
Yes, sir. Echo?
Yeah.
Do you want a lateral?
Yes. I would always love to have a lateral with a piece, little barium swallow. They have stopped doing that now.
This is the echo?
Yes, sir.
Where is the echo? Echo itself. We don't want the report. Where is the echo?
Just tell her, no? We are giving.
That's the echo report, madam. Yeah. We have
Many
not taken
places
echo,
would just give the report, madam. I may not give the actual echo recording.
Okay. That's all right. What is
In
it?
an examination, at least you should have an echo. Okay, go ahead.
What is it that you want to see other than the mitral valve?
The size of the LA, presence of any thrombus, because
Not there.
and the aortic valve.
Yeah, aortic valve is normal.
Yes, sir.
Mild tricuspid regurgitation. So do you think this is organic or functional?
It is probably functional, sir, because on examination I had not found any thrills.
Now, what about the clue from this echo? Is there any clue from the echo that says it is?
It does not mention any thickening of the tricuspid valve leaflets or any involvement. So I'm thinking it could be functional.
Also the RVSP.
55.
High.
Right ventricular systolic pressure is high.
Yes,
so
sir.
more likely it is functional.
Yes, sir.
Very good. So what are you going to do with this patient? Do you want any further investigation?
Since he's 40 years of age, that's the cutoff at our institute to do a coronary angiogram.
Okay.
To see the status of the coronary vessels. Following which I would like to proceed with a mitral valve replacement.
You said the patient is 30 years of age.
Yes, sir.
So why do you want a coronary angiogram?
It was 40, sir.
40, sir. 40.
Okay.
Yes.
Did you do a CAD?
Previously in 2005, a CMV had been done, sir.
No. Coronary angiogram.
So no, sir. They don't have any report as of yet.
Okay, all right. So what are you going to do with that?
Sir, I would like to plan the surgery. So for mitral valve replacement, the monitoring lines are placed, parts are painted and draped.
Would you like to do any tests for rheumatic activity?
Yes. Do you want to tell the patient anything?
Yes, sir. Okay. I would like to prepare the patient. So I will explain the diagnosis to him. And I will tell him that I would like to proceed with replacement of the mitral valve. And I would like to give him a mechanical valve considering his age following. And because of the implantation of the mechanical valve in the post-op period, he would require to take acetrom, and he requires constant monitoring throughout his life to maintain the dose. And I would also explain the risks of usage of anticoagulation. I would also tell him the availability of bioprosthetic valve, but in this stage we would prefer to go ahead with a mechanical valve. So I'll tell him the advantages and disadvantages of both.
Is there any reason why you would go for a mechanical, any other reason, go for a mechanical rather than a bioprosthetic?
Since he's a young patient.
No, any other reason in this patient?
This patient?
AF is there, and the echo also shows the probability of a clot. So I
No, the AF is there, so you will be putting the patient on anticoagulant. So the real advantage of using a bioprosthetic valve will not no longer there. You're going to give anticoagulants in any way. Is that a
You can't
okay? You
repair this
understand?
valve? Can you repair this valve?
So in the exam, I would like to say that since I'm a beginner, I'll go ahead with replacement or.
Never mind the exam. What would you like to do in this patient?
So I would examine the valve after opening and then decide the further
There's
whether it is
something you do
repairable or not.
before.
Is there any investigation before opening up? You can tell exactly the morphology.
Yes.
What are the things which are favoring or not favoring a repair? So essentially, they're asking, look at this report.
Sir, ma'am, there is subvalvular fusion of grade 3 in this.
Something else.
And the mitral
Valve is what?
Valve is calcific with fused commissures.
All that also can be done, repair. We have a different technique available, you can do that. But before opening up, we want to know the morphology better. Any investigation you would like to do? Which will tell you everything practically. You had several sessions yesterday.
TE, ma'am.
Yes. What do you look for in the TEE?
TE 3D echo. Huh?
No, 2D or 3D, it doesn't matter. You do TEE. What do you see? What do you want to see?
The movement of the leaflets.
Yes.
Commissural fusion if it is present, and thickening of the leaflets.
Yes.
And subvalvular apparatus, how involved it is.
You want to know how extensive the calcification is.
Calcification is.
Yes, sir.
Whether it's focal.
Sir, we are running short of time. Another 5 minutes we can assess, sir.
Okay. What kind of calcification excludes repair? If it is commissural calcification that is heavy, it is difficult to do a repair.
Yes, sir.
And then you must measure the anterior mitral leaflet length. What length will tell you it is possible to repair?
What do we measure every time?
AML height.
What is required for repair?
In the
21.
21, no?
26.
26, we keep.
It is 18 millimeters per meter body square or 26 millimeter absolute. If that is there, then possibility of repair is good.
Yes,
anyway, this patient is unlikely to have a repair.
Yes.
You will do a mechanical valve replacement. Now tell me how you are going to do the valve surgery quickly.
Medial sternotomy. Vertical.
Can you have the slide removed, please?
Pardon, ma'am?
No. Can we have the slide removed, Nico?
I'm the second person, ma'am.
No,
you
no.
want the first?
No.
You go ahead.
She wants
I can't
to
see you.
You keep talking.
Satish, can you go to the main Zoom screen?
Median sternotomy, vertical pericardiotomy. After this, I'll inspect the heart chambers. I would expect the RA, pulmonary trunk, and LA to be enlarged in this case.
No. You have forgotten something. This patient was operated before. So what's happened there?
Post CMD, I will expect adhesions. So initially, I would try to do the pericardiotomy over the expected aortic area, and the aorta and the RA appendage area I would like to clear first, so that I can cannulate, and then the other adhesions, if it's possible to release, I will. Otherwise, I would wait to go on bypass and then release the other areas, including the apex and the lateral part of the heart.
Why do you have to release the whole heart? Simple question. Simple answer is to de-air.
Yes, sir.
It's necessary to de-air the heart, so you want to release the entire heart.
Yes, sir.
You're correct. You will go on bypass, which will give you some time to release the heart, especially the left heart, without bleeding.
Yes, sir.
Then what are you going to do after that?
Once the aorta and the RA appendage are released, I would like to take purse strings with 4-O-proline on the aorta, the aortic purse string, and then I would like to take in this case, since the LA is large, that I know beforehand, I would like to go through the LA approach. So I would use a 2-stage cannula through the
Two-stager.
Two-stage.
Sorry, I would use a RA appendage cannula.
No way. You may need to do
Have you seen in your hospital 2-stage cannula ever being used for MVR? No, then why do you talk some things which you have not seen?
SVC and IVC cannulation. I would like.
Table cannulation, SVC, IVC, always for mitral valve.
Yes.
Because they may need tricuspid valve surgery. So you need to recannulate both SVC and IVC.
Yes, sir. Sorry, sir. Then I would like to take the purse strings for cardioplegia. And after the cannulation is done, I would, I will, before this, I would like to heparinize the patient to achieve an ACT of more than 450. After the cannulation is done, the aortic cross clamp is placed and cold antegrade hypokalemic cardioplegia is given to the root with topical cooling. Once the heart is arrested, the LA incision is made, extending from the upper border of the right-sided superior pulmonary vein up to the lower border of the right-sided lower pulmonary vein. Then after opening the LA, I'll examine the valve structures and I will decide about the retractor depending upon the space inside and the visibility. Then with adequate exposure, I'll visualize the leaflets.
You are going to inspect the left atrial cavity.
Yeah, sorry.
You want to see if there's any thrombus. If there is any thrombus in the left atrial appendage remnant.
Yes, sir.
You will do that first.
Yes, sir. I'll inspect the LA cavity, and if there is any clot, I would like to extract that, followed by inspection of the leaflets. I would see the morphology, and I would also like to see the underlying chordae and see how much of disease is there to decide about.
See the chordae unless you excise the valve. Either you do a commissurotomy and see, or you excise the valve cusps and then see the chordae.
Yes, sir.
What do you want to do? You plan to do a replacement.
MVR, yes.
About mechanical valve replacement. How are you going to do it?
So after inspecting, the first incision is placed at 12 o'clock position at the center of the AML. Then using a scissors, I will go around and disconnect the leaflets 2 millimeter away from the annulus. I would like to preserve the PML as far as possible.
What about the AML? You can preserve both.
You are not going to preserve any chordae from the AML? What is the practice in your hospital? Just tell us. It doesn't matter what you will do.
PML and the PML chordae are preserved if they're not involved.
So you don't preserve the anterior chordae?
Not everybody's. No, sir.
Okay, tell me, after you pass and become an independent surgeon, what are you going to do? Are you going to preserve all the chordae or only the posterior chordae?
Ideally speaking, all the chordae should be preserved if they are not deceased.
What are the advantages of chordal preservation?
Preserving the chordae will preserve the LV geometry. So post-op incidence of LV dysfunction.
There are six reasons for preserving the chordae.
Yes, sir. LV geometry is preserved, prevents early post-op LV dysfunction. Then LV rupture is prevented. And late post-op period, the LV remodeling is better if the chordae are preserved.
It doesn't
and LV function, if lesser, will improve if the chordae are preserved during the primary surgery.
What about the RV function? Does it help in the RV function?
I'm not aware, sir.
Yes.
Okay, sir.
preservation of the cardia, retains RV function.
Yes, sir.
And it retains the LV geometry. So there is no remodeling that's occurring.
Yes, sir.
To preserve all the cardia.
Yes. Then
Do you know of any other approach to the left atrium if you are unable to take the posterior approach, directly through into the left atrium for a better exposure? Do you know any other approach?
Approach, ma'am?
Yeah.
Okay. The superior LA approach can be used. There are different approaches other than the LA. If required, the two extents of the incision can be extended, or the
What have you seen in your hospital?
the transseptal.
Yes.
Describe the transseptal.
Don't hesitate. You say transseptal.
Yes.
You open the left atrium first. If it is not enough, then you can do a transseptal approach, or you can do a superior left atrial approach.
Yes, sir.
So what happens with the superior left atrial approach? What's the problem? If you don't know, tell me.
I'm not aware, sir. Visibility is very good, but the disadvantage.
Okay.
There is a place where you can go outside the heart.
The SA nodal artery traverses
Yes,
the roof of the left atrium. So if you cut it, you will develop problems. But in this case, already there is atrial fibrillation, so it really doesn't matter.
Yes, sir.
So how are you going to fix the valve? What sutures do you use? How many?
2O polyester pledgeted sutures. I would take first I will size the valve with the appropriate sizer, and then I'll take 2O polyester pledgeted sutures mattress. And
is it what you do in your hospital?
Yes, sir.
Okay.
Then once the sutures are taken, there are structures around the annulus that I'm going to be careful about not injuring when I'm taking the sutures.
What are they? And where are they?
What structures?
On the right side, near the right fibrous trigone is there, on near the posterior medial commissure, little beyond it. There the node and the bundle is present, so I would want to be careful.
How will you know you're inside the mitral valve? You're looking
I
at
have
it.
never seen anybody block the bundle in mitral valve replacement. It's too far away.
No, sir.
Have you produced something like that? Have you seen?
No, sir.
Complete heart block.
I have not seen, sir.
It happens if there is heavy calcification in that region.
Yes, sir.
And
if
what is
there
that region?
Calcification in that region, MVR should not produce complete heart block.
Yes, sir.
What is that region? That's what I was asking you. Where exactly will you be careful?
Right fibrous trigone, ma'am.
Now you tell me on a clock face. You know, a clock face, you said 12 o'clock, you're going to make the incision. Where is the bundle?
Or in relation to the
1 to 2 o'clock. Around 1 to 3 o'clock, I will be careful about the bundle.
And
Why did you say in relation to the commissures?
It's near the posterior, posterior medial commissure, ma'am.
That's why
And then coming down inferiorly from about 4, 5 o'clock to around 7 o'clock, I would want to be careful about the coronary sinus. Then
coronary sinus.
Yes, sir.
What else is there that's more important?
The LCX is more lateral, around 6 to 9, 10 o'clock position, sir.
Where is the aortic valve?
The iotromitral curtain is between around 11 o'clock to 2 o'clock position. There's the iotromitral curtain.
11 o'clock to?
1 or 2 o'clock, sir.
No. That's not where it is. What is between 9 and 12?
The anterolateral commissure, left fibrous trigone,
So what is there?
LCC, and then the NCC.
How is it related to the aortic valve?
The aortomitral continuity comes there, sir.
Yeah, that's right. So what can you injure over there?
The aortic leaflets.
You should be careful. But if your incision in the mitral valve leaves a little couple of millimeters of the mitral cusp, nothing
Yes,
will
sir.
happen.
You're safe.
Yes, sir.
Anything about the posterior annulus? You're preserving both the leaflets, so you're safer. But can you injure anything there?
The LCX and the coronary sinus are near to the posterior, ma'am.
Okay.
After you're finished placing the valves and tying it down, what are you going to do?
Test the valve with the tester that's provided with the
Correct. What orientation is ideal?
anti-anatomical for mitral position is ideal, sir.
Is it what kind of valve do you use?
If for a bileaflet valve, anti-anatomical. If I'm using a tilting disc valve, then the greater orifice should face towards the posterior.
Very good. What if you are using a bioprosthesis? What are you going to do? Where will the struts be? I said it this morning, so you should know.
Around 1 o'clock, 5 and 9, sir.
Yeah, okay.
Sir, I think we should close. Yeah.
Struts.
Thank you. I request Dr. O.P. Yadav sir to give the summation of the candidate report, sir, please.
Well, see, all I would say is that whenever a case is given, it should be broken. The time that has been allotted to you, you should optimally divide that time and must always keep some time to revisit the patient, revisit the history, and revisit your diagnosis before you actually go to the examination hall and face the examiners. So after you have taken the history and done the clinical examination, you should at least spend 5-10 minutes to see what is fitting into what and what is not fitting to find an explanation. And I still maintain, I'm not saying salient findings or salient history should not be said or should not be, brought forward. But some of these which are very subjective to what level the radiation is going, what is the type of the apex beat. Now, these kind of things which are very subjective, they should fit into your clinical picture and you should not give jarring notes. And the second point I would like to say is that the history taking should lead you to some diagnosis every time rather than just mechanically throwing out no history of this. No, everything should come out. For example, in this patient, we know that this patient is going to need a valve replacement. Now, it may sound trivial, but did we bring out, did this patient have any dental sensitivity, any discharge from the ear, nose, throat, any bleeding diathesis which contraindicated anticoagulation? These things which are extremely important in practical realm were missing from the history, which should have been brought forward and which the examiners will appreciate and will get an idea, look, this is a student who has not come from the books, but has come from the wards and from the patients. So my request is only that before you go into the exam, keep rehearsing to your fellow students. Let one or two of them act your examiner, and you present the case to your fellow student who acts as an examiner, and then reverse the role. He presents a case and you act as an examiner, and things will change. So those are, few things, and everything should be practically relevant to this particular case.
Yes.
Yes, we will give the marks, but overall, it could have been better, especially the history taking and the explanation of the physical findings. Management, I would say, was slightly better than the first part.
Thank you. Thank you, sir. I think we'll go with the next case. Yeah.
Next case is also a valve.
It's a thoracic case, sir.
Oh.
I
Thank you,
request
sir,
Dr.
and
Elizabeth
thank you, ma'am,
Kanya.
for chairing the session. For next case, I call upon Dr. Srinivas from Apollo, Chennai, Dr. Vinay Malhotra from National Art Institute, New Delhi, for thoracic case presentation. The examiner for the session are Dr. S.V. Shri Krishna, Professor of Thoracic Surgery in Narayana Hridayalaya, Dr. Ali Zamer, Consultant Thoracic Surgeon, London, Dr. Ravindra Kumar, Director and Professor of National Institute of Respiratory Disease, New Delhi, Dr. Shiv Kumar Swami, Professor and Head Thoracic Surgery, Rajiv Gandhi. So there's a candidate assessment sheet given for evaluation and time limit is 1 hour.
Good afternoon, ladies and gentlemen. I'm going to present a thoracic case. 22-year-old girl, Renuka, coming from Coppola, presented with complaints of fever and cough for the past 3 months. Coming to history of presenting illness, she's having fever for the past 3 months, which is low grade, more commonly in the evening time, relieved by medication. The fever is not associated by chills and rigors. Cough is present for the past 3 months. It was insidious in onset and gradual in progression. There is no seasonal or diurnal variation or postural variation. It is not associated with any sputum. There is no history of any blood in blood while coughing. She is giving history of mild breathlessness on an exertion, about NYHA class 2. There is history of loss of appetite, but she is not giving any history of loss of weight. No history of any chest pain or wheeze. No history of any diabetes, mellitus, hypertension or asthma. No history suggestive of any congestive cardiac failure. On evaluating the history, she is giving a history of cough with expectoration 1 year back, 1.5 years ago, for which she was evaluated in another hospital and diagnosed to have tuberculosis, for which AKT was started. She received the treatment for 8 months, and after the end of 8 months, she was sputum negative. But after again 1 month, she became sputum positive and again took the treatment for another 6 months. And finally, she became sputum negative in December. Now she was evaluated again in a hospital and started again on ATT in March. She's giving history of needle aspiration of fluid from the chest. She's family history, there's nothing significant. Personal history, there's no history of any substance abuse. She's not giving any history of allergies.
Dr. Zamir has just joined us. Hi, Zamir.
Hi, how are you?
Oh, can you just summarize?
Did you start early? Did you start the case early?
No. We were on time, I think. Okay. Now, can you summarize the whole history in 2 lines?
22-year-old girl who's having currently fever and cough for the past 3 months, whose earlier was on ATT, and she's again been started on ATT. So she's mostly having infectious pathology of the lung.
Fever and cough for
the past 3 months. Yes. With past history of ATT intake.
Okay. No history of hemoptysis.
No history of hemoptysis.
Right.
Weight loss? She's giving history of decreased appetite, but no history of weight loss.
Okay. Go. Okay, Zamir. Okay, carry on.
Sorry. Yeah, carry on. I've just joined. Let me catch up.
On general physical examination.
Hold on. Yeah, go ahead. Zamir.
No, let him carry on.
Okay.
On general physical examination, the patient is conscious oriented, moderately built and moderately nourished. She is afebrile to touch. Pulse rate is 90 per minute regular, normal force and volume, no specific character, no radial or radiofemoral delay. BP is 110/17 right arm supine position. Respiratory rate is around 18 per minute, abdominothoracic type, no accessory muscles of respiration are used. JVP is not raised. Saturation is 95% on room air. No pallor, icterus, cyanosis, clubbing or lymphadenopathy or pedal edema. Our ENT examination is normal. There is no spinal or back deformity. Coming to systemic examination of the respiratory system, on inspection, I examined the patient in sitting, standing, head on the waist and head on the hands on the waist and hands on the head position. The chest appears to be bilaterally symmetrical with abdominothoracic type of respiration. No accessory muscles of respiration she is using. I could appreciate decreased movements of the left side of the chest. The trachea appears to be shifted towards left side, Apex beat is visible in the left fifth intercostal space, just inside the mid-clavicular line. I could not appreciate any scar sinuses, dilated veins. On palpation, it's not warmth, no tenderness. I could not appreciate any lymphadenopathy. Inspectory findings are confirmed. Trachea is deviated to the left side. On the chest expansion is reduced on the left side, and the tactile femmeters is also reduced on the left side, mostly in the mammary, inframammary, axillary, infra-axillary, and infrascapular areas. On palpation, I could not appreciate any lymph node enlargement. Percussion, the right side there is a tympanic node, while the left side mammary, inframammary, infrascapular, and infra-axillary areas I could appreciate a stony dull, while other areas it was relatively dull on the left side compared to the right side. On auscultation, normal vesicular breath sounds are present. Air entry is decreased on the left side, mostly in the lower zones, the same inframammary, infra-axillary, and infrascapular areas. The vocal resonance is reduced on the left side. No other added sounds I could appreciate. Coming to other system examination, S1, S2 present, no murmur. Per abdomen soft, non-tender. Bowel sounds present. I did not do a PR examination. CNS is conscious oriented. No focal neurological deficit present.
So can you summarize your clinical findings?
On clinical finding, I could appreciate decreased movement on the left side of the chest. Then on palpation, the chest expansion was reduced. Then the vocal femmeters and the tactile femmeters both are reduced on the left side, and there's a stony dull note on the left side. And the trachea is also deviated to the left side. According to me, she is having left side tubercular empyema with underlying collapse in NYHA class 2.
Fantastic. How do you know it is empyema?
She told the needle aspiration was done in a history, which they got pus from that aspiration. The patient gave history of needle aspiration. And
okay, now she's got an empyema in a patient with a fluid. Say, it could be effusion or empyema. What would happen to the venous time? Would it be shifted towards the?
It could be shifted opposite to the side of the effusion.
So why do you think the patient?
Because she's having an underlying collapse, so the trachea is shifted to the same side of the collapse.
There would be collapse, or it's a long-standing.
Long-standing disease because she's already taken ETD for 1.5 years.
So can I ask you a question, please?
Sure.
You told me you think she's got tuberculous empyema. Why did you use the word tuberculous? How do you know from your clinical findings and history that this is tuberculous?
He's giving history of ATD intake for the past 1 year. She was started on ATD 1.5 years ago. So it's most likely that she's the underlying pathology is tubercular, and it's the most common cause in our developing countries.
What else can present with this sort of clinical condition?
She can have post-pneumonic pleural effusion or empyema, syn-pneumonic or paranpneumonic effusion empyema. And other causes of empyema can be iatrogenic or trauma with post-traumatic, and they can also be migrate from diaphragm.
Don't talk from theory. There could be 101 causes of empyema, but you are talking about this patient. As everybody, all examiners have always told you, talk about this patient and what you will do for this patient. Okay. So tuberculosis is a possibility.
Yes, sir.
A fresh new pneumonia with symptomatic effusion is a possibility.
Yes.
Okay. That is what
It could have migrated from subdiaphragmatic abscess or mediastinal pus can migrate from adjacent areas.
Anything else?
Oh, that's good.
One comment I wanted to make. You said I did not do a PR. Would that give you any extra information in this particular patient? No, just because morning Zamir said you have to examine external genitalia. So don't go on to something irrelevant things and get into trouble, because that is what is going to be this thing. So just stick to the point. Okay. So now what is your diagnosis?
The she's having a left-sided tubercular empyema with underlying collapse consolidation.
You have decided it's tubercular.
Most probably tubercular.
Do you want to have a differential diagnosis or anything else?
She could have a parapneumonic effusion which has gotten infected.
So now how do you go about this patient?
I would like to investigate the patient. First, I would like to do routine blood investigations and then chest X-ray of the patient.
Don't stop. You know, you said you like to do routine blood. So tell us what routine blood investigations you'd like to do.
Routine blood,
and why? Why would you like to do whatever you would like to do?
First, we'll do hemoglobin and WBC count. If it's a pneumonia, her WBC count will be raised and the polymorphs will be more. While in case of tuberculosis, the lymphocyte count will be more. And we'll do a liver function test because if we have, since the patient is on anti-tubercular drugs, they can impair liver function test. We'll also do a renal function test in case she has to undergo a contrast CT or something like that, and chest X-ray POU to see what.
Would you like to do a sputum examination?
Actually, the patient is telling she's having no sputum associated with cough.
Yes, sir, you have to do.
Yes.
If the patient is not able to do that, what other ways of trying to get a sputum examination?
Early morning nebulization and saline nebulization.
Early morning, we can give the patient nebulization and give us saline nebulization and give her a container to.
What is the importance of doing sputum examination?
If the sputum is AFB positive, or we'll send the sputum for AFB test if it's AFB positive, or any other organism she has.
Once your differential diagnosis is pneumonia, could be a bacterial pneumonia.
Can you have a better audio? Can you speak into the mic, please? Not audible. Not clear.
You can remove this and stand if you want.
Go on.
And I would like to do a chest X-ray of the patient.
Good. You want to?
Can we have the X-ray? Does he do the whole thing, or the other candidate takes over?
I'll take
one. That's the next one. Okay.
Mike.
Who is the next candidate?
Myself.
What's your name?
Sir, Srinivas. 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 Yes.
Sir, plain chest X-ray, PA view. Trachea is deviated towards the left side. The lower zone of the most of the lung is the lung is not seen. The lung is collapsed towards the mediastinum, and some lung is seen on the upper part of the left zone also. The right side of the chest is hyperinflated. The mediastinum also is shifted to the left side.
So stop for a second. You said there is lung seen in the upper part on the left side. How do you know there is lung there? How do you identify if there is lung or is it air? What is the differentiation?
Sir, there are bronchovascular markings are seen.
Can you see bronchovascular markings on the left upper zone?
Yes, sir. Yes, sir. Little bit I can see, sir.
You can? Okay. Maybe I can't because it's okay. Carry on.
Do you think this is an acute process or a chronic process on this X-ray?
Chronic process, likely. Why
do you say so?
Because the acute pleural effusion will have a crescent-shaped effusion like that, but this does not have any characteristic shape of the effusion.
No, the crescent shape will be there only if there has been no intervention. He's already had a pleural tap.
Yes.
So that doesn't come. What else is striking there?
It's the intensity is looking very thicker.
There is collapse.
Collapse of the underlying.
There is loss of volume of the left hemithorax.
Yes, sir.
Okay.
Trachea is also
the
trachea is some
the
pulled
whole
towards the
mediastinum is shifted
to
my question to you.
Yes, sir.
I can't see the.
There are two things.
Yes, sir.
There are two things which I want you to talk about. One is what is happening to the left main bronchus, and number two, what is happening to the right lung? You have not told us that.
So right lung is hyperinflated. I mentioned that,
Good.
sir.
Okay.
Is there herniation to the opposite side?
So this is the border of the right lung. That becomes
from there.
And what is happening to the left main bronchus? Hello, can you hear me?
So I'm not able to see the left main bronchus. It is acutely cut off at that level.
Yeah, so you have to say it is acutely cut off, isn't it? Can you see, you can see the left main bronchus, but it's acutely cut off. Now tell me, why do you think the left main bronchus is acutely cut off?
Because
what are the causes of the left main bronchus being cut off?
Because there is no ventilation happening towards that side of the lung, because it may be completely collapsed. The second thing is that the bronchus must have been completely filled by the secretions from that side of the lung, or there can be something obstructing the left bronchus at that level, some intrabronchial mass or something like that.
So what would your next investigation be in this patient?
So I would like to do CT scan, contrast enhanced CT scan test.
Okay. What about the heart? Can you comment on the heart on this X-ray?
So the heart lateral border is completely merged with the adjacent shadow. It cannot be differentiated, but it is definitely herniated towards the, it is shifted more towards the left side.
The entire heart is in the left hemithorax. You can see the spine completely, isn't it?
Yes, sir, I can see.
So the entire heart seems to be on the left side.
Yes, sir.
So would you be happy to put a needle into this chest to aspirate fluid?
No, sir, unless it's ultrasound guided, it is dangerous, sir, because we don't know.
Yeah, but you said somebody aspirated this chest, isn't it?
Yes, sir, yeah.
Do you think that's the right thing to do? Aspirating this chest on a chest X-ray?
Maybe if they have done by ultrasound and then loculated where the pleural, where the effusion is, maybe.
Very dangerous, very dangerous. You might end up in the heart. Very careful. Okay, so CT scan, let's see the CT scan.
CT scan is there?
We can't hear him.
Sure.
Do you want to do an investigation before CT scan? Do you want to do a lateral view of this patient or no?
Yes, sir.
Will it give you any further information?
Yes, sir. We can see the structures anteroposteriorly.
Okay. All right.
One more thing you should remember in your practice. This patient has had a history of tuberculosis, treatment for over a year. So you must always ask for previous X-rays and things if they have.
Yes, sir.
Okay. Make sure that you see the previous investigations and previous X-rays. That will give a clue to you how this disease has progressed to this stage.
Yes, sir.
Always remember that.
Sure.
In fact, it's the most important point when you see the chest X-ray. You should say, can I see the previous imaging, please? In the exam, all the students, please remember this. As soon as a chest X-ray is shown to you, you must say, can I please see the previous imaging? Okay, carry on.
This patient, last 10 years back, she has taken ATT, and again she is taking once again.
Yes, sir.
Very important.
Just the previous reports.
Sir, plain CT scan of the chest. We are seeing the mediastinal window. This is the chest X-ray film. Starting from the upper, starting from the cervical region, we are coming down. You can see the left trachea there. The left, that main trachea there. The trachea is going towards the left side. The right lung is starting there, very high up in the right thorax. Then here I can see the consolidated and compressed lung there, which is completely surrounded by loculated thick effusion all around. And the right lung is very much hyperinflated, that has crossed the sternum and come onto the other side. And
It's called herniation.
Herniation, yes.
Okay, at this stage, would you like to review your diagnosis?
Sir, this is tubercular fibrosis of the left lung with effusions, with the empyema.
Do you think? I don't see any empyema.
Where is the empyema?
I don't see any empyema.
This one.
That's outside the chest. It's outside the chest wall that you are showing. That's the reason I asked you, would you like to review your diagnosis? Just see what else you see on the left side.
So this is all, it's like a consolidated lung only, sir.
What happens in tuberculosis, long-standing tuberculosis? Consolidation. There's collapse and consolidation of the lung
with fibrosis.
With fibrosis, which has shifted the whole mediastinum to the left heart, with herniation of the lung to the from the opposite side. So what do you call this situation?
Destroyed lung, sir. TB destroyed lung.
No, not TB, just you are not come to
destroyed left lung.
This fits into a destroyed lung, actually.
Yes.
To the left side, of the left side.
Yes.
Now, what would you do?
I would also like him to talk about the left chest wall. You know, you've spoken about destroyed lung, you've spoken about herniation of the lungs and the heart.
I would like to see the other
the ribs.
I would like you on the CT to describe the left chest wall. What's happening to the chest wall? Yeah, the ribs.
Can I see
What's
the
happening to the ribs?
cuts of the CT scans?
Sorry?
Can I see the other views of the CT?
No, on this one, what is happening to the ribs on this one? Compare it to the right side.
Compared to the right side, it looks crowded on the left side, sir.
Yeah, I want to hear the words ribs are crowded. Why is it important that word ribs are crowded?
We said that there is
why is it important?
Volume on the left
lung, left side, loss of volume on the left side.
Rib crowding.
So why is this information important?
That tells that the underlying lung is fibrosed for a very long time.
Okay, that's one. And number two, as a surgeon, why is this information important?
Sir, that it is like thoracoplasty has already happened, and the underlying lung is compressed by the chest wall.
Don't use words like thoracoplasty. Why is this information important to a surgeon that the ribs are crowded?
if we have to intervene on the left side, then our space is limited to.
Yes, absolutely right. It's going to be very difficult access into the left chest. You might even have to cut a rib to even get into the chest. Okay.
Yes, sir.
It's important to tell me these things.
What other precaution you would do if you want to do a thoracotomy? Can you do a normal standard posterolateral thoracotomy, or would you be careful and enter the chest in a particular way?
Sir, I would like to collapse the lungs before entering the lungs, so that
the lung is already collapsed here.
The opposite side of the lung.
Then how is he going to survive?
Patient will be dead. Patient will be dead.
Just for a few seconds.
What for?
Little bit of space I can get.
Because it is adherent, it can't move.
Hey, listen, don't dig your own grave, man. Come on.
Thing is that the entire mediastinum is on the left, and there is very little space. And there is a possibility, because of the herniation of the lung, there's a possibility of opening the opposite pleural. So that is why you have to go in the posterior aspect of the chest cavity for entry. Make sure that you're in the space and not injure the heart or the opposite pleural. So this is important for it. Now, does this patient require surgery? The whole lung is already gone. There's no problem, nothing. It is an auto-pneumonectomy done.
Sir, if this patient is having multi-drug resistant tuberculosis, which is very difficult to treat medically, then there is some role of surgical excess in that part of the lung.
How do we know that he needs further treatment? He's had 1.5 years of medical treatment.
She's again, sputum is getting passed too, sir.
She's positive?
Yes.
Oh. Not sputum, it is a bronchial lavage.
Bronchial lavage.
So you have done it. You will need to do a bronchoscopy. Bronchoalveolar lavage, and you will see whether she is still positive.
Yes.
What else you would like to see during the bronchoscopy?
I will see if there is any intrabronchial mass, and I will take the cytology and then send it for the cytology. And culture.
Bronchopleural fistula.
Fistula, where the fistula?
No, where's the fistula?
Culture of the bronchial lavage to find out any other organisms that we are
That's
missing.
okay. All right, you've done a lavage. What else are you interested as a surgeon? You are the surgeon.
It's a very good question. Tell us on bronchoscopy, why? What are you looking at on the left side?
One thing I told, intrabronchial mass pathology that we have to find out.
No, we got that.
Other than mass, anything?
As a surgeon, what are you looking at?
What are you planning? What surgery will you plan in this patient? Decortication?
Decortication.
Yes, sir.
What surgery can be done?
Have to see the bronchial branches and the supply to the bronchopulmonary segments.
So I'll follow the bronchial tree during the bronchoscopy. I examine the sequentially the.
Who said decortication?
No, I'm just needling it. Sorry. Okay,
It's a very good question, actually. It's a straightforward question. What are you looking at bronchoscopy? As a surgeon, what do you want to do for this patient? What are you going to look at? Come on.
Shows the report, bronchoscopy. You want to see the nature or the condition of the bronchus. If you have to rule out endobronchial tuberculosis. Because if you have to do a pneumonectomy on this patient and you're going to section the bronchus, that will have to heal. Otherwise it will end up with a BPF.
BPF, condition of the bronchus.
So the indication for bronchoscopy in this patient would be one, for a lavage to get some specimen, whether there is active disease going on. Second, the nature of the bronchus at the site of your section.
Bronchial section.
So before
this is a very, very
Sorry, tell me.
No, this is a very important point. This is a very important point which Sri Krishna has mentioned. In the exam, I don't know why you're not coming out with it straight away. It is just direct answer that one is lavage and number two, to see the left main bronchus. Very important point, because that's where your pneumonectomy stapler is going to be.
Yes. Now, coming back to my first question, what stage? Last time. Coming back to my first question, does this patient require surgery and how will you go about it? Morning, Zamir said various things to assess before surgery.
Fitness for the surgery.
There are three things that you should answer in every patient. One, does this patient require
surgery? Does this patient
is he
fit for the surgery?
And third, is the surgery going to improve
Outcome.
what you do? If not, you have no, if the answer is even no for even one question, you have no business in touching it. Okay?
Yes, sir.
So now you have to know, okay, this patient may require surgery.
Yes, sir.
What is the primary thing that you will look for before even deciding about surgery?
Sir, I will see a post-operative pulmonary.
Sorry, sir. Before that.
Before that, I will see a cardiac fitness.
You've only seen mediastinal
window.
pictures. Would you like to see the opposite lung?
Yes, sir.
And make sure that the opposite lung is healthy.
Well, healthy.
Then
yes.
only you can operate on him. No?
Yes, sir. Definitely.
Look for the opposite lung.
Next film.
See, one of the things we said is look at the lung window and the mediastinal window. So please look at both.
Yes.
We know tuberculosis can affect bilaterally.
Yes.
Right?
Yes.
So both the lungs can be involved.
Yes.
So if you have to knock off one lung, you have to make sure that the remaining lung is normal. All right, all of you.
Next film, please. The right side lung is hyperinflated and it looks healthier, sir. There is no signs of fibrosis or any disease.
Okay, it looks all right. Fine. Now, what's your next step?
I'll do bronchoscopy, sir, as you told, and those things. And if you have already done that, then I will.
The bronchoscopy, again, remember, bronchoscopy should be done by the operating surgeon. You will not accept somebody else's report. Okay?
Yes.
If you have to either do it preoperatively yourself or on the table, you will make sure that you will see the bronchus yourself. Remember this all your life.
I would like to do a contrast enhanced CT to see how the adjacent structures are related to the fibrosed lung. Then,
so what else in your assessment? Zamir told you in the morning. Preoperative assessment.
Sir, to see the fitness for the surgery, the routine blood investigations, hemoglobin, WBC count, platelet count, all those things. Then I'll look for the cardiac fitness. I'll take an ECG. And if there are any abnormalities or if there are no murmurs for this patient, she is young female. So if the ECG is normal, then I don't think echo is, echo is needed because the heart is shifted towards the other side.
Yes, there is growth.
Absolutely. Echo is mandatory here.
Have to do an echo in this patient.
Yes, sir.
Okay?
Yes, sir.
What for?
So to see any associated lesions that we are missing in the this one. Compression of the chest wall. Constrictive pericarditis by the tuberculosis that has affected from the left lung.
And because of the gross shifting, you can have structural abnormality and valvular regurgitant lesions also. It's possible.
Yes, sir.
You have to look for pH and RARB function here.
pH. Sir, after that, I will do the stair climbing test, shuttle test, and see her physical activity, how is she able to perform. Then I will.
Tell me, how will you calculate? Samir told you a formula in the morning.
Yes, sir.
How will you get? How many segments are there on the left side? How many segments are you removing?
Sir, left side there are 8 segments are there, sir. Because the right side is completely sorry. Right side there are 10 segments are there, sir. The left side is already destroyed. So
how many segments on the left side? Please repeat. How many segments on the left side?
9 segments.
9 segments.
I thought I heard 8. You said 8.
You said it.
Well,
okay.
There is controversy about that as well. Okay, but
yeah, but common things is 9.
People, when you're calculating post-operative pulmonary, I mean FEV1, you always take it as 9.
9. Okay.
Okay, 9 segments.
Yes.
Because although anatomically apico-posterior is one
Yes,
segment on the left side,
yes, sir.
but they're still considered as 2 segments,
2 segments
for calculation of the
post-operative, predicted post-operative FEV1. Sir, I would do pulmonary function test, see how is our FEV1, FEC, then I'll do DLCO, see how is our diffusion capacity.
Okay, let's assume everything is fine. Young patient, all right. You want to do a pneumonectomy in this patient?
Yes, sir.
Okay. How will you go about a pneumonectomy?
Sir, left posterolateral thoracotomy.
What is your anesthesia? What technique?
Sir,
what are the
okay.
things that you're going to do? You
Sir,
just
patient is-
you just go and slash him up like that?
Sir, patient is positioned in right lateral position after double lumen endotracheal tube, confirming the position of the double endotracheal tube by bronchoscopy.
Will you put a left-sided double lumen tube or a right-sided double lumen?
Right-sided double lumen tube, sir, because it should not come in my way of the bronchial resection this side.
Very good.
Sir,
What is the difference between the two?
the Murphy's eye
Very
will be there for the right-sided one.
All right. Fine. And you will confirm it by bronchoscopy, that
Bronchoscopy.
you have placed the tube
Properly, and then
Okay,
the
left thoracotomy. Then what else?
left thoracotomy, I'll release the adhesions. There are like 2 ways of doing it, sir. Some people, if the conventional way is that I'll release all the adhesions from the surrounding the chest wall, and then I'll after releasing all the adhesions from the mediastinal the peritoneum also, pericardium also. Then I'll divide the inferior pulmonary ligament and dissect the mediastinal structures. Then I will loop the pulmonary artery, pulmonary vein, and then.
Can I ask a question, please?
Yes.
Sure, please go ahead.
So one of the things that I told you when we look for qualities in a surgeon is that he is a safe surgeon. Okay, that is the first quality. I want to make sure that he is safe surgeon. So in this patient, you have not told me anything in your preoperative management anticipating a complication. You know, what is the commonest complication you'll have in this case? What is the most likely complication you'll have while operating on this patient?
Sir, the entering of damage, entering the pericardium and the heart is
the most. What is the most likely complication? Bleeding, correct?
Yes, sir.
Is that correct or no? Okay.
Correct,
So
sir.
as a safe surgeon, before you start this case, is there any precautions you want to take to make sure that if you get into trouble, you have a backup or some way to save this patient's life?
Yes, sir. From the history, I'll see for the bleeding diagnosis in the investigations. I'll see for the bleeding time, clotting time, INR. And just before starting the case, I'll make blood grouping and reserve adequate units of blood before starting the.
So that's one. Make sure enough blood is available.
Blood is in theater.
Is in the theater before
you do it.
Yes, sir.
Second, what else will you do to make sure you don't get into trouble?
Something else can happen very easily in this patient.
What else will you do, my friend? You're working in a cardiothoracic unit and you're doing this case. What are you going to take precautions before you start this operation?
Supposing you're doing a redo CABG, what are all the things that you do on the table?
Sir, I'll see for the peripheral cannulation sites and prepare it, drape it, and then expose it before starting the redo.
And this patient can very well go into arrhythmia, BF.
Yeah, external defibrillator
You
part
must
should
have
be
an
there.
external defibrillator on table. Okay.
What about the bleeding? What precautions will you keep standby if you run into severe bleeding? Is it a difficult question?
Cardiac surgeons is simple.
Sir, we'll have to give the tamponade and we have to go for the proximal control of the bleeders.
Yeah, but there is all adhesions there. You will not get any proximal control in this situation.
Then we have
So
to.
before you start, what will you do? Would you like to keep a bypass machine ready somewhere around in the
Yes,
unit?
sir. Yes, sir.
Okay. Would you like to prepare the groin and keep before
Yes, sir.
you
For
start the
peripheral
case?
cannulation. Yes, sir.
Would you also like to speak to a cardiac surgeon and keep him standby in case you run into trouble?
He himself is a cardiac surgeon.
I'm a cardiac surgeon.
Yeah, but I mean, this is a thoracic case. So I am assuming if things go really bad, you will need a second person to help you, isn't it? To go into bypass and all that.
Yes, sir.
So always, you have to keep standby. See, when you talk about a case like this, it's not about how to do a pneumonectomy. It's the precautions you're going to take before you start the case. That tells me that you're a safe surgeon. It's not about, running into trouble and then calling for help. Then the patient will die. This is exactly the principle I told you, that before you start the case, all this must be in place. So please think that way. Okay, think like a surgeon, think like a consultant, and talk. It's not about the inferior pulmonary vein and superior. It's about how you make sure this patient comes alive on the other side.
Yes.
Okay, carry on. Please carry on.
All right, we have got all that. Now we have mobilized the lung. What next?
Sir, I'll go from inferior pulmonary ligament. I'll release. I'll mobilize the lung. I'll loop the from anterior to posterior. I'll loop the pulmonary artery, and then double ligate.
After releasing the inferior pulmonary ligament, you will go around the hilum in front and the back, the mediastinal pleura, so that you expose the hilum well, and then you will try and access the. Remember, this is a chronically collapsed, consolidated lung with a lot of fibrosis.
Yes.
The anatomy is totally distorted. It's unlike cardiac surgery. The minute you open the pericardium, everything is free and everything is visible to you. This is a totally different scenario.
Yes.
Okay. So you have to literally dissect each and everything, go step by step, step by step. And many a time you may have to have an intrapericardial control as well.
Yes.
So first thing is you will try and loop the pulmonary art. Okay.
Yes, sir.
Is there a difference between right and left pneumonectomy?
Yes, sir. The right side, there is epicardial bronchosis there.
You will not bronchus first. We generally loop and ligate the pulmonary artery first, isn't it?
Yes, sir.
Why?
Because the bleeding towards the throughout the surgery is less if you have ligated the pulmonary artery first.
Is that right? Oh, is that the reason?
there any anatomical difference between left and
And
right?
it is anteriorly accessible structure.
Supposing you're doing lung cancer.
Lung cancer will preferentially ligate the pulmonary veins.
No,
So,
sir.
sir, pulmonary artery first, because the metastasis will not happen. Like when handling the lung, the tumor cells will not go.
So
out
it
of-
goes, that is why you have to ligate in
pulmonary.
principles of cancer surgeries, you ligate the vein first.
Yes.
So that it doesn't disseminate to the circulation.
Yes.
But here in the lung surgery, we generally go to the artery first. Why? You must know.
Bleeding throughout the surgery.
No, because if you ligate the pulmonary vein first, and the blood will still keep coming into the lung. So the lung gets more and more congested.
Congested also. It's
And
easy to handle.
Yeah, the handling will be difficult. That is why we always do the artery first and then the vein. Although in the present scenario with VATS, you will go through whatever comes first, whether the artery or the vein or what is this thing. That is the norm now. But in the earlier, in open surgery, in a case like this, you will try and get the artery first.
Yes.
Shri Krishna, can I ask a question, please? Hello?
You are one of the examiners. Go ahead.
Yeah, so before you do this pneumonectomy, I still want to take a step back. You know that you are dealing with chronic tuberculosis and you think that there could be endobronchial TB on the left main bronchus.
Yes, sir.
So when you start making your incision,
I will
what are you going
harvest
to
muscle flap.
think? You will harvest what? Sorry?
Intercostal muscle flap.
Okay, intercostal will be a little difficult because of the crowded ribs. So any chest wall muscle you want to
That
sort
is
of
dorsal muscle.
well, serratus you can actually
Serratus.
preserve and try and make sure that serratus is okay. Also, if you can preserve some part of the latissimus dorsi, you would make sure that you would preserve. What are the difficulties you will have to enter into the chest? Tell us about that.
So the adhesions are there. That is one thing that we have to clear out the adhesions before.
No, outside. You're doing your
ribs are crowded, so we don't have much space to enter.
So what are you going to do?
We have to do the rib resection. Sir. Rib resection.
Okay, so I would mention that in my operation that I would need to do a rib resection and I would harvest the muscle before I start doing the pneumonectomy. Okay, sorry.
Running out of time, last 3 or 4 minutes. Zamir, you can ask whatever. Okay.
No, it's okay. Carry on. You take over.
Assessments are for the students.
My feedback. Okay.
All things.
You want to give him a feedback, Zamir?
You start and I'll follow you.
Well, the history and presentation was okay. All right. As I said, you stick to relevant things. Okay. Don't talk some rubbish things unnecessarily and sidetrack the examiner because he will catch on to you and you'll go out in a fully tangential way. Okay. And as we said in the morning, keep a steady track and think you are the surgeon. You're not appearing for an exam. You are the surgeon and what you are going to do with this patient. This is how you will think and go about everything. Okay, the assessment has to be exactly in that manner, whether the patient is safe for surgery and whether the surgery is safe for the patient. This is the most important thing. As Zamir said in the morning, you have to have a live patient when you go get finished. All right. So make the patient safe for surgery and surgery safe for the patient. That is of prime importance.
Yes.
Second, make sure that all your things are kept available, ready in the theater before you
start the this.
And make sure many a time, many centers don't have blood in the theater when we start. Yes. Because it is not relevant in a cardiac patient because I know I've been in both.
So I've been doing both. So cardiac patient, you can still go on pump quickly, and you have here the advantage of going on pump with hemodilation, but you don't have that luxury when you're doing a badly stuck lung on the thing. Okay.
You have venous bleeding and you go on pulmonary vein bleeding and you go on cardiopulmonary bypass with pump.
Here into the
So you have to have blood in the theater and all the other these things that we said keeps CPB standby. Many a time you may have to go intrapericardially to take control of the vessels, both the artery and vein. And we didn't go about the bronchial closure. That is an important step. Maybe we should talk about a couple of minutes on the bronchial closure. What do you think, Zamir?
Yes, please.
See, nowadays, many people will use a stapler, okay, for bronchial closure. In the olden days, we used to do hand sewing technique, the various techniques to close the bronchus. One was used to be a simple suture, close by. Second used to be a mattress suture. And the third, which I used to practice, was a mattress suture followed by a distal continuous suture with Crowley. Mattress suture by Vicryl or Ethibond, and then distal suture by Crowley.
Yes.
So various things can be done. You can close, but the idea is you will not use a cautery near the bronchus.
Yes, sir.
You will not injure the vascularity of the bronchus, and you will not tie the sutures too tight to
compress the
vascularity. Nowadays we use and the bronchial close should be as close
to the main stump as possible,
as minimal stump that is left. That is important. Nowadays we use staplers, and the staplers there come in various colors. So remember which color you will use for bronchus. Do you know? Have you seen a stapler being used on a bronchus? Anybody? Any of you?
Seen, sir.
Because they come in various colors. Okay, you have a white color, you have a blue color, and you have a green color, and you have a gold color. So white is usually a thin stapler used for vascular. Blue and gold is for parenchyma, especially if you are going to divide
segmented.
And the green color is used for bronchus. Remember these things. Anything?
I would like to give him a 1 minute feedback. Is that okay?
Sure, sure.
Yes.
Yeah, I think on the history, I think there was a lot of negative histories which were being presented. I think the history was good. My worry was that he came up with only one diagnosis, which is tuberculous empyema. And actually on a CT scan, it was not. So be very careful in the exam. Always give differential diagnosis. Always give more than one diagnosis, okay? And my concern with your description of the operation was that you were so focused on taking vein artery bronchus that you did not talk about safety profile for these patients. I really wanted you to talk about how will I make sure this patient is safe going on the table and safe coming out of the table. And also you did not talk about access, taking the intercostal muscle and things like that. So talking about pneumonectomy is not the key thing here. You will come across as a better surgeon if you talk about all these safety profiles of the patient rather than just talking about artery, vein, and bronchus. You understand that? This it's very important to talk about the steps you're going to take before operation, during the access, and in case you have a complication. That is very important. That shows to us that you are a good surgeon.
Thank you.
Thank you. Thank you, sir. Thank you for joining, Dr. Alizaman Khan. Yeah.
Okay. Thank
to the organizers for this opportunity.
Thank you, sir.
Thank you very much.
We'll move ahead with the next case, sir. Can you see the chat box? What are the chats?
Thank you, sir, for chairing the session. For next case, I call upon Dr. Kaushik and Dr. Samraj from Jaydev Institute of Cardiovascular Sciences. The examiner for the session are Dr. Sampat Kumar, ex-professor and head CTVS AIMS. Dr. Balram Iron, ex-professor and head CTVS AIMS, New Delhi. Dr. O.P. Yadav, editor-in-chief, Indian Journal of Thoracic and Cardiovascular Sciences, and Dr. Shiv Kumar Chaudhary, professor and head CTVS AIMS, New Delhi. The time limit is 1 hour and warning bell will ring at 50 minutes. We'll start the next session.
Good afternoon to all. I'm going to present a 20-year-old male, Mr. Akbar Mannan Khan, a BCom graduate residing at Bangalore, came to the hospital for regular follow-up, who is a known case of congenital heart disease, tetralogy of Fallot, for which he was for which corrective surgery was done, and he was routinely on follow-up. History of presenting illness: a fifth-born child of premature normal vaginal delivery at 8 months of gestational age, with prenatal diagnosis of tetralogy of Fallot, born of third consanguineous marriage. He was on follow-up for that congenital heart disease, following which he had a history of cyanotic spell and was managed conservatively for up to 2 years of age, and was advised corrective surgery at 2 years of age, and had undergone complete correction at 2 years of age. At present, there is no history of shortness of breath, pedal edema, oliguria, abdominal distension, orthopnea, paroxysmal nocturnal dyspnea, and no history of fever or no history of chest pain or palpitation. Past history: there is no history of tuberculosis, epilepsy, or bronchial asthma, and he was on tablet losartan. Drug history: he was on taking tablet losartan for the past 2 years. And there is a history of cleft palate and cleft lip surgery at 3 years of age at Bangalore. Family history: he is the fifth-born child of third consanguineous marriage. All other siblings are normal, no significant family history. Personal history: he is non-smoker, non-alcoholic, normal diet. General examination: conscious, oriented. No.
Just a second, can we interrupt? When you're presenting, you didn't give any little more details about the first history, just total correction. Is that enough? Was that a complicated, uncomplicated? Did you have any untoward reaction? Something we can learn, from the first experience?
It's uncomplicated correction was done.
Why he has come now? Why he has come to you now? Why this patient has come to you now? What are his presenting features?
You said all negative history. What
Yes,
is present symptoms?
At present, he is asymptomatic, sir.
Then why he has come to you?
He has come for to get redo surgery for free PR, sir. First surgery was a VSD closure, RVOT resection with the
Is he symptomatic now? Is he symptomatic now?
No, asymptomatic, sir.
Now, what Dr. Yadav asked you about the details of the first operation,
yes,
that matters a lot when you are going for the redo surgery. What are the details in the operation notes?
It is a VSD closure, RVOT resection with a small pulmonary annulus. So they have resected, it is a bicuspid pulmonary valve. They have resected the pulmonary valve, and 12 size Hagar was expected to be paused. They are not able to pause it, so they have placed a transannular patch with monocusp repair of pulmonary valve was done, sir.
What material was used for the RVOT reconstruction?
Sir?
What material was used for the RVOT reconstruction and the monocusp?
Pericardium, sir. Pericardium.
Pericardium.
Yes.
So was any cover provided to the heart after the operation?
No, sir. No, cover was provided.
No. Now, second, what Dr. Yadav asked you is that how was the course post-operatively? For how many days patient stayed in the hospital? That will tell you whether patient had any complication in the first surgery or not.
No complication in the first surgery, sir.
No sternal infection, no bone infection?
No, sir, no.
No sternal infection?
No sternal infection, sir.
And he was not taken back to the operation theater for...
no re-exploration, no sternal infection, sir.
Okay.
Even, you know, things like what was the duration of intubation? How much time did he spend in intensive care unit? Did you go through the operation notes yourself?
Yes, sir. I have read the OT notes.
Good. Okay, good. So these are important, you know, learning from the experience of the first surgeon. He might have made some small points which he knows are valuable to the second surgeon. Simple thing as was the pericardium closed or not could be very, very important for these. So that's the relevance of asking you to go through the operation notes and the anesthesia notes and the entire post-operative course.
Did they describe the intraoperative findings?
So the pulmonary valve was small, sir. Main pulmonary artery was hypoplastic with adequate branch PSC.
That he has already told. Anything else you want to tell?
Aortic arch, right aortic arch.
Okay, what else? Was there any innominate or not?
Vein, innominate
Innominate
vein.
vein.
Brachiocephalic vein or innominate vein.
Innominate vein is present, sir.
Okay, so that means there is no LSVC.
Yes, sir.
Okay. Did they say how did they cannulate the heart? Venous chambers.
Aortic and bicaval cannulation, sir.
How bicaval?
SVC and IVC cannulation.
SVC directly or through the right atrial appendage?
Directly, sir.
Okay. Then what approach was used for the correction? Transatrial?
Transatrial approach was used, sir.
Okay, right.
General examination.
Surgery done? Where was the first surgery done?
Sir, Satya Sai Hospital, sir, on 2003.
All right.
General examination, conscious, oriented, no pallor, icterus, cyanosis, clubbing or lymphedema. There is a scar in the lip due to cleft lip repair, which healed with primary intention. Pulse rate is 60 per minute. Normal in rhythm, no specific character, no radio-radial delay or no radiofemoral delay. Blood pressure is 110/60, measured in the right arm in supine position. Respiratory rate is 18 per minute, abdominothoracic type. Saturation is 99% at room air. He is afebrile, JVP is not elevated. CVS examination, inspection. After obtaining consent, patient was adequately exposed and examined in both supine and sitting position. A midline scar extending from the suprasternal notch to superior sternum due to previous cardiac surgery, which is healed with the primary intention, and trachea is midline. All quadrants of chest moves equally with respiration. Apex beat is seen at the left fifth intercostal space at mid-clavicular line. No dilated veins, no visible pulsation. There is a precardial bulge noted at the left side of the sternum from second intercostal space to fifth intercostal space. No other pulsation in the chest, sir. Palpation, inspectory findings of the are confirmed. No warmth, no tenderness, trachea is in midline. Apex beat at the fifth intercostal space at mid-clavicular line, hyperdynamic type of apex. Auscultation. In apex, S1, S2 is heard, no other added sounds. In tricuspid area, S1, S2 heard, no other added sounds. In pulmonary area, grade ejection systolic murmur of grade 3/6 and early diastolic murmur of grade 2/4 is heard at the pulmonary area, no other added sounds. In aortic area, S1, S2 heard, no added sound, S2 is single. In no other murmurs heard in head at the back or lateral scapular area. In percussion, right heart border correspond to the right sternal edge and left heart border correspond to the apex. Other system examination, RS, bilateral air entry is present, no added sounds, CNS, no focal neurological deficit, per abdomen soft, no organomegaly, no, especially no hepatomegaly. Diagnosis.
Anything else you like to see? Very minor thing in your inspection. How many scars are there on the body?
One lip midline lip scar and one mid sternal scar, and then drain side scars are present in sternum and left pleural, left side.
Left pleura. That means left pleura was open.
Yes, sir.
Any scar on the right side?
No, sir. Right side, no scar.
So there was no drain on the right side.
Yes, sir.
Why did I ask this question? Why did I ask this question? See, nowadays it is described that you can change the pulmonary valve through the left anterior thoracotomy. If your left pleura was open, that means there you might expect adhesions there also. So it may be slightly difficult in case you are planning that approach. Okay.
Yes, sir.
So that's why all the details about the first operation are very essential for you.
Okay. Yes.
All right.
Yes, sir.
Okay.
Diagnosis: a case of cyanotic congenital heart disease, tetralogy of Fallot, status post corrective repair, VSD closure, RVOT resection, and transannular patch. Now with severe pulmonary regurgitation, and he is not in failure in he is in sinus rhythm, not in failure, no evidence of infective endocarditis and thromboembolism.
So we are coming to the same question again, that why the patient wants to go for the pulmonary valve replacement at this stage?
RV dysfunction, if it becomes symptomatic and if the RV dysfunction is severe, it may become irreversible.
But you said patient is absolutely asymptomatic.
Sir?
You said patient is absolutely asymptomatic.
Yes, sir. Even in asymptomatic patients, if the
now on examination also, except for the murmur, that is systolic diastolic murmur, there is nothing else which is positive in this patient.
On the other hand, on the other hand, Dr. Balram wants to know what are the indication for pulmonary valve replacement after tetralogy correction.
Transannular patch being put in the previous surgery.
That is there. So what are the indication? When would the timing of re-intervention?
So when patient is symptomatic is the first one, sir. Second one, on routine follow-up, if the on cardiac MRI, if the RV end diastolic volume is more than 170 ml per meter square, or the RV ejection fraction is less than 45%, then it is an indication for redo pulmonary valve replacement, sir.
Yeah, so that is one thing. In tetralogy, you follow them routinely, even if the patient is not symptomatic, the RV is going to fail. So preemptively, you keep a check on the RV volumes by MRI.
And
that okay.
Yes, sir.
So maybe that would answer Professor Balram's question.
What are the effects of PR that you looked for, or would you look for clinically? Effects of the issue in this patient is free pulmonary regurgitation, nothing else?
Nothing else, sir. Only free PR.
So what are the clinical features that you're going to look for in a patient to evaluate that free PR? Start from the history, if you wish.
History of right-sided heart failure, like a pedal edema, abdominal distension, or shortness of breath.
Yeah.
And then
examination wise, we can look for right ventricular hypertrophy.
Will it be right ventricular hypertrophy or right ventricular enlargement?
Right ventricular dilatation, sir, enlargement.
What about any arrhythmias?
history of palpitation or
so if nothing is present and on investigation, if there is no evidence of clinical deterioration of the RV function, would you still go for a pulmonary valve replacement?
If it meets the MRI and echoes meet the expected criteria, we can go ahead with the pulmonary valve replacement to prevent further RV dysfunctions.
Let me put it the other way around. Is there any harm of pulmonary valve replacement? Are there any complications attached, or is it a benign procedure?
Since it is a redo procedure, it carries risks.
So that's one, operative risks. And then what about the risk attached to a valve?
Depends.
Yes, what are the risks of a usual valve? You can say mechanical valve, bioprosthetic valve.
Or homograft.
Or homograft. So what are the issues with each of these?
If you use a homograft or a tissue bioprosthetic valve, the implanted valve can get calcification and it might further require a redo after 15 or 20 years. But 15 years survival is around 60 to 90% in post pulmonary valve replacement. And mechanical valves are also being used now, but they require lifelong anticoagulation, and risk of thromboembolism is there in such patients.
Shall we go for the investigations?
Yes, sir. So investigation, first we would like to go through the previous operation notes of the patient, and then baseline investigations, hemoglobin, complete count, blood grouping has to be done. And then ECG, this patient's ECG shows a rate of around 75 in normal sinus rhythm. Axis is, there is right axis deviation of plus 120, and loop is clockwise loop. P waves is 0.04 seconds. QRS is widened with 0.2 second duration, and there is features of incomplete right bundle branch block, and RVH features are there. R wave in V1 is more than 7 millimeter. And, there is no ST elevations, and T wave is normal.
What about Q wave in lead V1?
Q wave, deep Q waves are there, sir, which is again suggestive of right bundle branch block, sir. And
is it right bundle branch block or something else? Can it denote volume overload of RV?
Yes, sir.
Yes, proceed.
Then I would like to do a chest X-ray for the patient.
Suppose I see the ECG of such patient and I say that this case is hopeless. What would you find on the ECG which will suggest that the prognosis is bad? ECG.
RSR dash pattern, sir.
That is very common. Why would RSR dash pattern suggest bad prognosis? Bad prognosis on ECG, especially in this
Widening of
scenario.
QRS more than 180 milliseconds. Widening QRS more than 180 milliseconds, sir.
Beyond that,
it is.
What is the terminal event in these patients?
Sir, arrhythmia and sudden death, sir.
Which arrhythmia?
Sir, usually supraventricular or ventricular tachycardia, sir.
Don't combine both. Which one is the fatal one?
Ventricular tachycardia.
So what will happen before that? Multiple ventricular ectopics, if you see in the same strip, isn't it bad thing? If you see multiple ventricular ectopics in this patient, it's a bad thing.
Yes, sir.
Okay, proceed further.
Then I would like to do a chest X-ray for this patient, sir. Chest X-ray, I would like to get a postero-anterior view and then a lateral view for the patient, sir.
Show the X-ray.
This is a plain X-ray, PA view, adequately penetrated, not rotated, showing situs solitus. Cardiothoracic ratio is approximately 50 to 55%. Aortic knuckle is normal. Pulmonary bay is full. RV type apex and right heart border appears normal. Lung fields are normal. Bony cage and soft tissue is normal. Previous sternal vials are seen, sir. Total 4 in number. In this actually.
The bony cage normal, but the spine has got some problem.
No.
What about the trachea?
Trachea looks to be deviated to the left, sir.
Slightly. And what about the diaphragms, domes of the diaphragm?
Cardiophrenic and costophrenic angles are free, sir.
Domes of the diaphragm. Which diaphragm is usually up?
Right side is
here.
Here both are at the same node.
Right. Okay. What about the right heart border? You said it is normal. Does it show any right atrial enlargement?
Yes, sir.
Why you want the lateral view in this patient?
Sir?
Why you want lateral view in this patient?
Sir, he's already been operated, sir, previously. I want to look for the relation of the undertable of the sternum to the chambers and the great vessels, sir.
Okay. Is it a better way to look into it?
No, sir. CT is a better investigation of choice, but for preliminary investigations, we can get a lateral chest X-ray.
Okay.
You can show that. Do you have the lateral X-ray?
We don't have it.
Is there some finding in this X-ray which, even on a peer view, which makes you a little worried when you're going to do a reduced sternotomy? Did you get that?
Aorta is in the midline, could be in contact with the sternum.
No, but something which could be, something which is going to worry me. What are the areas that are most in jeopardy when you're doing a redo in these kind of patients?
Right ventricle, sir.
What else?
Right ventricle, great vessels, and
you said everything. What about the right atrium?
Yeah, right atrium.
Right atrium. Yes, sir.
That's a thin wall right atrium, and your patch itself, I mean, a transannular patch is going to balloon more than your right ventricle. And probably in this patient where the RV has not yet set into dysfunction, RV is not going to be that dilated to be such a big trouble to you. So in this, to me, right atrium looks a very worrisome organ. And the full bay that you have, probably the transannular patch may be stuck to. So these are the two areas where I would be very worried and like to know how much is the space between these two structures and the sternal backbone.
Yes, sir.
Okay, go ahead.
Next, I would like to go do a cardiac CT, sir. Echo is showing situs solitus, levocardia, normal pulmonary venous drainage. IAS is intact. Ventricular septal defect patch is intact. RVOT gradient is 15. There is mild TR. RV systolic pressure is 25. And there is severe PR. RV end systolic volume is 68. And RV ejection fraction is 40.
Why did this patient, I mean, now that's the importance. What was the RV ejection fraction equal to LV 40? What was it immediate post-op, pre-op? Do we have any information there?
So the post procedure only so far 2 cardiac MRIs has been done for the patient, sir. That other report I couldn't get, sir.
So isn't that an indication in itself why we were discussing that? Why are we doing a pulmonary valve intervention? Don't you have answer in this echo?
Yes, sir.
Yes, go ahead.
Yes, sir. Then I would like to get a cardiac CT done.
Now, before you go to cardiac CT, what is the information that is missing here?
Diastolic volume. RV and diastolic volumes.
Is there any additional VST or residual?
What's the size of the pulmonary?
Pulmonary valve annulus. Sorry.
What's the size?
Anything else is missing in the report?
How is the branch pulmonary arteries, and is there any aortopulmonary collaterals?
Do you expect aortopulmonary collaterals in this patient?
No, sir.
Then why you want it?
No, sir.
What about the other valves, aortic valves? In the long term, the aortic valve in these patients may start having AR.
Yes, sir.
It is not mentioned here whether the aortic valve is normal or not.
Why do you want pulmonary annulus diameter?
Sir, to plan for adequate processes. And second,
Yes, what is the second point of importance in today's scenario?
Percutaneous.
Percutaneous interventions are also possible for the pulmonary valve.
Right. So what are the criteria for that?
So patient in RV failure and previously conduit valve placed. During the first corrective surgery.
What Professor Sampath asked you about the pulmonary valve annulus, does it relate to your percutaneous intervention also? What sized valves are available now? Any idea?
Sorry, sir, I'm not sure.
You never thought of percutaneous valve replacement? You did not.
That option is available in India, but the cost is about 25 lakh.
No, but he should think about it. He should consider that if the patient can afford
Right
it.
aortic arch.
An operative procedure.
Transannular patch system.
Yeah.
What is the problem when I try to deploy?
Attachment.
Attachment is.
Just a trivial question. What is new that has happened in the last 5-7 days as far as percutaneous valves in pulmonary position is concerned? It's been in news all over. The Melody valve has been approved by the FDA as a class 1 indication now. Okay?
Yes, sir.
It's approved. Earlier it was off-label use. Now it is on-label use.
Okay, shall we go for the CT and MRI? Pardon? Okay.
In cardiac MRI, I would preliminarily look for the RV end diastolic volume of more than 160 and RV end systolic volume of more than 75. Then an LV end systolic volume of less than 65, and look for right ventricular hypertrophy.
RV ejection fraction.
And RV ejection fraction of less than 45. I would like to offer a surgery for this patient, sir. Redo.
So all the criteria are met?
All the criteria are met.
Yes, sir.
Yes, sir.
All right.
Still, do you have any thoughts for this LVF of 40%? I'm uncomfortable in tetralogy. Do you get LVF of 40% usually?
No, sir.
So what could have gone? Can you think of some plausible explanation?
What happens to the LV in patients who got dilated RV?
LV also might go in for failure.
Why?
Back.
How does it happen? Is it a myocardial problem or it's a geometrical problem?
It is a geometrical problem, sir.
What's that?
Septum, sir.
Yes.
The progressive RV dysfunction will lead to ballooning of the septum towards the LV.
Right. So it becomes like D-shaped. Okay.
Yes, sir.
There is a technical name for it. Can you speak in technical terms? It's called ventricular interdependence. Okay.
Yes,
And
yes, sir.
also, can it be a perioperative poor myocardial preservation of first surgery?
Yes, sir.
Everything becomes yes, then it becomes difficult. This is where, you have to give some plausible explanation. That's okay. All you test in the exams is your process of thinking and logical reasoning. And that's it. It has happened or not happened. Even we don't know what has happened.
Okay, you think that this patient needs re-intervention. What are the options available for you?
So first, I would like to discuss the option of pulmonary homograft, pulmonary valve replacement with bioprosthetic valves, and the use of mechanical valves is now also being advocated. And
sir, can I interrupt a bit more?
Yeah.
Do you think your evaluation is complete? Now you are going for a redo procedure. You have MR. You said that MR, you have seen the volumes and function, ejection fraction. What all would you look in MR? You just mentioned 1, 2, 3, 4, 5. MR or cardiac CT, whatever you do, what all things would you look at?
cardiac CT, first I would like to know the relation of the vessels and the great arteries and the ventricle with the sternum for my safe re-entry. Second,
only great vessel or anything else?
The transannular patch along with the left atrium also, sir.
It's all cardiac chambers.
Cardiac chambers.
Okay. The RV will be anterior most of the RA which you place.
Yes, sir.
Okay. One thing is relation of the cardiac mass with the sternum. One. What else? Next. Balram sir has already given a hint to you.
Aortic valve, the other valve.
No. That you won't assess on CT. Na? That was done on echocardiography or you go by when you do MR. When you are talking about cardiac CT,
additions to the left pleura can also be seen.
That adhesions, how can you see on CT? That is not even, it's not a good tool to detect adhesions. What about presence of innominate vein? Does that have some bearing?
See, in your first operation, you don't know whether thymus was excised in this patient or not. If the thymus was excised, he will have the innominate vein, which will be just lying under the sternum.
Even
Not covered by anything.
innominate injury also is possible while re-entry. So I would like to know
That is one of the
the
commonest
presence of
injuries.
innominate vein.
Then what else?
Innominate vein, great vessels. Then the
Okay.
RA, RA, RV, the
That's-
transannular patch.
Yes. What else? Would you like to
At the
have a look
transannular
at the-
patch, so sorry, sir. Transannular patch, what all you want to see there?
Calcifications,
Yes, what else?
whether it is ballooning.
It is not, you should say whether it is aneurysmal or not. Okay?
Yes, sir.
Where the patch will be quite thin if it is aneurysmal.
Yes, sir.
Okay, now go ahead. What Dr. Chaudhary was asking you.
What more?
Then I would like to evaluate with femoral Doppler and
No, just let's limit to the cardiac CT first. You may like to look the coronary anatomy also.
yes, sir.
If that was not given in your notes.
Vessel crossing the RVOT.
The transannular patch is there, of course, but suppose you have to extend your ventriculotomy to accommodate a bigger valve or put the valve lower down. So you should know what is the coronary status. Then you see where the right pulmonary artery is originating. It's very proximal right pulmonary artery or distal, so that you can plan. Suppose you are going to insert your valve little distally, and if you are not aware, you may impinge upon the mouth of the right pulmonary artery. Then if you are planning for MICS, you should also see in which intercostal space your chosen site, the proposed place of the valve is going to lie, because you may plan MICS, you don't have to open whole thing.
Yes.
And one more important thing which we forgot in echo is presence of an ASD.
That he has
If
written
an
IACTS.
if an ASD is present or any left to right shunt is present, your MICS is ruled out. So before going or planning for MICS, you must rule out any left to right shunt, whether a residual VSD or an ASD. Okay, so
Why this presence or absence of ASD or PFO is important? Of course, it is written in the echo, the IS is intact. Why it is, some more point why it is important besides MICS?
Venting can be done, sir, intraoperative.
You want to vent this patient?
How old is this patient?
Sir, he's 20 years, sir.
What's his weight?
45 kgs, sir.
Hemoglobin. You don't know his hemoglobin?
15.2, sir.
Are you going to do blood conservation or no?
Yes, sir. On table autologous blood we can withdraw, sir.
Is that the only thing? What else can you do for blood conservation? Can you do something preoperatively?
Preoperative phlebotomy, and we can bleed the patient also, sir.
Phlebotomy.
No, we can bleed the patient. Autologous.
I won't do anything like that. I will do something on the table for phlebotomy or collection of blood. But preoperatively, you can give him something to raise his hemoglobin, even though it is 15.
Erythropoietin.
Most expensive. Ordinary fersolate is good enough.
Yes, sir.
See, why I asked you that question was that if you are doing only for the pulmonary valve replacement or the RVOT reconstruction, if there is no ASD or PFO, you don't have to give cardioplegia. That means you don't have to dissect out the aorta pulmonary artery. You get me?
Yes, sir.
Okay.
Also, you can
On
do
pump, beating heart.
And why do you want to do replacement? Is there anything else you can do?
That's what I asked. What are the options available?
A homograft can be used, sir.
That a homograft is a replacement.
what are the options for the RVOT reconstruction? That is the question now.
Your problem is pulmonary regurgitation. How can you correct it without replacement of the valve? You create a valve.
Autopericardial reconstruction.
Is there any pericardium left?
No, sir.
So?
Bovine pericardium.
Anything better you can use? PTFE membrane?
Yes, sir. Gore-Tex patch can be used for recreation.
See, Gore-Tex patch and membrane are different. Okay,
Yes,
what is the size? What is thickness of the Gore-Tex patch and what is thickness of the Gore-Tex membrane?
Membrane is 0.1 millimeter.
Yes, sir.
Patches can be anywhere between 0.5 to 1 millimeter, 1.5 millimeter thick.
Yes, sir.
So for the cusp, you use the Gore-Tex membrane, PTFE membrane. Don't say Gore-Tex, say PTFE membrane. And what are the ways to use the PTFE membrane to create the valve, which are described?
A tear-shaped PTFE membrane can be used, sir.
See, either you make a tube, in that you insert the valve, or it is already RVOT is reconstructed. You are going to open the pulmonary artery. You can create the valve there. Or what is described by this fellow from Australia, Nunn, Graham Nunn. What does he describe?
Nunn technique.
Pardon? What does he describe? Bileaflet construction of the pulmonary valve. Okay.
Yes, sir.
And as per his report, the results are very good. Okay. And that is where Dr. Shiv Chaudhary asked you that where is the RP origin? When you are reconstructing this bileaflet valve with the help of the PTFE membrane, you have to have the first stitch just proximal to the origin of the right pulmonary artery there. All right?
Yes, sir.
Do you know about this? How to reconstruct the bileaflet valve with Graham Nunn's procedure?
No, he is
It
not.
is available in literature.
Yeah.
It is available.
So,
Please read it.
Yes, sir.
So we were discussing about the pre-operative workup. So you said cardiac CT, something more is left, almost finished about the evaluation. What else is left apart from cardiac CT? What else would you like to do to this patient?
To make him fit for operation.
A femoral Doppler and a transesophageal echo, sir.
That you will do on the table.
On table.
You're not going to subject the patient for a transesophageal before.
Yeah.
Not only femoral Doppler, you would evaluate the whole venous system, femoral, iliac, and IVC.
Yes, sir.
Okay, because you may need to put a cannula from down and you find that your cannula is not going up. There may be some problem. And at the same time, you evaluate the arterial system also.
Yes, sir.
Okay.
Yes, sir.
Are you going to send him to the dentist and the ENT surgeon?
Yes, sir.
Why?
We are placing we are placing a bioprosthetic valve, so we should rule out dental caries tooth.
See, if you are planning for a valve, mechanical valve, or even the bioprosthetic valve, you will like to keep him on anticoagulants for some time. And if any dental procedure is to be done, that should be done before your procedure is done.
He should be cleared from any orodental sepsis as well as sepsis in the middle ear. What is the Japanese technique of RVOT reconstruction? It's been published with 10-year follow-up. Have you heard of the name Komoda? Okay, now they have made a PTFE conduit. They stitch it on the operating in the operating room. They use a PTFE expanded PTFE tube, and they use membrane to produce 3 cusps. They also have a technique to produce sinuses, all 3 sinuses. So they get a conduit which looks exactly like the homograft, and they have very best results with it, with no calcification, no regurgitation, and excellent post-operative hemodynamics. So go and read about it. The name is Komoda. That's another option for you. Now, this can be done on a beating heart without cross-clamping the aorta or stopping the aorta. But you must be absolutely certain that there is no residual VSD, ASD, PFO, or any other shunt.
So let's come to this patient. What would you offer to this patient? Suppose you are the operating surgeon. What are you going to offer?
Sir, I would like to go ahead with redo sternotomy with pulmonary valve replacement with the bioprosthetic valve, sir.
Redo sternotomy on cardiopulmonary bypass.
On pulmonary bypass.
Without cardioplegia or with cardioplegia?
Sir, I will go ahead with cardioplegia and do the procedure, sir.
Okay. So now the question is, what are the advantages and disadvantages of cardioplegia in such patient?
Sir, there is already right ventricular hypertrophy, sir. So myocardium protection is better with cardioplegia, sir.
No, if it's beating, continuously beating, perfuse, it's equally good. Why not?
Yes, sir. For proper correct measurement of the annulus, it is better if the heart is in arrested state, sir, in diastole.
Why? I thought the other way around. After all, you are going to give him a beating heart later on, no? So if you take the measurements when the heart is beating, that will be the normal scenario.
You measure the size of the annulus on TEE before you go on bypass. So you don't need to go and put in anything there to measure it. You can.
Oh, one more thing do you always prefer to put in the native annulus when you are going for the valve replacement in pulmonary, such redo?
Supraannular also.
Hmm?
Supraannular placement also can be done.
Supra, what's the disadvantage of supraannular placement?
So we are planning for a bioprosthetic valve, sir. So the strut might come in the way of the closure of the pulmonary valve, the pulmonary artery.
Anyway, you are going to put a patch. You are not using the native tissue only unless it is grossly aneurysmal. But if you put in the annular region, what may happen? Suppose the patient needs a good size valve, you are going to put it for at least 15-20 years, a big valve. Suppose in this patient, you are going to plan a 29 or 31 valve.
Calcification of the implanted valve also can happen, sir.
Calcification will happen wherever you put it. I'm just asking, if you put in the annular position or supraannular position, what can happen?
Calcification doesn't happen when you suture the valve. It happens many years later.
Many years later.
Yeah.
Immediately when you are closing the sternum, what will happen if you use, let's say, 29 number valve in the annular or
This question is a tricky question. Think about it. You have a transannular pericardial patch.
The patch may dehisce.
The patch may dehisce, it may not hold the suture even.
See, when you're closing the sternum, it will get compressed by the sternal plate. If it is a big valve and if it is in that position.
So in pulmonary one, if we are using the valve in relatively younger patient and a big size valve, at least we put below the annulus towards RV side, somewhere between the tricuspid valve and the native pulmonary annulus, so that you get good space for the valve. And because you are going to cover it with a patch, so not an issue. So we usually avoid putting in the annulus or supraannular position. Supraannular, never. Annulus, sometime if it's a grown-up patient and the desired valve is fitting nicely, yes, you can do. But otherwise, suppose this child was 12-year-old and you want to put a 27 size valve. You won't have that much space in the annulus. And if you put somehow, it will abut the sternum and it will cause problem. So better to put the valve below it. So that is a practical problem.
Sir, we have 10 more minutes for this case.
Have you seen a patient undergoing this kind of operation in your hospital?
Oh, last week it was done. Yes, you have seen, but homograph was
done, sir.
Are you comfortable with the operative steps in this patient if we ask you the procedure?
Yes, sir.
One question I wanted to ask with the large valve, which they have not been touched on. You put the valve, you put a large valve high up, you close the sternum, and then you suddenly find ST segment changes in all the, in V1, V2, V3, you start seeing ST segment. What is the cause?
Left main compression.
Coronary crossing in between aorta and
No,
pulmonary.
not coronary.
Left main compression.
Left main can be compressed by the rigid prosthesis. That's something
Okay, so
right, where you should not.
Can you describe the operative steps now?
Yes, sir.
Your patient is anesthetized. Okay.
Yes, sir.
You have to prepare the patient. How will you prepare this patient?
Sir, first I would like to apply external defibrillators, sir. Second, I would like to get a transesophageal echo probe inserted. Third, I would expose the groin region and will electively go on femoral bypass, both femoral arterial and vein cannulation, and then go ahead with the sternotomy, sir. After heparinization, I would achieve an ACT of 450 and go ahead electively on femoro-arterial and venous bypass and go ahead with low flows. I would like to go ahead and proceed my redo sternotomy, sir.
Suppose your CT scan has showed that there is a clear visible space between the posterior table of the sternum and the cardiac structures. Then you like to go for the fem bypass?
Sir, I'm a beginner, sir, so mostly I'll go on elective femoro-arterial venous cannulation.
Right. Taken. Go ahead.
And then once the sternotomy is done, I would like to do adductiolysis beneath both the sternal tables so that I get enough space to insert the sternal spreader and go ahead and with blunt dissection, we'll go ahead and dissect the additions over the intrapericardial and to the cardiac additions, sir, to expose the aorta and right atrium.
Now, here there's some technical point. You have done this sternotomy. Okay. Yes. Then what is the next step now? Once the sternum is split, sternum you are able to split without any complications. Okay. Now, yes. Sternum is split. What next?
What are you going to do with the sternum?
Where would you place your retractor and how would you open it?
Double blade sternal retractor.
No.
Can you do it immediately after splitting the sternum?
Sir, I would like to apply CATS retractor on either side and reduce the addition so that I get enough space to apply my sternal spreader.
See, first of all, yes, you put your CATS on one side first, release the additions from the sternum. Okay.
Yes,
as
sir.
if you are harvesting the your lima or rima. Create this space on both the sides so that at least a small size retractor you can place it. Then go further and create more space so that the sternum is retracted properly with a normal sternal retractor for this age group before you touch any of the cardiac structures. Okay.
Yes,
so
sir.
once you have mobilized these adhesions to place the sternal retractor, where will you now start dissecting out for the heart, cardiac structures?
So first over the aorta, sir.
Will it be first over the aorta, which is the area which is easier to free in a redo case? This is always the diaphragmatic surface of the heart. Okay.
Yes, sir.
Okay. Now, so what all structures will you expose now?
Sir, I would like to expose the aorta, the right atrium and SVC, sir. Once I have adequately exposed these, I would like to convert my cardiopulmonary bypass to aorta and SVC cannulation, keeping the femoral vein for venous drainage through the IVC, sir.
Why? If you have cannulated the femoral artery, why you want to shift your cannula to the aorta now? Already there is a cannula into the IVC, there is a cannula into the femoral artery. Okay. So you have to put one more cannula only for the SVC drainage.
Yes, sir.
I'm sure you know how to prepare the circuit before you go on bypassing these patients.
Yes, sir.
Okay.
Yes, sir.
So do you have to really loop the IVC and SVC in these patients?
No, sir.
Okay. Even when you are fond of doing cardioplasia.
So, I'm not going to open the right atrium, sir. I will vent the heart through the RSPV and go ahead with root cardioplegia, sir.
But you are going to open the RV patch and you will enter the RV at least. What will happen?
What will happen if RV is opened with ordinary cardiopulmonary bypass? You open the incision and cardiopulmonary bypass terminates. Stops. The pump will be I think because you have not seen it in our hospital, we do something different. What permits you to keep cardiopulmonary bypass on with the RVOT open or even the RA open without snaring?
Intact IAS.
Not intact IAS, man. Intact IAS, of course, but no, you have opened the RA. But with how can you open the RA on cardiopulmonary bypass without snaring SVC, IVC? Is there a way?
With adequate CVP, sir.
How is it achieved in the hospital, in your hospital?
What will happen to the cannula?
What will happen? In ordinary bypass, if I don't do that,
we'll apply vacuum through the CPV.
If you have
sir.
vacuum assist,
Yes,
you
sir.
can do it. If you
Yes,
don't
sir.
have vacuum assist, then you have to snare. No. Then you should have told I will have vacuum assist.
Yes, sir.
Only if you have vacuum assist, you can do that. Understood?
Yes, sir.
All right. Go ahead further.
Sir, I would like to give root cardioplegia, sir, and arrest the heart.
You are not able to cross clamp the aorta because you have not released the aorta enough.
Aortopulmonary groove I will dissect and keep it free, sir.
See,
so that I get adequate
case in these patients with the redo where you are doing the PVR, if there is no a PF4 AST, you can do it on a beating
heart
on cardiopulmonary bypass.
Yes, sir.
Okay.
Yes, sir.
I think they are ringing the bell behind.
Time is up.
Yes, sir. We need to. The time is up, sir.
Questions do you expect after surgery? So just one comment, this is now a little variation and I've got a little difference. If infarct VSD, we can go on single venous cannula and repair an infarct VSD. So when the tricuspid valve closes, you do not have to do two venous. So I think we can go on without any vacuum assist in these patients. Definitely RA single venous or DUP two-stage venous cannulation can be done.
Yeah, the assumption is that the tricuspid valve is competent, but in tetralogy you cannot.
For standard
I've
teaching,
done an echo
from
in this patient, every detail about it. So in
for
this
standard
patient,
teaching, I would say for standard teaching for resident purpose, the most simple and straightforward answer should be yes, loop it before we open RV. They should follow that practice.
You can loop it, do not snare it. Okay.
If needed.
Or there is air in your circuit, you can definitely snare it. You got the option for that. But at their level, I think we should teach them the safe methods which are to be used. No shortcuts.
Sir, we have sent the form, sir, to fill the candidate's assessment sheet to your emails. I request candidate to fill and send it back. I request Dr. Shiv Chaudhary to give the summation marks for the candidate and his remarks. Sir.
No, just now.
Yeah, now. Sir.
Overall, their performance was good. They have the basic understanding of the subject, the pathology, the evaluation process. Operative may be some steps they are missing because they themselves have not done, but they have good understanding about the indications and pre-operative evaluation, which is the crux of their teaching. Operative, yes, maybe they will pick up in coming time.
Thank you, sir.
Thank you, sir. I would like to just bring to notice to all the residents who are here, need to become the associate members to get the prize of the surgical loops with the headlight from the association. The best presenter will get the loop provided is an associate member. Even the quiz winner also should be an associate member. So still time is there. The IACTS manager is sitting in the hall itself. Immediately membership will be given. We are so fast in giving memberships also.
This looks so lucrative. Can I also participate?
You cannot.
Sir, you can participate in the quiz, but the prize will be given only to the who is associate member.
You will have to first become a resident.
I'm resident, sir.
Exam.
Sir, I'm resident. 4 of my teachers are sitting in front of me. I am the resident. So
Hand over your MCH degree.
Thank you,
all
sir.
my teachers are sitting here.
Sir, we have time for our tea. I would request Dr. Balram Myran to give his talk. Is he okay? It is okay, sir?
Yeah, it is okay for me.
Yeah, good. Thank you, sir. We'll just continue immediately. So, Dr. Balram, slides ready? Manpreet, you can go ahead with the introduction, please.
It is already recorded.
Yes. Manpreet.
Thank you, sir, for chairing the session. For next session, I call upon Dr. Balram Myran to render his lecture on the current trends in the mechanical circulatory sport. Dr. Balram Myran is a senior cardiothoracic surgeon of our fraternity. Darren served as the Dean of Academics, Professor and Head of Department of Cardiothoracic and Vascular Surgery, and Chief of Cardiothoracic Center at All India Institute of Medical Sciences, New Delhi. Thank you, sir.
Good evening, everyone. I'm first of all thankful to Dr. Hiramat and his entire team who is organizing this IACTS SCORE, and I appreciate that they invited me to participate in the same. It is an honor to me. Dear colleagues, today we are going to talk about the current status of the mechanical circulatory support devices. These devices can be used for the acute condition or for the chronic condition for a long-term therapy. For the acute conditions, we have various indications. Patients who are in cardiogenic shock. Now, this patient may be in cardiogenic shock because of the acute myocardial infarction. They may have acute myocarditis, that is especially seen in the children, or they may have complications after an acute MI in the form of papillary muscle rupture, leading thereby to severe mitral regurgitation, or they may have a large ventricle septal defect. Also, we use this support for the post-cardiotomy failure, especially in the patients who are undergoing open heart surgery, and we are not able to wean them off the cardiopulmonary bypass. Then we can utilize any of these mechanical support devices to sustain acute phase and lead them to post-op recovery. This may also be used in patients who are known to have the end-stage heart failure, and they had some acute insult and now they are in cardiogenic shock. So we support them also with these MCS devices. Also, in patients who had ventricular tachycardia or malignant arrhythmias, if the cardiologist, they are trying to ablate it, and if the patient suddenly goes into electrical storm, that is the heart failure, then we can sustain them on this MCS therapy. Rarely it can be used for the patients who have myocardial depression because of the hypothermia or the drug overdose. Now, how do we divide these various types of the devices? We can have the various bridges, like bridge to recovery, which is commonly used in patients who have got post-cardiotomy problem, or any acute insult where we think that the patient's heart will recover. So we give them a short-term mechanical support so that the heart will recover. It can always be bridge to decision. Sometimes if the patients are waiting for a definitive treatment and the patient goes into acute failure, then we can put them on these acute circulatory devices, and that can support the circulation till the patient's decision is made whether the patient goes for the transplant, destination therapy, or any other mode of the treatment. This can also be used as a bridge to bridge, like the patient has been put on a short-term device, but now the judgment is that patient will require the support for a long term. So then we can switch over to the ventricular assist device, which can go for the long run. Also, most common indication is the bridge to transplant. When the patient is awaiting heart transplant, he goes into acute heart failure, then we can support them with the help of these MCS devices till the time patient gets a heart for the transplantation. In some of the patients who are not fit for the heart transplantation, we can use them as a destination therapy also, so that these patients go on till the time they survive on these ventricular support devices. So how do we divide these various types of the pumps? We can divide them in various types, like if we divide them for the pump location. Extracorporeal means that the pumping chambers, they are placed outside the body. Paracorporeal, when pump is located outside the body, but it is not too far, it is adjacent to the body. It is somehow connected to the body itself. Intracorporeal, when the pump is implanted within the body, and out of the body a thin drive line comes out for the electrical supply. Or orthotopic, that is most commonly in case of the total artificial hearts. We can also divide these pumps based on the which ventricular we are providing the support. By the left ventricle, that means LVAD, or right ventricle, RVAD, both ventricles BiVAD, or if we are replacing both the ventricles with the total artificial heart. These can also be divided according to the time period for which we are going to provide the support. That is called intended use. That means if it is for the short term, like in patients where we use them for bridge to recovery. So these patients, they remain hospitalized till the time their hearts recovers and they are tethered to the pump. That means that wherever they are going, they are carrying the pump with them, which is externally placed. Or for the long-term therapy, that is bridge to the transplant or the destination therapy. Here, patient is discharged from the hospital with adequate mobility. That means that patient not totally tethered to the device. Then again, we can divide them according to the type of the pump, like pulsatile pump. These used to be used previously in the first generation pumps they had come. They were either driven through the on the pneumatic basis or electrical actuation was there. Here there was a pusher plate which was used to pump the blood forward. Nowadays, the devices which we are using are the continuous flow devices. There is no pulsatility. So these are based either on the axial flow principle, that is the axial device, or continuous flow principle with the help of the rotary pump based on the centrifugal design. Either of these may be either having bearing or they may be without bearing. Without bearing, the long-term devices which are available now, they are based on the technology of magnetic levitation, where the magnets, they provide the electromagnetic force which propels the blood out of the pump. Also, we can divide them according to the mode it is inserted. This may be percutaneous, like the most commonly used device is IABP, or in the cath lab like Impella, or another commonly used device is the ECMO. Or it may be like durable devices which are implanted inside the heart. That is HeartMate 2, HeartMate 3, HeartWare. These are the three commonly used devices nowadays. So what are the devices which are used percutaneously when we need these devices in the acute phase? Well, most commonly used device is intra-aortic balloon pump. It is a pulsatile pump. Here the pump uses a balloon inside the aorta. Balloon is inflated during diastole so that the more blood is provided to the heart through the coronary vessels, thereby increasing the oxygen supply to the heart. In systolic phase, the balloon deflates, so that way it unloads the left ventricle. In cath lab, we can use Impella CP or the percutaneous heart pump. These two devices are based on the principle of Archimedes screw, where when the device rotates fast, it displaces the blood from the ventricle into the aorta. All these three devices are intracorporeal, while in extracorporeal, most commonly used device is ECMO support or the tandem heart, which can be used in the cath lab. What is Impella device? Impella device is based on the Archimedes screw principle. This device can be placed percutaneously, most commonly through the femoral artery. The device is placed into the left ventricle. So in the ventricle, this portion of the device is placed where there is inlet for the blood. When the device rotates, it sucks the blood into the pump and then pumps the blood into the aorta through this outlet. This device is of 9 French diameter. In the catheter size is 9 French and the motor size is 21 French. It can generate the blood flow up to 5 liters per minute. It increases the cardiac output and the coronary perfusion and decreases the myocardial oxygen consumption. What are the advantages of the Impella device? It is a small rotary pump. It can be placed percutaneously, mainly from the femoral artery. It is placed into the aortic valve without the need of the transseptal puncture or the venous access, and it is very easily removed. However, what are the disadvantages of the Impella device? It produces hemolysis, although it is not thought to be clinically relevant. Also, most of the devices available can generate only partial cardiac output up to 2.5 liters per minute. But in the recent models, it can go up to 4 to 5 liters per minute. It is difficult to place in the setting of the severe peripheral vascular disease, and sometimes when it is placed into the femoral artery, it can damage the femoral artery. There are chances of damage of the aortic valve also. Tandem heart is a paracorporeal device where the catheter goes into the femoral vein, into the right atrium, across the septum, into the left atrium. This is the inflow channel for the pump. So blood is withdrawn into the pump. Then with the centrifugal force, the blood is pumped out of the pump into the femoral artery. This tandem heart is very easy to place in the cath lab, and there are no chances of the aortic valve injury. However, it requires transseptal puncture that may leave behind an atrial septal defect. It can generate 3 to 4 liters of blood per minute. What are the advantages of the tandem heart? It can be placed easily in the catheterization lab. It can supply up to 5 liters per minute of the blood flow and can be easily removed. What are the disadvantages? Well, it requires transseptal placement. It is difficult to place in the setting of the severe pulmonary vascular disease. And as in Impella, there are chances of the femoral artery injury. ECMO. ECMO is the most commonly used device by the cardiac surgeons, as well as the cardiologists, as well as the pulmonary medicine people. Its indications are the acute, severe reversible respiratory or the cardiac failure with a high risk of death, and that is refractory to the other conventional modes of therapy. The ECMO may be veno-venous or veno-arterial. In venous ECMO, we take out the blood, usually from the femoral vein. It goes into the ECMO circuit, the blood gets oxygenated, then it is pumped back into the heart on the right side, usually through the internal jugular vein. What are the indications for the venous ECMO? This is mainly for the patients who have got severe pulmonary failure because of any of the etiologies mentioned below. And these patients should have adequate cardiac pumping mechanism. That means that the heart is good, heart is not in failure. Various indications may be severe pneumonia or ARDS, like it was used frequently for the H1N1 infection and nowadays in the COVID infection also. It may be because of the acute graft versus host disease, and other indications may be bridge to lung transplant also. It can be also used in patients where after the lung transplant, there is problem with the lung and that lung is non-functional. What about the VA ECMO? In fact, VA ECMO is the most commonly used ECMO. Here, the blood is taken out into the pump through either a venous line, that is mainly through the femoral vein, or in case we are doing the VA ECMO in the operation theater after the post-cardiotomy, then we can utilize the right atrial cannula, which provides the venous drainage. And after the oxygenation, blood is pumped back through the femoral artery or through the aortic cannula in case we are using it after the open heart surgery. Also, we can have the ECMO utilizing on the left side of the heart, where the lungs of the patients are good. So here we can take the blood from the left atrium, either through the pulmonary vein or directly cannulating the left atrium itself, take the blood to the pump. Without the need of the oxygenator, we can pump the blood back or either into the femoral artery or into the aorta. So what are the indications for the VA ECMO? Well, these are various regions where we can use the VA ECMO. Most commonly used is failure to wean post-cardiopulmonary bypass or bridge to the LVAD, when we think that we can implant the left ventricular assist device, but we are awaiting for the various logistics to be sorted out. It can also be used for the graft failure, post-heart or the heart-lung transplant, and in the cases where there is non-ischemic cardiogenic shock. It can also be used for massive pulmonary hemorrhage or the massive pulmonary emboli. Now coming to the ventricular assist devices, which are used for the long-run therapy. What are the statistics in US? In US, almost 2,500 LVADs are implanted annually. And it is now seen that with the current LVADs, we can have 1 month survival up to 95% and 1 year and 2 year survivals up to 80 to 70% respectively. The three most commonly used LVADs nowadays are HeartMate 2, HeartMate 3, and the HeartWare. What are the indications for the ventricular assist devices? There are various indications. Most commonly, these are the patients who are awaiting a heart transplant. They have some acute insult. They go into the acute heart failure. They are not responding to the usual modes of the medical treatment or the cardiac resynchronization therapy, or their requirements for the medicines, diuretics, etc., is increasing day by day, or they are requiring the frequent hospitalization into the intensive care unit because of the repeated heart failure. In these patients, they may have low peak VO2 of less than 14 to 16. And these patients may have an end organ dysfunction, which may be attributed to the low cardiac output situation. Here, if we are using the ventricular assist devices, they improve the end organ circulation and organ oxygenation, improves the end organ function. What are the contraindications? The absolute contraindications include irreversible hepatic, renal, or the neurological damage, or if there is no medical adherence to the therapy, patients are not following the medical instructions, or there are severe psychosocial limitations. Also, patients may sometimes not afford the LVADs because they are costly devices. What are the relative contraindications? Well, above the age of 80, because the lifespan of the patient is not too much, we may use them for the destination therapy rather than the heart transplant. Other comorbidities where we have to think twice before we use the VADs are obesity or the malnutrition, musculoskeletal disease, where we think that the rehabilitation of the patient will be limited, or patients may have acute infection, or they may be prolonged intubation where we suspect that the chances of acquiring infection after the VAD implant will be high, or in case patient have got untreated or uncontrolled malignancy. Severe pulmonary vascular disease is another relative contraindication. What is the basic design of the VADs? Well, there has to be one inflow, one outflow. So inflow is usually through the left ventricular apex. We take the blood, which comes into the pump. This pump houses the impeller, and then the blood is pumped out through the outlet into the aorta. That is the basic mechanism. How the impeller works? The impeller may be designed with the axial flow principle or on the centrifugal pump flow principle. These are the totally implantable LVADs, and what comes out of the body of the patient is a drive line, which is connected to the system controller. System controller provides two functions. First of all, it measures the various parameters of the LVAD, including the cardiac output, heart rate, everything. And also it provides the electrical supply to the LVADs with the help of the power source. Power source may be through a battery or through the AC power. So the LVADs move blood from the LV apex to the systemic circulation in a non-pulsatile manner. That is, it is a continuous flow. There is no phasic pattern. The pump speed that controls the cardiac output, and the fundamental parameter which can be altered by the person. That means a medical personnel or the person who is taking care of the pump. As the pump speed increases, so is the cardiac output. So as the speed increases, more and more blood circulates to the body. And the system controller that estimates the cardiac output based on the speed of the pump as well as the power consumption of the pump. What are the benefits provided to the patient? Well, the VAD provides more time for the patient who are under waiting list for the heart transplant. And as I said, it may provide the destination therapy for those patients where either there is contraindications for the heart transplant or where the lifespan is limited. The augmented cardiac output, what does it do? It improves the heart failure symptoms, improves the end organ function, and on general, patient feels better. And it consequently also benefits the patients who are undergoing heart transplant because it improves the post-transplant outcome in these patients because their end organ function improves, their oxygenation is better. Now, what are the various generations of the devices? Well, the first generation devices under the total artificial heart category were Jarvik 7, Abicore, and the Lion Heart, which are now obsolete. The second generation total heart under investigation is CardioVest. Amongst the ventricular assist devices, the first one to come was the Thoratec device. which was a paracorporeal device. Then came HeartMate 1 and NovaCore. These were the devices, HeartMate 1 and NovaCore, where the pump was placed in the preperitoneal space and the drive line used to come out of the heart. The second generation devices were Micromet DeBakey, Jarvik, HeartMate 2, and the hardware. The third generation device, which is now commonly used, is HeartMate 3. Now, what are the differences between the various devices? HeartMate 2 is based on the principle of axial flow design. And it has got a very large profile requiring implantation in the preperitoneal pocket. While the HeartMate 3 and hardware, these can be directly implanted into the pericardium or into the thoracic cavity. These two are based on the centrifugal flow principle. They've got a smaller profile and allows implantation into the chest itself. However, they are more sensitive to the preload and the afterload than the HeartMate 2. They provide more accurate cardiac output, and there is a mechanism of speed modulation. That means it can slow down the speed of the impeller, or it can speed up the impeller very fast. It is supposed to reduce the risk of the in situ pump thrombosis and the aortic valve insufficiency. This is the example of the thoracic device. This is placed in the patients. The pump comes out of the body. One is goes into for the inflow channel, one for the outflow channel. This is the drive line, which used to be attached to a console. Console used to be very big, almost the size of a eco machine these days. These thoracic devices were first implanted in 1990s. However, no longer these are being used. This is the design of the HeartMate 1 or the NovaCore. Here, the inflow channel is into the left ventricular apex. It used to come into the pump, and through the pump, this used to go into the aorta. Now, this was the inside design. There was inflow channel, and there were an outflow channel. Now, these were the pusher plate, which were activated either pneumatically like in thoracic or electrically like in HeartMate 1. Pusher plates will push up, thereby pumping the blood into the outlet channel. When the pusher plate is down, it used to withdraw the blood from the heart. The second generation devices, there are either centrifugal pumps or they are axial pumps. Now, they are totally implantable devices. They provide the continuous flow. And they are very small devices which can be easily implanted into the chest. What comes out of the chest is only a drive line, which is attached to the battery backup system. These are put on the patients by like a holster sort of thing, and patient can move around. These are all electrical driven, and the examples are HeartMate 2, hardware, and Jarvik 2000. The third generation devices are HeartMate 3 and DuraHeart. Here is instead of a pump, here it is magnetically levitated. That means there are magnets inside the impeller. It is titanium housing, and impeller blades themselves have the magnetic core, and there are coils here. So there is electromagnetic coupling. This electromagnetic coupling provides electromagnetic force, which propels the blood into the aorta. And the examples of these are the HeartMate 3 and DuraHeart. Because there are no bearings here, these are magnetically levitated. There is minimal wear and tear. So these can be used for the long-term basis. Well, LVADs are not without complications. It is seen that more than 50% of the patients are usually readmitted within 6 months following LVAD implant. And what are the various complications seen? One is the infection, mainly the dry line site infection. So we have to be very careful in these patients to make sure that there is no infection. Second is bleeding, and then dysarrhythmias, stroke, in situ pump thrombosis, and right ventricular failure in patients who have only LVADs. So these are the patients who may require RVAD support also after the LVAD implant. It is seen in the literature that almost 80% of the patients, they will experience some sort of complication within first 2 years. Do we have any LVADs for the pediatric patients? Yes. Well, these are in pediatric patients. We have got miniaturized devices for infants and children which are available. And this is mainly the Berlin Heart Score. If you see, this is a paracorporeal device, which is almost based on the design of the previously available thoracic VADs. So these are pneumatically driven, where the pusher plate that is connected to the through the drive line to the console. Now, various types of the devices are available depending on the volume of these pumps. And this can be 10 ml, 15 ml, 20 ml, 30 ml, 50 ml, or 70 ml pumps. Or depending on the need of the patient, we can use the pump. This is how these devices are used in the kids. This paracorporeal device, which are attached to the body, but not inside the body. What are the total artificial heart? The previously used total artificial heart was Abacor, which is taken off the market. Most commonly used nowadays total artificial is Syncardia, which is still under investigation. More than 1,400 implants have been done. Here we have got two ventricles, which replace both the ventricles of the patient, and one output is connected to the pulmonary artery, other to the aorta. These are polyurethane ventricles, and each ventricle has a volume of 70 ml. However, in Indian patients, this device may not be implantable because the requirements are that AP chest diameter, that is from the posterior plate of the sternum to the anterior plate of the 10th vertebra, the distance should be more than 10 centimeters. And the body surface area of the patient should be more than 1.7 square meter, which is hardly to get in our patients in the Indian scenario. Do we have any VADs specifically for the right side? Well, no. There is no customized long-term implantable device for the right heart. Whenever required, we modified the LVADs to be used on the right side. Mainly, right side is supported with the help of the ECMO, or nowadays with the CentiMax support. However, there are percutaneous RVADs available. Those are called Impella RP or the Tandem Life Protect Duo. If you see, these right side VADs are mainly used either post heart transplant or post LVAD implantation when the right side is failing, or because of massive inferior right ventricular MI, or after the open heart surgery when we are unable to come off bypass. Is there any change in the design of these Impella devices compared to the left side? Yes. You see, these devices are slightly thicker. The catheter diameter is 11 French instead of the 9 French, and the motor size is also 22 French instead of 21 French. Also, you see the inlet area which is placed in the right atrium is proximal, while the outlet area is distal, because this goes into the pulmonary artery. It was reversed into the left side where the inlet area was into the ventricle, so it was more distal. Outlet was in the aorta, which was more proximal. These devices can provide flows up to 4 liters per minute. You see here, this is the Impella RP, which is placed into the right atrium for the inlet and into the pulmonary artery for the outlet. CentriMag support. CentriMag is the most commonly used devices nowadays for intermediate support to the patients. These devices are based on the magnetic levitation principle and can be used up to 30 days. And it is the most commonly used device for the right side as well as the left side support. So like you see, they are the various coils and the magnets into the impeller. So it can provide the support up to 30 days. It can be used for the left side, right side, or both the sides. What do we have in India? How many LVADs have been placed? Well, the first LVAD was implanted in Asia at AIIMS, New Delhi in 1990s. As I said, the initial LVAD which we used was Thoratec, which was paracorporeal device. Later on in 1997, we started using PCI HeartMate, where we used 5 of these pumps to implant into the patients. And the longest survivor at that time was 2 years. Since 2012, in India, 138 implants have been done. This is as per the website of the INSHLT. The most commonly used are HeartMate 2 and 3, and hardware and Berlin Heart in about less than 50%. What is the future of the LVADs? Well, the companies are cutting down on the size of the ventricular assist devices so that these are more easily implantable. And we have hardware MVAD, which is almost completing its trial and will be soon available. Then we have got Cleveland Heart, again under investigation. It is a micro-sized. Then we have got total artificial heart in the form of Bivacor, and then pre-Siron aortics, which can be placed into the aorta to support the heart. However, mind you that why such less number of the VADs are implanted, not only in India, but all over Asia. One of the articles states that the most common problem is the high cost of the ventricular assist devices. One LVAD for the support of the left side costs only 75 to 80 lakhs to the patient. And in India, most of us cannot afford it. Thank you very much.
Thank you, sir. I will just wait for Hermes sir. There are some questions there.
Sure.
Questions, can you show? Sir, there's one question. In LVAD, axial flow pump or centrifugal pump, will it make any difference?
Well, mostly with the recently available HeartMate 3, I think that will be one of the most useful device because it is based on the magnetic levitation principle. So wear and tear will be less. In axial flow, as I said, this is pre-peritoneal device, while in centrifugal device, we can put it inside the pericardium. So it makes it easier for us.
Okay, thank you, sir. There are no more questions.
Okay, thank you.
Thank you, sir. For the next session, I request Dr. Pradeep Narayan sir to guide us about what's new and essential in clinical trials for the city surgeons. Dr. Pradeep Narayan is professor and consultant cardiovascular surgeon at Narayana Hrudayalaya Rabindranath Tagore, Kolkata. He serves as associate editor of Indian Journal of Thoracic and Cardiovascular Surgery. So I hand over to Dr. Pradeep Narayan sir.
Thank you very much for the invite. It's a pleasure to be here. I'm not a professor, but it does sound good. And I think I've already uploaded my presentation, so if you could kindly play that. Very good evening to all of you. In this particular talk, we are going to be discussing some of the important clinical trials for the purpose of the exam. And what we are going to do is primarily focus on two things. Firstly, we are going to focus on what kind of questions to expect in the exams. And secondly, we are going to see what is the best way to answer these questions that you get asked. Now, what kind of questions can you expect? It could be a direct question that you can get asked on a particular trial, for example, a short note on the freedom trial or something like that. Or it could be a bit more subtle, and you could be asked that what is the rationale of doing, say, carrying out CABG in diabetics. You could well be asked that what are the long-term results of off-pump surgery. Now, to answer these questions, you obviously have to know quite a few clinical trials and which are quite exhaustive. So there has to be a minimum information that you need to remember about these trials. And in my view, what you can do or you should be able to do is to fit all the required information on one particular slide. And I'll show you in a minute how you can do that. These are some of the trials we are going to be talking about. I will not be spending too much time on the different trials because the idea is not to cover the trials, but to tell you how to be able to answer them or answer any questions that you get asked on them. Now, some of the things that we need to remember about each trial is the aim of the trial, okay? The study design, and there are some tips and tricks here. Like almost all the studies that you get asked are randomized controlled trials, they are multicentric. So you don't have to remember those things. What you have to remember is whether these were non-inferiority trials or superiority trials or trials of equivalence. Equally, you have to know your patient population, where they carried out in stable ischemic heart disease, for instance, where these diabetics, what were the arms of the study, whether 2 arms or 3 arms, and whether they were, say, TAVR versus SAVR or off-pump versus on-pump. You just have to know these things. The results, I think this is the most important part of any trial. And I feel that if you know the results, you should be able to fill these other 4 headings that I have just mentioned. Now, if you answer these 5 points for any trial, I think that should be good enough to get you a pass. However, if you want to excel, if you want to do well, you should also be discussing the strengths and weaknesses of any trials. Now, I will not be covering them because that's quite a lot to cover in a short session. But if you want, you can, you should be able to, comment on that. Now, let's start with this particular trial, the RAPCO trial, which is one of the more recent trials that have been published. And I'll show you how you can summarize this one trial in a single slide. So I want you to focus on the title, Radial Artery, Patency and Clinical Outcomes. So there is a lot of information there in the title itself. The aim of the trial was to compare radial artery with free reta and with saphenous vein grafts. Study design, as I told you earlier, it's RCT, and this is one of the exceptions where it is a single center study. The patient population, those undergoing CABG, there were 2 different sub-studies in the RAPCO trial. One was comparing RA with free reta, and the other one was comparing radial artery with saphenous vein grafts. The outcomes were angiographic patency and all-cause mortality, as well as MACE events. Now, almost all the trials, the outcomes will rotate around mortality, all-cause mortality, cardiovascular mortality, stroke, MI. So basically, MACE events and mortality will form bulk of the outcomes. That is what you have to remember. The results, if you look at the RA reta, the study reported that radial artery was significantly better than free reta in every possible way. Whereas if you look at the RA saphenous vein graft, it said that radial artery was still better, but not statistically significant. Now, as I said, you should be discussing the strengths and weaknesses, but for interest of time, I will not be getting into it. If you do wish to know the strengths and weaknesses of any trial, most of them have been covered in the Indian Journal of Thoracic and Cardiovascular Surgery in the section Critical Appraisal of Trials. You may go there, make some notes along with the slides that you have. Now, let's take a look at another trial, the ART trial. How can you summarize in a single slide? Now, we know that our trial compared bilateral mammary with single mammary, Study design, just as I said, patient population, just as we discussed, and the two arms, it's very obvious, beta versus zeta, and the outcome was mortality at 10 years. Now, what did the trial show? It showed that there was no difference in mortality at 10 years between beta and zeta. However, the mortality when multiple grafts were used was significantly lower than when a single artery was used. So that is our trial for you in a nutshell. Now, this trial you may or may not be very familiar with, but it is a randomized control trial carried out in patients who were asymptomatic but had severe or very severe aortic stenosis. It's called the recovery trial. And the aim of the trial was to assess the optimal timing of surgical intervention. Study design, just the same. Patient population, we have already discussed that very severe AS who were asymptomatic. The comparative arms were early surgery versus conservative treatment. Primary outcome, as I had mentioned earlier, composite of operative mortality or mortality from cardiovascular causes. What did the study show? It showed that the majority, almost 75% of the patients in the conservative arm became symptomatic and needed aortic valve replacement. The adverse, both the primary and the secondary adverse events were significantly more in the conservative arm compared to the surgery group. That's once again all the information you need on one single slide. Now let's stay with the aortic valve replacement and move to another very important topic, which is trials of TAVR versus SAVR. Now, again, you could be asked this question in many different ways. So you could be asked to just write a short note or partner trial or the evolute trial, or you could well be asked to compare TAVR versus SAVR. Or you could be asked even something more specific, like comparison of TAVR versus SAVR in low-risk patients. Irrespective of what the question is, you basically have to know the partner trial and the evolute trial. And in the next few slides, I'll tell you, if you just follow a scheme, it is not very difficult to remember what is there. So we know there were 3 partner trials, 1, 2, and 3. Now the partner trial is the only one which had 2 subgroups, the high-risk group and the inoperable group. The high risk was called 1A and the inoperable group was called 1B. Partner 2 had intermediate and partner 3 had low-risk patients. Now, again, on a single slide, so you watch carefully, the aim remains the same. You compare TAVR with SAVR, design remains the same, and it is a non-inferiority trial. We said it was a high-risk group, so the STS score is more than 10, and the comparative arms is transfemoral TAVR versus SAVR and transapical TAVR versus SAVR. Primary outcome was all-cause mortality, and the key finding was that TAVR had a similar 1-year mortality as compared to SAVR. Therefore, TAVR was deemed non-inferior to SAVR, and it was concluded that both TAVR and SAVR are acceptable treatment modalities in high-risk patients. Now, let's take a look at 1B. As I told, 1B was inoperable, so everything remains the same except it was compared, TAVR was here compared not with SAVR, but with medical management. And it was a superiority trial. The patients were those who were considered inoperable. The comparative arms were again TAVR versus medical management. Primary outcome was the same. And the finding was that 1-year all-cause mortality with TAVR was significantly lower than medical management. So it was concluded that TAVR should be the new standard of care in patients who were considered to be inoperable. Along similar lines, let's take a look at the intermediate risk. Now, I want you to concentrate on the areas that are highlighted. Here, nothing has changed except the valve. So the SAPIEN has changed to SAPIEN XT. The risk profile has changed from high to intermediate. And the primary outcome has changed from all-cause mortality to a combination of all-cause mortality and disabling stroke. Again, TAVR was found to be non-inferior to SAVR, and the conclusion was that both TAVR and SAVR are acceptable therapies in intermediate risk patients as well. Now let's take a look at the low-risk patients. Now here it becomes more interesting because low-risk patients, they were dealt with in 2 different trials, the Partner 3 and the evolute. Partner 3 used a balloon expanding valves and evolute used a self-expanding valve. But the basic single slide scheme remains the same. Here, once again, the valve has changed from now SAPIEN XT to SAPIEN 3. The study design has changed from non-inferiority to a combination of non-inferiority and superiority. Patient population is low risk, STS score is less than 4, and the outcome is now a combination of all-cause death, stroke, as well as rehospitalization. This study, incidentally, both the superiority and the non-inferiority criteria were met for TAVR in low-risk patients. What about the Evolute trial? Again, just name of change, the trial name change, the valve changes, everything else remains the same. The composite outcome here is though different. It is all-cause death and stroke at 24 months. Again, it was found that TAVR was non-inferior to SAVR in low-risk patient, but the superiority criteria was not met. Right, now let's move on to a different patient population group. Let's take a look at trials that have looked at stable ischemic heart disease. Now there are three very important trials: the ischemia trial, the COURAGE, and the ORBITA trial. We primarily are interested in the ischemia trial because it involved CABG, but we'll very briefly touch upon COURAGE as well as ORBITA. So ischemia trial compared early interventional strategy with medical management, optimal medical management. Again, study design remains the same. Patient population, we have already discussed that it was in stable ischemic heart disease. The comparative arms, quite intuitively, are optimal medical therapy and early invasive management. The primary outcome you have to remember, it was composite of 5 different variables, and the results showed that the event rate between the invasive strategy group and the optimal medical therapy was very similar. So essentially what this study showed was that early invasive strategy, either with CABG or PCI, does not cause any better outcome compared to optimal medical therapy alone in stable ischemic heart disease. The same finding was seen in the COURAGE trial, but here only PCI was compared with optimal medical therapy, and it showed that PCI in stable ischemic heart disease did not reduce the risk of adverse events. The ORBITA trial is one of the more interesting trials in my view, and which compared PCI with a placebo procedure or a sham procedure. So all the patients were taken to the cath lab, an incision was made, but in some patients, called the placebo procedure, angioplasty was not performed. The primary outcome in this study was difference in exercise time, and it was found that PCI did not make any difference compared to the placebo as far as the exercise time was concerned. Now, let's move to the more subtle questionings. Like if you do get asked that, what is the rationale or what is the evidence for carrying out CABG in left main stem disease? Here you need to summarize the findings from different studies because it is very difficult to talk about individual studies. You still have to know that these are the 6 randomized controlled trials that have been carried out. If you can remember the type of stents that were used in these studies, that is even better. But you certainly have to remember what these studies showed. So apart from the Noble and the Boudreau trial, which showed that PCI was inferior to CABG, all the other studies showed that there was no difference between PCI and CABG in left main stem disease. Now, you can get asked a bit more about Excel and Noble, so I'll just very quickly touch upon them. So we have already discussed that the patient population is left main stem and the comparison is between PCI and CABG. And we have already told you that these are all RCTs, multi-center studies. So all you have to remember is in the Excel, everolimus eluting stents were used. If you cannot remember that, just remember that 2nd generation stents were used. And the other important thing to remember is that peri-procedural MIs were included in the primary outcome. The study showed that there was no difference in the composite outcome of mortality, stroke, or peri-procedural MIs, but mortality on itself was significantly higher with PCI. This is something that you have to remember for Excel trial. Now, when we look at the Noble trial, the only things which were different was that FFR was used, humerolimus stent was used, and peri-procedural MIs were actually excluded in this study. This study, unlike the Excel, showed that PCI was inferior to CABG. whereas the Excel trial showed that PCI and CABG were similar in the subset of left brainstem patients. So let's take a look at another summative question that you might get asked: the rationale of using CABG in diabetics. Now, again, several studies have been carried out. These are the 6 most important studies that you should remember. The top 3 were exclusively designed to compare PCI and CABG in diabetes. The bottom 3 were subgroup analysis. But irrespective of the design of the study, what all the studies uniformly showed was that CABG was superior to PCI in diabetics. In fact, I want to make a special mention of the VA cards, which showed that CABG was so superior that the study had to be stopped very early on. Now, comparison between on-pump and off-pump, it's a huge subject. If I'm not wrong, there are probably 100 randomized controlled trials that have been carried out. I just want you to concentrate on the patency, because not many studies have looked at the patency outcome comparison between on-pump and off-pump. But still, these are the 10 studies that have been carried out, 10 RCTs that have been carried out comparing the patency, either angiographic patency or CT angiography. One of the studies, as you can see, is from India by Dr. Sajja. Now, of these 10 studies, the top 5 showed that there was no difference between on-pump and off-pump. The bottom 5 showed that on-pump was better than off-pump. Now, I think we have covered many different clinical trials, and I have tried to give you an overview as to how the questions can be asked to you in different ways. And you might be thinking that there are actually so many different clinical trials to remember, but the fact is that the number of clinical trials are actually going down year on year for the last 20 years. Some of you will be taking the exam this year. Others who are relatively junior and will be appearing in the exam in 2 to 3 years' time, I'm afraid you'll have to know these future trials as well. So those of you who are taking your exam this year, well, good luck. And those of you who are taking it later, please do remember to read these trials before you go for your exams. And thank you all for listening. Thank you very much.
Thank you, Dr. Pradeep Narayan. I think there are quite a good number of questions on the chat box. I think you have answered them directly. It's very kind of you. I have a few questions here. Any questions from the audience sitting here? Yeah. Pradeep Narayan, we have a question. What can we take back from the GOPCAP trial for the Indian scenario?
Well, to be very honest with you, I don't remember the exact findings of the GOPCAP trial. So it's very difficult for me to comment on that right now.
Sure, no problem, sir. Next question is, what are the implications of sequential grafting in clinical trials?
I mean, that is a very important confounder. There have been some studies, some observational series that have looked at sequential grafts, but there is no head-to-head comparison between sequential grafts in CABG versus non-sequential grafts. There are only what happens is people who do sequential grafts, they publish their own result. Usually these results are not supported by angiographic data. So while clinical outcomes are reported and are quite impressive, it is very difficult to know whether these grafts are all patent and the patient is doing well, or the patient is doing well despite some of the territories being blocked. So there is no evidence at all to say that sequential grafts are either good or bad.
So the next question is highlights of promote patency trial.
See, promote patency trial, the biggest highlight is that this is the first time a randomized control trial was done in India that compared off-pump and on-pump patency. It showed that there was no difference. But having said that, I think one of the biggest criticisms of promote patency trial was that they used 2 different methods to compare the patency. The They use CT angiography, and they used conventional angiography as well. Now it is very difficult because the scoring system in CT angiography for patency is different to what we use in conventional angiography. So that is one very important limitation of the study. But despite that, and irrespective of those fine those nuances, I think what it showed was that if you are good at off pump, you should do it. If you are good at on pump, you should do it, because no technique was superior to the other. I think it was down to your own practice rather than to the technique.
Sir, are there any trials for valve repair, sir?
There are no RCTs. Again, there are a lot of, there is some, when you come talk about valve repairs, there are some trials which are currently undergoing to look at device versus surgical. But as such, there is no RCT that I'm aware of that has compared valve repairs. There was, if you go back in time, but that was the Rhine trial that compared moderate MR, and moderate MR was either repaired or the valves were replaced as opposed to not doing anything. But I don't think that can be called a valve repair sort of trial.
Thank you. Just any other questions on the chat box? I think all have been answered already. Thank you. Thank you, Dr. Pradeep Narayan, for joining us.
Thank you, sir. Thank you.
I have an important announcement. Next session will be on the instruments and both the cardiac surgical instruments and CPP instruments, wherein we'll have almost an hour for the discussion. I would like to all the residents to participate actively, number one. Second, followed by that is the quiz program. Quiz program, unless you register for the quiz, I'm requesting all the fellow members, life members who would like to participate. The registration closes by 6:45. By 7 sharp, we are starting quiz. Initially, I'll be giving a demo how exactly we are doing the quiz. Dr. Prasan Simha sir is here and myself. So after that, the questions will start. If you are not registered, you will not be able to participate. And prize winners, once again, I'm going to remind, it will be for the associate member of the association. That is a resident who is an associate member. Still 1 hour is left for the members, residents to become members. I'm fast in giving the membership number also. As I told earlier, you can submit your documents later. You can become a member immediately. That facility also has been provided. So whoever is interested, kindly go ahead. We'll start with the next session. That is on instruments. Dr. Manpreet, you can just take over.
Dr. Hiramat.
Yes, sir. Please go ahead, sir.
Do we also have to register, or we are allowed to participate?
No, you have to register, sir.
Oh.
A great surgeon is nobody without his instruments. I now request Dr. Krishna Iyer, Dr. Prasanna Simha sir, and Dr. C.S. Hiramal sir to teach us the different tools of the cardiac and thoracic surgeries. I request all the students to actively participate in the session.
Okay. Shall we start? Dr. Iyer, idara?
Dr. Iyer, sir, are you there, sir, on board? Kindly get Iyer, sir, on board, please.
Okay. In the meanwhile, we'll start. Now, when we give you an instrument, it's not, the focus is not just on the instrument. It is to initiate the discussion.
The camera should be focused on the instrument. Huh?
You need to be able to describe the instrument, and then you have, after describing the instrument, you should be able to know the use for it. And typically when you get some instrument, the discussion goes towards something related to that instrument. Coronary instruments illa. One opcap. Octopus coronary probe. So if I get to give you, let us say, if I give you an octopus, we are trying to get, the understanding is that you are going to describe the octopus, but then we are going to start asking about coronary artery surgery. If I give you a valve retractor, you will similarly that. So typically what we do, many of us do in the exam is, we put the tray of instruments in front of you and ask you pick up an instrument. Now, one of the things that you do is pick up an instrument which you are comfortable with. Don't take something which you are not comfortable with, and you should be able to talk. Now, whenever you see an instrument or something, you look at the instrument, be sure what is the instrument, and then once you start talking, don't stop. And one of the things that you can do is remember that every instrument, describe it from one end to the other end and give the complete description of the instrument. If you know the name of the instrument, fine. It's also an added point. But certain instruments have got this thing. So now I will ask you all to come and pick up one instrument. Come.
The other examiners, faculty on board, sir. Dr. Shiv Chaudhary is there. Dr. Iyer, Dr. Shukla, you can also keep asking questions, sir.
As and when you can, you're all welcome to.
As we are discussing.
Come. So you are given one instrument at a time. Chal, take whatever. See what.
Hey, please return the instruments, sir. Properly.
And please see that the instruments are returned. Okay. Okay, take. Come pick. Quick. See, the more we discuss, the faster you pick up the things. Come, pick up one instrument, one cannula, and please return all the things. Okay, start taking it. Take an instrument. Take this. Take this. Take this. Take this. Rather, you take this. Come. Take an instrument. So all of you, one by one, see, the faster that it takes some of the instruments, no? Come, take. You want me to hand over, is it? You can take it. Okay, I'm going to give you. Take this rather than that. Leave that. That's not so important. Give me this. Someone has got a.
Hey, maintain distance, no? What? Don't come so close. Little distance you maintain. And everybody see that they wear mask.
Somebody take this. Some instrument is not. Okay, one of you come with
mics, 3 mics to all the students, please.
Yeah, one of the students come here quick. If you do it quickly, we will be able to discuss more. Somebody has taken this.
All instruments can be discussed. We have adjusted time in such a way that this session has more time.
Because this is take this and this. Somebody take it. Pass it around. Okay. Come. Start. Boy, come.
Take the mic and come. Where is the mic for him?
Yeah.
Somebody be there to help him with the mic. Satish.
When you come, return the instrument also here.
Start talking in the mic.
Start talking. Loudly.
Pediatric.
Can you increase the volume for his mic?
Does it necessarily have to be pediatric? It doesn't necessarily have. So just start telling it is a
wire reinforced plastic beveled tip with a side port.
What cannula?
Arterial cannula.
Arterial cannula. So bevel tipped, wire reinforced, arterial cannula with side port, and then what else?
Stillet.
No. What else here? See, I go point to point. What is this got?
Connector.
Built-in connector. And what is the funny part of this? Feel this. What is this?
This is a rigid. This is malleable.
So what is it? Is it single cast or multicast? Is it a single thing or a multicast?
It's two things.
So it is called as multicast. And then what does it have?
Stillet.
It has got a stillet or an obturator, which is blunt tip. And it does not have any wire guide. A hole or a wire guide. Now, when you get such an instrument, what do you think that will be the questions? You tell me what do you think will be the discussion on?
Aortic cannulation.
It can be on aortic cannulation, or it can be on pediatric, they say, or else they can ask you about flows about the cannula. I'll ask you, how do you select the aortic cannula?
Depending on the body surface area.
Why do you need to select different cannula for this? I will give you a simple example. Do you know that GSLV Mark III, the liquid oxygen exit to the turbo pump is as big as a 50 paisa coin. 50 paisa coin. 40 tons per minute go through that hole. So definitely 40 tons goes through that hole per minute. I can definitely push blood in this.
Problem is the resistance.
So what? Let it be the resistance. I will push. Pump is there, I push.
The aortic plaques made.
In a pediatric patient, where will I have a plaque? But still, even in a bachu, I won't do this.
Gradient should not be.
But what happens if the gradient goes up?
Spallation.
Spallation does not occur here. Spallation occurs when the roller head hits the.
That is the.
He said high velocity hits the jet and it can cause dissection, everything. But what else is another problem of having a very narrow cannula and with a high resistance? So you think it damages blood. Now, if it damages blood because
hemolysis.
There is cavitation and turbulence because it is going through a small thing. So now think, what are the components of blood?
RBC, WBC,
RBC,
plasma.
WBC, platelets, and plasma. RBC damage?
Hemolysis.
WBC damage?
Yeah.
What happens when WBCs get damaged?
Infection.
Inflammation will occur. Platelet damage?
Thrombocytopenia.
And today platelet is not just
thrombosthenia.
And no, don't use word. Now, if you start telling thrombosthenia, but I will start asking you how to do intraoperative thrombosthenia. Now, don't get into trouble. I will start asking you about what is thrombosthenia. Don't use words which you cannot qualify in the exam, because I love to talk to you about for half an hour on thrombosthenia, where you'll be blabbering. Okay. Then platelets also are platelet factor 4. What are all that? Inflammation. Again, coagulopathy, inflammation. In proteins, what are there? Albumin, globulin. Albumin, if it is denatured, what will happen?
Decreased oncotic pressure.
Not oncotic pressure. It again causes inflammation. Globulin activation. What are the globulins you'll have?
Gamma globulin.
Various globulins which are coagulation factor, kallikrein activation, all your various things are interleukins, all are activated through proteins. So you have coagulopathy and inflammation. So now you realize the detrimental effect of having this. Normally, from the pump to the, incidentally, what is the narrowest point of the CPB circuit?
Tip of the aortic cannula.
Tip of the aortic cannula. Now, what is the acceptable pump head to this thing?
Less than 100 mm.
Less than 100. In mixed day, go up to around 150 and all. But then you realize that you are trading off something for something. Okay, but the traditional answer is 100 millimeters of mercury you should have. So you should see that you always have a adequate cannula. Now I will ask you one problem. What is the problem of having too big a cannula in a pediatric patient? Sir, anytime you want to interrupt, please, sir. Sir.
Yeah.
Anytime you want to ask, please.
Sure. I'm listening. I'm learning from you.
So now, what is the problem of putting a big? If big is better. Yes. Why not bigger is better in a baby?
Because it has to make a hole in the aorta.
Everybody makes a hole in the aorta.
That has to be repaired.
It has to be repaired. Yes, I tie a purse string and I tie it.
It will become purse string and then the lumen will.
Before I even put the purse string, I put a large cannula in a small baby. What can be the problem?
It can.
Anyone can think you are having a doubt. What can happen? This itself can be obstructive. Na?
Yes,
so sometimes in a critically small child, if you put a large cannula, you may have a drop in pressure. Now you have to note that drop in pressure because that can cause problems to you. When you are delinking, you are having an obstructive cannula and you think, oh, my blood pressure is not good. And sometimes, God forbid, you may have to even remove out the cannula and keep it in the RA to return the volume or whatever. It's something which you don't want to do. So you would always like to take the, can you, now, this is at Sada level. You told that it will narrow. How many times have you actually seen a aortic purse string narrow the aorta? In
The mic is not working.
in neonates it can happen. Which is now, if you are a gold medalist, I will ask you, in which type of surgery will you have difficulty and you put a cannula in and then you have a higher chance of cannulating and causing a problem. In fact, what we tell is that the consultants in one particular operation where you may have to ask the senior consultant may have to cannulate. Where is the aorta narrow?
Wherever is the systemic outflow is low, like VSD.
No, VSD will have a small aorta, but not drastically narrow.
Hypoplastic left heart syndrome.
Of course, in hypoplastic left heart syndrome, you don't get an opportunity to cannulate the ascending aorta. How will you since you use the word hypoplastic?
Ascending aorta.
You are cannulating ascending aorta. In a hypoplastic left heart, since you asked it, how will the cannulation go through? Innominate or through the temporarily through the you may put it through the duct also or innominate artery, but you don't go to the aorta. What is the size of the aorta in hypoplastic left heart?
Very small.
2-3 millimeter, 2 liter, 1 millimeter. That very small aorta, right? So you don't go to that. In a interrupted aortic arch, you can have a smaller ascending aorta, and that's where things can be going wrong. So you understood now how you have to talk.
Yes.
The other condition where the aorta is often very small is TAPVC.
In TAPVC also.
In
So now,
TAPVC, the other thing you have to remember is that you may get away when you put the cannula and not notice it and go on bypass. But the disproportion will manifest when you're trying to come off bypass. And very often, you may not be able to come off bypass if your aortic cannula is obstructed.
very big. Okay, that's why I said when you put the cannula in, you need to have noticed whether there's a drop in pressure, because that may become the problem for you afterwards. Okay. Any other questions? Anyone has doubts about this? No. Then what is your other thing that you have? What is this? Can I open this, please?
Yeah.
Now that you have picked this instrument, now how do you describe any instrument? Again, tell from top to from one. See, anything that you do use a protocol. The simplest way is start from one end, go to the other end. So for this instrument, what is this instrument?
It's vascular clamps.
What type? If you were to be a little bit more careful before talking, would you like to have a look at the entire clamp?
Yes, sir.
Look at the entire clamp. See, in the exam, the key is don't blabber as soon as you get something at hand. Look, see. Examiners want you to look, but once you start opening your mouth, don't allow the examiner to interrupt. The moment he interrupts means the ball is gone into his court. You have to keep it in, but not like that girl who was speaking so fast that we could not hear. You have to learn to breathe.
Vascular clamp with Defect type of
serration. Okay, you said Debeke type of serrations. Okay, and then
with
it is a straight
clamp
with Debeke serration. What is this?
It's a square type of
English type of box joint or French type of box. It is an English type of box joint.
With locking.
With serrated locks and handles. Now I'm going to ask one question. I love Jumrutalaya, and Jumrutalaya Cardiac Center has actually come. You are gone to Jumrutalaya from Chennai, and then the Jumrutalaya Cardiac Center, they ask you, sir, please find out if this vascular clamp is good or bad. You are going to be using it. Now, if you choose a bad one, you are in trouble. How will you choose it?
So whether it is opening properly.
Okay, opening and closing.
Closing properly.
But then?
And then when the teeth when the teeth are approximating each other.
Okay, they are approximating each other, but are you happy? Are you happy? Now, what is the function of a vascular clamp?
It should not, it should occlude.
What is the name of the clamp? It's a A traumatic clamp.
Traumatic.
Now I will show you something which maybe if I, can you see this? What if I do this with the artery forceps? I'll be yelping and screaming. So one of the things that you can do as a simple test is that if you place it on your web space, you should not have pain. Now these are practical things. See, I'm not flinching. You want me to do it? You can do it. See? Did you pay? No, it did not pain. Whereas if I had done it with the artery forceps, you would have been screaming. So now.
So why is the difference between this and the artery forceps?
What is
the engineering behind it which makes this safer?
Yeah. What makes this safe? How is what are the type? Number one, see the serration. These are fine, which distribute. How is pressure exerted onto a point? Force, pressure is equal to force per unit area. You have been able to.
So many fine.
Yeah. So now the area, if you take this area, it's much larger. So that is one choice. Then two, the design is such that when I'm in a fully occluded position, they actually measure the pressure. They actually measure. Any other point you wanted to add?
Yeah, the arms of this are springier.
Springier.
They are more springy than the artery forceps where it is rigid.
Yeah.
So the force in the blades between the jaws is actually exerted by the arms behind that.
They actually measure
so in
it.
Vascular clamps, the pressure, these are the metal and the metallurgy is such that these are springier than the rigid ones in the artery forceps. So the pressure between the jaws when you fully close the ratchet is far less than what is there in an artery forceps. And that's why you can't use an artery forceps as a vascular clamp, because you will just tear the vessel across.
Incidentally, this is one of the questions.
Can I make a comment?
Yeah, please comment.
Yeah, you see, one of the very simple methods of understanding, there's a longer ratchet in all atraumatic clamps. And secondly, when you apply the clamp fully, that means using all the ratchet points, if you hold it against light, there'll be a gap in the middle of the blades.
There's another thing, because all of these are, because in microvascular surgery, have you heard of Ackland clamp? They actually, all these are supposed to be, when they're a vascular clamp, they're supposed to have pressure testing done for closing pressure. Okay, they are supposed to do the closing pressure test. Now I'll ask you one question. You are in a remote village. You have a vascular injury. There is a stab or a bull gore injury in the femoral artery. I have only general surgical instruments. Now this is a reality. Yeah? I have only artery forceps. And there's a bull gore injury and the femoral has got, I need to repair this. Now, can you tell me what is the way I can manage, what are the ways in which I can manage? And now I have to clamp the vessel. Now, how do I clamp this vessel?
You have to go for the proximal and distal.
Yeah, you have to go and get proximal and distal. I'll have a finger here. I expose the femoral artery. I got proximal and I've got the. But now I have to clamp to do the surgery. But I have no clamp. I have no vascular clamp. What can you do? This is a practical thing for people going in tier B and C cities.
Loop around and snug it.
One is loop around and snug it. But to loop around and snug it, yes. But sometimes you need to actually clamp it. Now I want you to clamp it. And I have only mosquitoes and artery forceps.
You can use rubber shot and.
No, rubber shot will make it all the more better. Worse. Can I have a glove, please?
Yeah.
One of the ways of doing it and to convert a traumatic clamp into a traumatic clamp is to see that you don't use a ratchet, but you can take the glove and wrap it round. And I gave you the simple test. No, do this. You do not use the ratchet, but you use you take the glove. Finger of the glove, cut it and place it. This is actually, see, because today you all have to do surgery in tier B and C cities and you may be caught unaware. So now this, when it is placed without clamping on the ratchet, you have to adjust it such that this can be life-saving. Huh? Remember, as a cardiothoracic and vascular surgeon, you may be called to small nursing homes in rural areas, and you have to be able to do this. So one of the ways of doing it is, or even in your own hospital, suppose a clamp which is not there for some reason. Can you see now? I am now converted, and you have to test it on your web space, and I have made it into a traumatic clamp. I have made it into a atraumatic clamp. Remember, this is more for a practical use. Okay. Yeah. Next, somebody.
Can I just talk for a second, Dr.
Yes, sir.
Prasanna?
Yes, sir.
Ajay, I want to see this clamp little carefully. Can you show it to me?
Yes. Yeah. Another thing that we wanted to, we forgot. Sorry. I think you're asking for DeBakey and Cooley.
No, this one, the one that you just demonstrated. I think it is originally made for it is a PTA clamp.
Yes, sir. I was going to ask that only. The next thing is where is this specifically used? This sort of straight clamp. This was used for what surgery? It comes in pairs actually. It comes in pairs. Which surgery?
For PDA.
Yeah, for PDA. It can also be a longer version of this can be used also in aortic aneurysm surgery. Okay. So the discussion will now go to PDA. If I like Dr. Vinayak Shukla was inviting you to talk about PDA, they will ask you about PDA ligation. And one small tip for all of you when you're talking of PDA ligation to make it easy is do not forget to say that I'll have proximal and distal control. I will loop the aorta above and below. Whether it's being done in your institute or not, tell that, because otherwise you'll invite too many questions which you don't want to get into. Okay. Now, one more last thing is in the fire serrations. You said something about DeBakey and Cooley.
Show a closer view of that tip of this vascular clamp. I want to see whether it's a triangular tip or is it
can we focus that? I'll just bring it there.
Cross section, is it triangular or is it rectangular?
It's sort of neither here nor there.
That's okay. You can tell me.
Either here or there. It's just something. Now, what is DeBakey and Cooley serration? But incidentally, it's DeBakey, sir. Here.
Okay.
Is it?
It's not a Cooley.
Not a Cooley. I was thinking it's not a Cooley. It's a DeBakey.
2 and 3.
1, 3.
2 rows.
1 and 2. It's 1 and 2
or 2 or 3.
It's 1 and 2 rather than it's 1 and 2.
1 and 2 would be Cooley then.
No,
it must be a triangular. Then
no, it's not a 2 and 2 parallel Cooley. Now, what are the types of serration?
Sir, Cooley and DeBakey.
What was the difference?
Sir, in the Cooley, there are two interdigitating, two on one side and then one projection on the other side. They interdigitate with each other.
Yeah.
In a DeBakey kind, it is
Cooley. Cooley, it was like this.
In DeBakey, it is two projections on one arm and the other two projections on the other arm.
Yeah, and in a Cooley clamp, you used to see markings on the side. Is there a Cooley clamp? But do you know why the clamp had markings? A Cooley clamp. This is not a Cooley clamp, but anyone has a Cooley? Is there a Cooley clamp? Is there a side biting clamp? Is there a side biting clamp? I'll open it. Now, a side biting clamp, there is a thing. What is this clamp, Bosch? You know who Satinsky was? Victor Satinsky was an American surgeon who devised this. And what was this originally? Why did he develop this? No, he did not develop it for RA appendage. He developed it for, he was a general surgeon for what? Portosystemic anastomosis. He developed it for portosystemic anastomosis. Now, see, can you see this the serration? This is a classic DeBakey.
May I ask you, historically, which operation was this most commonly used for in cardiac surgery? Historical, because probably most of them have never seen it, but they should know.
In a closed mitral.
Closed mitral valve electroatrial appendage.
Appendage was to be. This is, we will now something. Now, if you have set lines on it, it is called it looks with the Cooley serration. It's called a Cooley clamp. Why did he have those markers? And traditionally, see, many people assume it is 5 millimeters, but I asked Cooley himself and he said, no, it is 4 millimeters. And he had a specific reason why 4 millimeters.
Today morning's history of congenital
History
heart
of
surgery.
cardiac
What
surgery.
shunt?
Because
What
many
shunt
people
was-
got 4, 5, 4, 5. But I specifically asked him, sir, was it really 4 when he had come to India? He said, yes, it was 4. Why did he do that? 4 millimeters. To size the
Give the mic to him.
graft. Which anastomosis?
Get the mic.
Share the mic. Which anastomosis?
The subclavian to the PA.
No. One subclavian to PA was not the. If you say
You don't
Cooley,
need to size that.
there is no need to size that. It is flow regulator is the resistance
So for
across.
the Cooley shunt between the outer and the PA.
Waterston Cooley shunt. If even a millimeter difference would make a big difference. He wanted to target 4 millimeters. So he kept the markings at 4, not 5. But many people think it is 5, and some manufacturers, without knowing, are making it at 5 millimeters. But it's supposed to traditionally be at 4, so that he could make it exactly 4 millimeters. Okay. Now you sit down. Now if you are given this instrument, again, they can ask you about vascular exposure. A question for you is, you have this. Where all do you use this in cardiac surgery?
Sir, for side biting the aorta for proximal.
Okay.
In OpCap. Then we can also use for right atrial.
Not in, only in OpCap. You said side biting in OpCap. You on pump you don't use it.
We can use.
You can use it.
For proximal.
See, now the moment we thought you said OpCap, then on cap, then I'll ask you proximals first, distals first.
Yes.
See, the discussion can keep going on forever. Okay, then.
There's a Debicki type of serration. Relatively.
Where else do you use it?
For the right atrial appendage.
Okay, right atrial appendage. You can to side any
side.
Yeah. Now Now one of the things when you are describing this instrument, how will you describe it? You have got a atraumatic this thing, and here what are you going to say? It is angulated and curved on the flat. The term uses it's curved on the flat. Okay. Now I'm going to ask you this thing. Tomorrow now this is just I'm asking various types of questions. You can be asked a cardiac question. You can be asked a vascular question. I'll tell you that there is a stab injury has occurred. Why I'm asking this because many of you people think cardiac surgery is only cardiac surgery, but you may be called in for trauma. There is a stab occurring and it has penetrated right here. You open the abdomen and you find the IVC is injured. And you try to put the clamp and then you realize that the retrohepatic IVC has been torn. So I'm not able to place my clamp. Cardiac surgeon has to be able to expose every vascular structure outside the neuraxis. That is for the neurosurgeon. Now you have the IVC, which is retrohepatic IVC tear has occurred. Now think how we would manage. I'm not asking cardiac surgery. Now you thought, no.
I'll expose the IVC and side biting.
I can't place the side biting clamp. There is retrohepatic. Can you think? This is actually given in your general surgery textbook, which is why I'm asking you this. There is a figure in general surgery on how to do.
I look proximally and distally.
I look proximally and distally, and immediately hypotension worsens. IVC is clamped and zoom, the BP drops. Now, see, this is where your general surgery textbook, a cardiac surgical application of in a general surgery textbook. Pringle maneuver. Why will Pringle maneuver help you here? It is a retrohepatic IVC. So now you need to buy time to be able to get this thing. So what is the way you can do? Extend your incision up to the upstairs and then do what? Everyone is nodding, but I want you to know what can you do. This is trauma surgery. Cardiac surgeon will be called in for trauma. You didn't expect. I'm not going to ask you about it. What you can do is what is called. Have you all heard of a Schrock shunt? Not heard of a Schrock shunt. Please go back to your general surgery textbook. You can place a purse string in the RA and take a chest tube or any tube and insert it from the RA to the IVC. Snare the IVC, and that has got multiple holes. You snare here, you snare here. The intervening section don't have the holes. You understand? So it will pass through. Now you can manage it. We have dealt with it when we were in cardiac surgery resistance with trauma. So unfortunately, you all are not handling trauma, I think, isn't it? That's why you don't know it. But reality, when you pass MCHs, you're going to handle trauma. Yeah. Which is your other instrument? I just wanted to give you
another common use for the Satinsky is to loop the IVC.
Loop the IVC.
Very standard adult patients.
What is this?
So single piece angle plastic arterial cannula.
Is this an arterial cannula or an aortic cannula?
Aortic cannula.
It is an aortic cannula. Why do you say that? And what is the use? What is this?
It is a guard, sir.
A non-adjustable guard. Well angulated.
And it has a blue line.
What is the use of this blue line?
Sir, it tells the bevel tip, sir.
You have to see. Remember, different companies have different ways of. Some will have along the axis of the bevel. Some will have it opposite. So you should have examined it beforehand. Now we did it in the accidents. We dealt with not able to no blood coming out, this, that. So we are not going to discuss that again. Yeah. Next, some other.
Danger. What's the danger of using this cannula? What do you have to be very careful about when you use this cannula?
So it should be directed along the greater curvature of the aorta.
How can you direct an angled cannula into the greater curvature?
The bevel tip will be towards the lesser curvature.
Bevel tip towards the lesser curvature means like this, beta. If you want to do that, then you have to see that your purse strings are placed in such a way that you know where you are. But that's where there's a controlling plan.
The angle is not meant to go inside. The angle is meant so that the aortic cannula goes away out of your field. So the tip is more vertical. So the tip remains vertical and your cannula goes away.
Yes.
The most important problem when you push it in is that you may push it into the innominate.
Okay, that's what I was.
You get selective cerebral perfusion, which is high flow, and that can be disastrous. So when you put this cannula,
we discussed that yesterday, selective perfusion in CPB accident.
And how do you place it? Sorry. Yeah. How do you insert it?
How do you insert it? Now, do you put it like this or like this and rotate it?
Like this.
You've given the answer.
Like this, and then I'll rotate.
Why do you rotate it?
So that the flow.
Insertion of this angle tip to cannula, insertion is easy. It will always go like this.
Like this.
Suppose this aorta, it goes like this, and then you need to rotate.
Rotate it.
You can't put like this.
If you put it like that, you will dissect.
Dissect the aorta. This is a plastic tip. You have metal tip cannulas also. So insertion of an angle tip cannula always goes like this. Insert. Then rotate. That's where the civil diaster is passing. Okay. It's very important.
and when you rotate, it rotates freely, then you are sure that it's in the lumen.
Intraluminal.
If it doesn't, if it resistance to rotation, that means you are either dissected or you are not inside the lumen. So that's the second.
Okay. Another candidate come. So we are assuming to get the same sort of. We leave this because this is just a. Now you take that. Yeah, you take this. Can I open it?
Yes.
Yeah. Where is this original? Where does it actually? Where was this first used? The name of this instrument is a Ranger, agreed. But where was it? Where is? We have borrowed it from some other.
What Ranger it is? Is it just Ranger or something?
It's given another name. It is actually used for some other surgery. Some other surgery. Saliva. It's a pituitary Ranger. It was originally used for transnasal transnasal. It was done for that. But where are you using it in cardiac surgery?
Also for vertebral disc.
Pardon me, sir?
Also used for vertebral disc surgery.
Decalcification of the mitral valve and aortic aneurysm.
Since you asked me, you asked vertebral disc, I just want to ask you something. The neurosurgeon urgently calls you for massive bleeding when he is doing a disc, discectomy or whatever, and he tells you, I'm having massive bleeding. Where do you think he may have injured? What he may have injured? You are called now. Cardiac surgeon, sir, said discectomy. He's saying, I'm getting gush of blood during a discectomy. He has chewed up what structure to cause massive bleeding. What is the big artery in relation to the spine? I mean, above T4. Not anterior spinal artery is a very disc. The descending thoracic aorta, people have done it. We have all got calls. If you are in a hospital where there is a teaching hospital, you will have people doing spine surgery, and then suddenly somebody is calling, especially with microdiscectomy and all those things, they are encountering it more and more. Okay. Now, where do you use it in cardiac surgery? In mitral valve, you are really using this. Have you seen it really big use for mitral valve? Why more in the aortic surgery? You can use it theoretically in the mitral valve, but then there's a problem. What is the difference in calcification in the mitral valve and in the aortic valve? In the aortic valve, you're going to have a plane where you can get out most of the time. In rheumatic calcification, you may not be able to remove it, but in aortic rheumatic calcification, you can still get the plane. In MAC, degenerative MAC, you may be able to dissect it out, but that you don't use a ronger. You will have to dissect out. That's another thing, but that's okay. Tell me the steps of decalcification of the aortic. Suppose you don't have this ronger, what else can you use? In Dumbratalaya, there is no ronger. You can use an Alice. Now, when you use this, how do you actually use it? How do you use the ronger? You grasp it, and you don't actually you twist and rotate it. It forms the plane and it comes out. And why do you decalcify the annulus?
The valve fixing properly.
The valve, if you have a wonky donkey up and down, you will have paravalvular leak. Number 2, if I take a suture through calcium, what will happen? It will. Why does it cut through? It cracks. The 3, if you don't remove the calcium, Dr. Sampath Kumar will be after you if you don't remove the calcium. Why? Your annulus expands. All that fibrosis, calcification, everything. So, common complaint which I have seen, which many the thing is that many people put too small a valve because you have not appropriately decalcified. Now, I'm going to ask you one question. Which is the danger area for you during decalcification of the aortic valve? What are the danger areas when you're decalcifying, where you can run into certain problems and what? See, you'll see how the discussion will go into AVR, everything. Where are the danger areas in decalcification of the aortic valve? NCC, RCC junction, what is the problem? Conduction. Okay, you may get conduction anomaly. That is why it's all the more important to grasp and twist and not cast and excise. Huh? But then, in any other place where it is very important, here the ostium, yeah, but you don't, you have to delaminate and get it. That's if it's there. Then,
what other important structures attached to the aortic valve annulus?
Annulus, that is
through the curtain.
Aortomitral curtain. You can perforate the aortomitral curtain. And I will tell you one thing. You do the decalcification, you have closed, you have put in the valve, you release the cross lamp, and then you start seeing blood coming up, welling up. AV dissociation. What AV? There is no AV group here. I am seeing blood welling up. Posteriorly where?
Let us
There.
see if they can answer this.
Anup Sood. The key is Anup Sood. You know who Anup Sood is? The famous article by Anup Sood. Now I have done decalcified. I put the valve in, I release the cross clamp, and I find gushing blood coming out from and I'm not able to see. I look at the aorta, I can't see, but there is blood coming. Up, up, up. It has come up to the level of the incision. Now it is pouring out. Your this thing is becoming, pant is become wet.
Already
You
wet.
don't know whether it is wet because of urine or blood. Now it is starting to drip on the leg. You don't know whether you are peeing. No, you put the clamp back again, and then you put the clamp back in, bleeding stop. Again I remove the clamp. Again bush. Anyone? Where is it? In here the NCC. Okay, the LCC more towards the LCC. Where is it going to bleed from? From the transverse sinus. Bleeding from transverse sinus is occurred. Deal with it. Deal with it. See, let me tell you, cardiac surgery, in fact, cardiac surgery, in fact, in pediatric surgery, the big work which is done is that what differentiates the center which is doing good work from excellent work is their salvage. They are able to salvage those which are wasted. First is to prevent. But if you run into a problem, they have found that what differentiates the excellent center from the good center is the ability to salvage issues. Now you have to salvage this point. How will you salvage? Your cross clamp arrested. One of the things I will tell you honestly, which are the things you have to do is, when you realize this has happened, call for one of your seniors. If you are the only cardiac surgeon in Jodhpur, examiners will want you to be a safe surgeon more than anything else. So you have reached, you think the limits of your competence. I will call for help. I will call a senior surgeon. I call my senior associate. I will appreciate that, because you realize I don't know how to handle this. I'm not confident of handling this. But you should know next what are the things to keep ready. What else will he do? What will your senior do? Or you may have to do it one day. Next, what will you do? You recross clamp the heart, bleeding, stop. Now what are you going to do? You're going to deliver cardioplegia. You have to open the aorta and deliver cardioplegia. If you try to do cardioplegia, it will all come out through that hole. It's bleeding. No? Next, what are you going to do? You have to explant the valve, and then what is that? There is a hole there, no? You'll have to patch that area or find suture, patch, do anything you want, and then reimplant the valve. Now I will give you a worse scenario. You did all that nice job. You again close the aorta. Now you close the aorta, you open it after doing all this. Again bleeding starts. Bleeding.
Looks like you've been through it.
Yeah, you things are which you don't want to happen in life, but it is always you think, Sala, your boss is the what operation he does, he gets into all problems you think. But then one day, let me assure you, you also will face these problems. Now again, it has started bleeding. Yeah, you called expert hat. The expert hat is not available, and expert hat says, please do it yourself. Huh?
Use the mic. Use the mic.
Yeah, tell it loudly. How do you use the connection to the LA?
Can you use the mic?
Can you use the mic?
So you create a fistula to the LA.
How? You incise the dome of the LA and you suture that LA up lower. You make an incision like this and you suture this lip to the aorta so that the bleeding internalizes. Understood? Any other? So these are ways. See, you must remember that internalization of bleeding can be one of the biggest saviors. Do you know anywhere else where internalization of bleeding can occur, can be done? not even an original metal. Even now we can do it. In what is that called as? Cabral fistula. So there are different ways of cabral fistulation that can be done. Cabral did it by wrapping and connecting it to the RA, but people have actually sewed a patch and taken a graft and connected it to the so that it internalizes the bleeding and the patient does not exsanguinate. Okay, next next instrument. This. Describe this instrument.
Gundry's self-inflating retrograde cardiac.
What is Gundry's self-inflating cardioplegia, retrograde cardioplegia cannula with and adjustable cord and still. Okay, I will ask you one simple question. How does this self-inflate?
When we insert the actually because of pressure, the blood will rise and it inflates and then.
No, but how does it inflate?
The hole.
The hole is here. If you see carefully, there are holes inside also. So when the blood passes, it also inflates. Now I will ask you a question. What are the precautions that you take when you are introducing this?
So after putting all the cannulas, aortic and venous cannulas, then I have to find the location where to insert.
Speak a little loudly, please.
First, I have to find the location in the RA wall. I will take a first ring in the RA wall, and then with my
where in the RA wall?
Like anterior, from the appendage to IVC, a 2/3 distance distally and 1/3 approximately. So
should not be in the incision. Okay, then next.
Next, with my left hand, I will insert the cannula with my right hand. I will see the coronary veins behind.
Incidentally, I do it ulta. I'm opposite handed. Okay, then.
Then I will insert it and I will withdraw it. I should not push it fully.
Okay, now where do you push it to? Which direction do you push it? To the left shoulder. Now, after putting this cannula in, if it's not a redo, what is the precaution that you have to take?
Then while giving PGA, the pressure should not go more than 40 minutes.
One is okay, but another thing that you should do, I always pull back the acute margin of the heart and peer down. What is that I'm peering down when I'm administrating this cardiac pressure with it? You put it, when you put it too deep in, you said don't put it too deep in. Why did you say don't put it too deep in? The middle cardiac vein. Now, where middle cardiac vein is parallel to what artery? PDA. So, what you have to do is withdraw and see whether the middle cardiac vein is being perfused. It obviously can't do it in a redo. Any other ways of? Okay, I will give you a scenario for this. This cannula is put in. You start cardioplegia. The pressure shoots up high and suddenly drops. Coronary sinus perforation. If perforation occurs, how will you handle it? You don't have to cool the patient. Coronary sinus perforation, what?
Or we can do it.
Why do you have to cool? No. What LA? You have perforated, it has gone outside the heart. So now you have to flip over the heart and you have to see where the tear is. Typically, this becomes a mushy area. You may have to actually take a patch and take a fine suture, and you may think it's easy to just suture. Unfortunately, it's easier said than done, but you may have to suture it. Now, can you tell me an absolute contraindication? Huh? Yes. Why, if you put it in a left SPC, what will happen? Where will it go? Cardioplegia will go where if you give it to the left SPC?
To the systemic circulation.
It will go to the systemic circulation. Okay. Anything else, sir?
Tell me who first used retrograde cardioplegia?
Who used retrograde first? Who used retrograde? If you don't know the answer for anything in cardiac surgery, there are usually two people. Either you say Cooley or not Debeki. Debeki was Cooley seems to be doing everything. Other person
Even before.
much before Cooley. Lily high. Yeah. And incidentally, do you know how to? If I don't have this cannula, what are the ways that you can give it? Retrograde. I want you to give retrograde, but I don't have this cannula. What are the ways of giving?
Before these cannula became available, it used to be, we used to use.
Yeah.
Open the RA.
Open the RA, take a Pershing, put a olive or a dressing and give. Number one. Number two, any other way? Something to do with the person who popularized bioprosthetic valve. Who popularized bioprosthetic valve? Carpentier. Did Carpentier, is his name associated with this? Apart from putting a purse string and tightening it and putting a catheter or an olive or something inside.
Pressurize the RA.
How do you pressurize the RA?
We can snap both the three-way
And then what? And then?
and give the bleach and the
Why
RA.
did you go to the PA? You have to clamp the PA, you have to clamp SCC, IVC here, and this was called as Fabiani and Carpentier technique. Okay.
And where does this cardioplegia come out when you're delivering retrograde? How do you drain it?
Where does it come out from?
Coronary artery.
Coronary artery, but where does it drain?
How do you complete the circuit?
You have to vent through the root.
One is through the root. Then is that the only way? One is it can efflux through the coronary arteries. Agreed. Any other thing? Have you seen the retrograde cardioplegia being given with the RA open? No. The RA is open and retrograde cardioplegia is being given. You will see blood coming back from some other place. From the Thebesian vein. So this is a bypass circuit. That's why RV may not be very well protected because it can shunt across and come through the Thebesian veins also. So one is through the reflux through the artery. Okay. What is this?
DLP.
That's what? You should use the word discovered to manufacture. What is this? See, because all of you want to do only one operation in life. What is this? What is this? Yeah, do you know who invented this? You'll use the word invention because it was his invention.
Netherlands.
Yeah. And who did it? You know the name? The seminal article in JKCVS describing this. It wasn't looking like this at that time. There were two long things, but they were. Eric Janssen. So Eric Janssen described it. And why is it called octopus?
The previous first generation.
Even this generation.
Has 8
Not 8 tentacles. These are like the sucker parts of the octopus, whether it was first generation, second generation. But the thing is, it is called octopus because it is like an octopus sticking onto things. Now I want to ask you, how do I manage when I lift up the heart? Why does hypotension occur? When you dislocate the heart to do CABG, hypotension occurs. What is the reason for hypotension?
Because the heart chambers are getting compressed.
Which chamber is getting?
Mostly RVOT.
The RVOT is getting kinked and we lose preload. How is it managed?
Wide opening of the right fluid. And we can displace the heart towards right.
Yes, okay. One. Then two. You are having hypertension. What are the things that are done next?
Managing.
Why? What? You increase the preload by? What are you trying to do? You are trying to distend the RVOT, which is getting thinned by increasing the filling pressure of the RVOT. So, understood? So you give Trendelenburg position. Number 3, can I give dobutamine or milrinone at this stage? Is it a
Dobutamine should not.
and milrinone? Madam was giving one big lecture that day, no? So you think dobutamine or milrinone, what will they cause? They're not dilators. The last thing that you want is dilatation. Isn't it? You don't want the SVR to fall. So then they give phenylephrine, everything. Now, we have already discussed this. Which is the vessels, what is your strategy for revascularization in OPCAP?
She's not being separated.
So the collateralized vessel is done first, and then the collateralizing vessel. You always try to do which vessel first? As far as then the next thing is you always try to do the LAD first, because even though you have flipped the heart, the lima will continue to perfuse and you don't get the vicious cycle. The last question that I will ask for OPCAP is this: what are the indicators for you to convert? Are you a person who says, I never convert in my life? Or you have to convert? You have seen conversion? What are the things that make you want to convert?
Intractable arrhythmia.
Okay, definitely if you have asystole or fibrillation, you better convert. Don't keep shocking the patient and continuing, because I want to have 100% OPCAP rate. Number 1. Number 2, intramyocardial difficult anatomy, I want to convert depending on the skill of the surgeon. Difficult anatomy. Then 3, hemodynamic instability, where the anesthetic, don't keep forcing the anesthesiologist. No, I've got some more stitches, just few stitches. You've seen that happening, no? By the time the next 3 stitches are put, fibrillate. 4, difficult exposure, which is you as a beginner who are doing OPCAP, which is the case you will not choose for OPCAP. OMs, number 1. Okay, 2. So OM, PLV, all are, that's a semantic. Then next, low EF, dilated heart. If the PA pressure is high, you will not take. If it is a squat heart, you see, no, some hearts are conical and some are squat. How do you make a squat heart conical? You do use what? A squat heart is made.
Starfish.
You apply the starfish. Apical suction device is applied to make the squat heart conical. Why does a squat heart create problem? Why does the squat heart create problem? What makes hemodynamic instability occur in a squat heart? No. What happens is MR settles. The squat heart is having MR and globular dilatation. It's more preponderant to MR. So if you have a TE, you may be able to see MR occurring is a very bad sign and you may have to convert. Okay. Next instrument. Any other points, sir?
No, fine.
What is this instrument? Will not open it. Okay, IMA retractor. I want to know, there are 2 blades here. This is who originally, what was the original IMA retractor described by whom? Favalaro. This is not actually Favalaro's retractor. Favalaro's retractor was what? It was actually a table mounted retractor. Okay. Now, are these 2 equal? Why? Which is big and which is small? Why is it one big and one small? Not at the chest, because the sternal this thing is angulated, right? At the manubrium sternum. So you need to have the longer side here, and the manubrium sternum is angulated down. If you do this, it will tip over. Now they will ask you all about IMA They can ask you about how to harvest IMA. What is the cautery setting at which you are doing using IMA? What cautery setting is done to harvest IMA?
Loudly, please.
Loudly. 20, 10, 15, something, but always low setting. I want to ask you, what are the methods of harvesting IMA that you know of? So, see, it's always good to be backseat driver. You're always the backseat driver makes the most noise. First he answers, then others answer. What are the methods of harvesting IMA? You know, you don't know. You don't know. Somebody else can tell? Skeletonize? All skeletonize has got nothing to do with pedicle and free. Method of harvesting has got nothing to do with pedicle and skeletonized. If there is something skeletonized, semi-skeletonized and non-skeletonized. Okay, you can have a virgin, like, have you seen these things being done? You can have only the bare IMA taken. Some of us, like I, take only the IMA. I don't take the accompanying vein. What is the advantage of non-skeletonized technique? Damage to the memory, no, it requires more skill. One, it is longer. Two, if I want to take a bima, which is the method preferred? It causes less renal devascularization because the collateralization by the branches of the IMA are being maintained. Okay, the IMA, when it gives branches, can have branches which form Ys like this. So if I clip here, I can keep the Y intact. Okay, and that may maintain external vascularity. They can ask you all about BIMA. They can ask you about art trial, whether BIMA.
I have one question for him. Is this a left mammary retractor or this is a right mammary retractor?
Is that mammary retractor left-sided or right-sided? This is right-sided, no? And then you ask the sister for the left-sided retractor. You can flip and you can change. It is adjustable. Okay. Next, what is this?
Somebody has put in the question box, he wants again to explain the difference between DeBakey serrations and Cooley.
Okay.
So I've just pulled out this diagram. I don't know if it's visible there.
Yeah. I think, yeah.
Can you see?
Yes, yes, sir. We can see it.
Now on the top is the DeBakey, which is the 1:2. That is one groove on one side and two on the other side.
Other side.
Second one is DeBakey again, but 2:3. Three. And this last one is Cooley.
Cooley.
Now why is this triangular shaped? And this is mainly used for the PDA clamps and coarctation.
2:2.
It is 8:2, but also you can see that the ratchet is triangle. That means the approximating edge is narrower than the.
Okay. So you should be able
The idea is that you can take a curved needle and when you suture, then that slight gentle curve, you can get a little more tissue of the duct PDA in that, and the suturing becomes a little more easy. So that gives you that extra 0.5 millimeter of space to put the sutures. So these are the differences between the DeBakey and the Cooley clamps.
There is one more called Castaneda serrations and Castaneda clamps. Have you seen Castaneda clamps? Typically, wherever neonatal surgery is done, Castaneda. Castanedas are transverse serrations, but they're interlocked. Okay, Castaneda, Aldo Castaneda, who pioneered neonatal surgery, made Castaneda clamps. Okay. This.
Venous canvas.
What venous? Metal tape. Multicast, metal tape, lighthouse tape, bevel, wire reinforced cannula without a built-in connector. Why is there wire reinforcing? Durability? No. Why is there wire reinforcement? It won't get kinked. Whereas, where is any other? If I bend this way, it's already kinking. Here I have made it into a knot. Okay. Then DLP, they can ask you. Now, do you know who introduced this? This was designed by whom? Pacifico. Who is Pacifico? Cardiac surgeon, cardiologist. See, people cannot not know these names. Yeah. Pacifico was a famous cardiac surgeon in University of Alabama, Birmingham, Alabama, UAB.
Not learned, read long-term results of valves. Follow up.
Why did he design this? What is the advantage of this? Why is there a metal tip? Yeah, the favorable ID-OD ratio. What are the side? Which branches? Azygous and and the hepatic vein. Okay. What is this? We discussed this, isn't it, yesterday? Per string on the SVC, direct SVC. We have already discussed it yesterday, sir. This. I will ask you one question. I have injury to the posterior wall of the SVC. And it is bleeding. I cannot see the bleeding, or posterior wall of the IVC, or posterior wall of the aorta. It is bleeding torrentially. You say, what is your tendency? Try to lift and take one bite. It does not stop. How will you manage? SVC to RA bypass, you can go on cardiopulmonary bypass, but now SVC posterior wall is torn. I go on RA bypass, but I'm getting bleed. What is the goal in any surgery? I want a dry field to be able to operate. Now I just bleeding. SVC bleeding. I put the RA in and I put this, and there's a bulky like thing sitting there, and I cannot see all the more. Cannulate innominate vein. Correct. You can cannulate higher up. Innominate vein cannulation can be a short note for you. But no, innominate vein can be cannulated. Next, what you do? No transecting. You open the anterior wall of the SVC, go inside, see the tear and close it. Remember, you don't even aorta posterior wall, if it is torn and you cannot this thing, you may have to open the anterior wall of the aorta, suture from within. Who described suturing from within? Historically, who described suturing from within? He's a transplant surgeon. University of Pittsburgh. Not University of Pittsburgh, yeah. But Krishna Bhadan was South Africa. Very famous. He's Pittsburgh, that is Stanford. He's a transplant surgeon. He described it actually for he described it for revolutionize the management of posterior injuries. Not cancer. Startzel. Startzel was the one who described suturing from within. He actually did it for transplant, liver transplant. He went about doing all sorts of transplants. No? So to manage both the injuries and this thing, he described suturing from within. Okay. Who described vascular anastomosis? Alexis Carrel. And what was so different about him that made other anastomosis different from what he did? Others flopped. He succeeded. He described not the bevel cut. He described triangulation. What was to happen is when people were trying to take the wall, they would hit the posterior wall and cause it. He described making the posterior wall stay away, making it into a triangle and joining it, for which he got his. Okay. Next instrument.
So just one question, Dr. Prasanna.
Yeah, sure.
They will surely be asked, how do they cannulate the IVC if they are given the Pacifico?
Yeah, Pacifico cannula, cannulate the IVC. ASD, you are doing a ASD, specifically we'll ask him that. ASD is going to be done. And you are asked to do the case. Have you done an ASD? Now how did you cannulate? You have to answer, boy. You know you don't know. Then you have to speak. Somebody else volunteer, please. Someone, how do you cannulate the IVC? Irish, come here. You have to talk. In the exam, every second, you are supposed to be exposing your brilliance to the examiner. Let me tell you, final year MCH candidate should actually be having more theoretical knowledge than the examiner. He should be able to rattle things which I don't know. But what is the advantage of the examiner? They have got 100 years of experience. Each individual has 30 years of experience against your limited experience, which makes the difference there. But you should be knowing better theory than him technically. Where did you go? Did you go straight into the IBC? You go into the body of the RA and then you take a turn around and you slip it into the. Why did you do that? Because you can hit the eustachian valve and you may not be able to get it. And another thing is some people have even put it into the LA, thinking that that is inside and then kept it there. That's why you have to rotate it once.
How do you realize that your cannula is in the LA and not
in the LA?
RA?
Right.
Before you open the RA, how would you realize that your cannula is not in the IVC but it's in the LA?
How do you distinguish SVC and IVC return? That's what sir is asking you.
You looped the SVC, IVC, you put the SVC cannula, you put the IVC cannula, you've gone on full bypass, you clamped the aorta, you given cardioplegia. Till now, there's no problem. And the perfusionist says return is all right, sir.
The moment you snare,
then you snug the SVC and you snug the IVC.
What
and
happens?
You open the RA. What will happen?
Something, if you are not having something, we just discussed in the morning, so you should take the hint. I open the RA with the IVC cannula in the LA. Something happens immediately. Air starts coming out. No, and CPB terminate.
There will be airlock. If the fellow is not watching carefully, the oxygenator will empty and he will put air into it.
Okay. That is why we always tell when you are doing an ASD or this thing, we tell you as students always do a test snaring. You snare.
When you snare, you should
test
feel
the IVC.
You should feel the snare around the cannula. That is one.
Okay, that's why the test snaring is
even before you open the RA, if you got a cannula in the LA or anywhere out and you snug the IVC, nothing will happen to the return. But your heart, if the return has been all right, the RA will be collapsed. It will get sucked in. So before you open the RA, if you see that the RA is getting sucked in, that's a danger signal, which means that your cannula is not in the IVC, it's lying outside. So before you see that, these are telltale signs of a misplaced IVC cannula. And it's not uncommon because you may put the cannula in the IVC, you may be sure when you put it in, but after a little manipulation, it can just slip out of the IVC and sit outside. And you snug the IVC, not looking very carefully that you are actually snugged around the cannula or not. You totally occluded the IVC. It is still draining, but now the negative pressure has sucked out all the blood from inside the heart and you get the RA sucked in. So that's a danger sign. So if you find the RA sucked in, never go and open the RA. First check why is the RA getting sucked in like this.
Now one question that we have to ask, because operative steps in surgery will be asked operative steps. When you open the RA, I mean not RA, when you open the pericardium, what are the things that you see when you are doing a ASD? Color of the, so what do you see? No, start from one then. You already checked the innominate vein because that may be a issue in the ASD. Then next, what is iotized? Small, PA is big. Then next, SVC is dilated. If the SVC RA junction is dilated, what do you think? PA PVC. Then next, what do you see about the RA? I am telling secondum ASD. RA is pink in color. Okay. Now I'll ask you something. You went in for a ASD and you find the RA is black in color. It could be everything, or it could be primary pulmonary hypertension. In the olden days, what would happen is septal dropout could be created in echo, and people have actually gone in for PPH and they have opened. It can be fatal. Okay. Then next, you take the purse string, what will happen? What other things can you see? When you take the purse string in the RA, in the appendage or in the IVC, what will you see? Bright red blood bleeding again. Then anything else? I have still got a doubt. In the old, it used to be done universally. Nowadays, we don't do it with tea and other things. No. Then what can you do? You can place a clamp, and we were all asked to actually put a finger, clamp the appendage, open it with a snare and everything, put your finger in. You had to feel through the ASD. You had to put your finger and palpate the 4 pulmonary veins, and you had to put your finger in the mitral valve. Today, we don't make you people do it, but that was to be a standard step before going on bypass. You had to put everything ready, then you clamp, you put your finger in, feel through the, palpate the ASD, palpate the 4 pulmonary veins, palpate the mitral valve and come out, and then go on bypass. That was to not miss things.
Because before the days of echocardiography, when ASD surgery used to be done purely on clinical grounds, you had a wide fixed second heart sound. The X-ray showed pulmonary plethora and a pulmonary apnea, and patient went for surgery. So you had to do a confirmation on the table before you go on bypass.
Today we don't do that. Then next, any other instance? What is this? I don't know whether it is Vaidya. It is a cardioplegia needle without vent. I mean, with the only thing without an accessory vent. Okay. Now, how much cardioplegia? See, this is something which I have found very surprising. Many of you people commit harakiri in the exam because you don't tell me what is the dose of cardioplegia that you give. Give 20 ml per kg of what's the potassium concentration? See. All are really 16 milliequivalent. 20 milliequivalents per. Why not give 40? If some potassium is good, I'll give 40 or 60.
It is fast.
Myocardial? Yeah, it can cause damage. Do you know which is the cardioplegia which had a very high potassium concentration? I'll give you a rose. Melrose. Melrose solution was potassium citrate, and he had a very high this thing, and
40 milliequivalents per liter.
40 milliequivalents, and it damaged them 40-60 milliequivalents actually, and it caused damage to the myocardium. Also, it was acalcemic, which caused another set of problems. Then we have discussed yesterday heart not stopping when you are giving cardioplegia, so we'll not go through that again. Anything specific you wanted to ask?
So I just want to know whether, do they know when echocardiography came into clinical practice?
Yeah.
2D echocardiography, and they should have some idea. 60s, 70s, 80s, 90s?
Yes, sir. Where was echocardiography first used in clinical practice? Gynecology, they were going to get the diameter of the fetus was under A. This thing. Okay.
So the early 80s, that
early 80s. Okay. Huh?
Initially, it was M-mode echocardiography. Then came 2D echocardiography, and then of course 3D, 4D, etc., etc. The initial was just MO, where you just got waves.
Only they measure distances. In fact, we have in Jaideva historical M-mode machine still there. We have kept it preserved for making the next. Next, somebody else come. Last instrument, somebody come. See, all the instruments are given to get into operative surgery. Any one more instrument, I believe. One last instrument. One last instrument. Come. Give my one instrument.
Are we starting the quiz at 7 o'clock as planned?
No, we'll take this.
I'm closing the registration for the quiz also, sir.
What is this cannula? Peripheral venous cannula. Now, what are the dangers of using this cannula? I'll ask you a simple question. Is it easier to go on the right side or the left side? Why do you choose right side? Huh? More in line. No, I thought it goes like this. It's not just because it's more in line. I will tell you. Do you know what you know this salsa and you have one guy and one girl and one guy and one girl, leg to leg, like this. Where in anatomy do you see leg to leg, tuck like that? They do, no? So what is the problem with the left? This thing is crossed by the iliac artery is crossing this left this thing, no? So they stay like this. IVC is like this, and so the left iliac vein is crossed by the right iliac artery. So that can be the thing. Which is the other place where this can find it difficult to ascend? The next place, be it left or right. Sacral promontory. So that's the next place. Now that is why in the olden days, if this was when we were students, we were not having these sort of cannulae. We used to use a chest tube, Atrial Trace tube or a chest tube, and we used to put. So we used to find it difficult. Sometimes you had to thread first a Riles tube and then place this tube over that, and chest tube, 32 chest tube under cut down would be put when these things were not available. But today with the wires, they say. Now I'll ask you something. You put it near the sacral promontory or somewhere, and then you suddenly it starts. You realize that it's bleeding. There is no blood coming out, and you have perforated the vein. What do you do next? You perforated the vein. Now you're in trouble, right? So what do you do with this cannula after it has perforated? Do not remove it. This will be the guide to find out where you have perforated. Is our time over?
Yeah, time over.
Yeah. Remember, there are a lot of textbooks of complications. There's a very famous book by Waldhausen and another book by Consari. You must read complications and how to deal with complications. Because trust me, in your life, in future, you will create complications and you need to deal with them. And the time to learn how to deal with complications is not on the operating table. Understood?
One last word of caution for these boys. When there is no venous return, when the oxygenator is empty, when the patient is empty and you have an empty feeling, the patient is dead.
Just before we go into all the logistics, I'll just brief how we are conducting the online quiz. This is a software which we have procured, and it's a very user-friendly software to conduct quizzes. And you should not log out of the Zoom what you are logged in as of now. We'll share you a link where you have to download that link, and immediately you will enter into the quiz session. That is the classroom, what we call it as. And we have formulated around 75 questions. Dr. Prasansimha sir, please sit on the stage. A mic to you had a mic to Dr. Prasansimha. To the two quiz masters, Dr. Prasansimha sir, who is my teacher, and myself. You a head mic, please. Head. Do that. And check it if you got it. And we have kept the quiz open this time. Actually, this quiz was supposed to be conducted during the national conference, And due to a number of constraints, we had to postpone it, and we saw that it is conducted at least during the IACTS SCORE within a month. The criteria is only members can participate. The registration has been closed. 7 o'clock we are starting sharp. We are crossing 7. We have closed the registration, and this time normally quizzes has been conducted for the last almost 8 years for the IACTS, and we have been successfully conducting every year in the national conference. And every year, the residents who participate, this time since it is online, we just keep an active e-learning session on. We have included life members, fellow members, and the associate members. In fact, after announcing that the membership is compulsory, we had a good number of increase in the membership format. Few things, I think people who were here this time in the SCORE program, the association was kind enough to introduce a prize for the best case presenter. And this time the prize is a surgical operating loop with an headlight. And that will be announced at the end of the section. Quiz winners also will be announced. We can tell who is the highest marks were scored. We have formulated 75 questions, and each question has a time limit of only 20 seconds. Number one. Second, I am going to read only the question. The options, 4 options, I am not going to read, because by the time I read 4 options, it will be 20 seconds. So you have to read it yourself. So how best you utilize your brain to see the question and see the Google and answer also. You can copy also. Choice is yours. No negative markings. People sitting at home also can do this. It's a challenge what we have tested, and we have come forward. 20 seconds, immediately we go to the next question. I will be reading only the question. There are no, I won't be reading the options. You have to see the options, immediately answer it. Clear? There are a mixture of questions, starting whether it's cardiac surgery, thoracic surgery, vascular surgery, history, little of physics, mathematics, all those things are there. Concerned with cardiac surgery only. I think are we ready? Hello? And 20 seconds, 75 questions will take exactly 30 minutes. Quiz is only for 30 minutes.
And Quizmaster's decision is final.
Yeah. As sir told, Quizmaster's decision is final. And after 30 minutes, the next 30 minutes, I will be discussing the answers for those. Okay. And at the end, we'll be releasing the questions. Any queries related to any of the questions, my teacher Dr. Prasansima is here to answer. We are here to solve, and our decision will be final. And we are happy that most of the members are here. And in fact, the president of our association, Senior Pediatric Cardiac Surgeon, Dr. Krishna also is there. Even he is participating in the quiz. Very kind of you, sir, to be here amongst us. Are we ready? Quiz pricing will be a cash prize. The person who wins shall share his account details. I will be transferring to his account. The association will be transferring to his account. The checks and all I have not kept ready to go more paperless. And he will be issuing the certificate also. E-certificate will be issued to them. All participants will be getting an e-certificate also. This was the first of its kind SCORE program after the national conference. We happened to conduct online. Many good feedbacks we have got. People participation from India and across other countries also have participated. And the transmission part, it's really appreciable, wherein we did not have any, luckily with God's grace, the net and all did not give us trouble. Are we ready? Yeah. I think just I'm going to repeat the instructions. Pardon me? I'm not. On what? So the instructions have been sent on your emails. Kindly check your emails. Instructions are there on your email. Simultaneously, I am going to read out the instructions also. Can you start?
The instructions you read it out.
Yeah.
They need some time.
So we're going to start. Kindly listen to the instructions carefully. The digital quiz will be conducted over a user-friendly online software with live instructions. Next slide, please. The Zoom link is open for demonstration and readdressal of queries. Next. Those who wish to take part in the quiz must register beforehand on the link circulated earlier. We have done this earlier itself, and it's already closed. You can't register now. This quiz can be attempted on a web browser on any electronic gadget, whether it's a mobile, computer, tablet. The login details will be declared before the quiz, which you have to enter. Next. All members of the association are welcome. Yeah, one question has come. Link is in morning only. Yes, it's the same link, sir. The link he has asked. Link. We are sending a link now to log into this software. What link was we had sent was to register for the quiz.
The name of the software, no, that Socrates.
Software link. I am going to display here also. Suppose anybody has a delay in getting mail and all, I am going to display here on the Zoom itself. So
we can log in here itself.
Yeah, you can log in, sir. If you have registered only, you can log in.
No, correct, registered, but we can log in on the screen itself.
Yes, sir. Yes, sir. Yes, sir.
Okay.
On your own mobile screen, you can. The login details I told will be declared just now. All members of the association are most welcome. Prizes will be distributed only to residents who are associate members. Next slide, please. Can we go to the next slide? Yeah. As I told, the quiz contains 75 questions following the demo. I have kept around 4 or 5 slides for a demo. You can answer on the demo. After the demo, only the marks will start. Okay, each question carries 1 mark. Questions will cover all subspecialties of cardiac surgery, as I mentioned. Next. All questions will be conducted in one rapid fire round. I have got only 1 round. No second round, third round. 1 rapid fire round of 75 questions only. Each question is allotted 20 seconds. As I told, 20 seconds, immediately the next question changes. Next. We hope to complete this quiz under 30 minutes. Next. I'm not going to read, as I told, the options. Only question I am going to read. You can read faster than me if you can see and do that. Okay. The answers will be discussed at the end. Top 3 winners who are residents. Actually, top 2 winners, because of COVID, our president told you can keep 3 winners. So I have got to keep 3 winners. It's a cash prize. Don't expect more cash. It will be given. Top 3 winners who are residents and associate members of the IACTS will be declared winners. You can't become members once you win. You can't become I'll become member after I get a prize. No. Okay. So marks who get lesser than you also will be given provided is a member. These masters will have finalized any disputes. Next. Yes, you can open your web browser. Do not exit from the Zoom meeting. Next. Enter the following URL. This is the URL which you have shared on email also. Kindly enter the URL. Next.
You can read it out. Bit.ly.
Yeah, bit.ly/3WQA0HI. Capital, small, all those things you should be careful. bit.ly/ and we have sent it on your mobile also. There is the Zoom. If you are there, we have shared it in the chat box. The link we have passed and even the password. Can you next for the next password, please? Yeah. So the password, please. Password is 421.
On the link, it says room number. So instead of room number, enter the password.
Yeah. Zoom number same. It's 421, sir.
421.
Yeah. Room number as you enter, sir. It comes. This is the. We are using this platform called as operative.
Yeah. I'm saying that I've already logged in. Instead of room name, you should put the password.
Yeah.
421. Yeah.
Enter the room name. Room name you should enter as 421. Room name. Next. Room name, please enter 421. Click to join. I hope everybody joined. You should have good internet. If no internet, we can't do anything. It's your luck. You should have internet to conduct this program. No complaints will be entertained if you have low internet.
No, I have internet, but I can't join.
421 has to be entered.
Room name, sir, please join, sir.
Room name.
Somebody said, sir, not getting the link. Link is, I told, sir, bit.
Ankit, you can take the link bit.ly/3 /3WK0HI.
You can keep the Zoom meeting on. You can take another device and do that also. Zoom meeting, keep it on.
Use your
That
phone.
you can see my slides here. I will be showing all the questions on the screen also here. Has everybody joined? We have sent the details of the link to quiz. We have sent it again on the chat box, and you need to enter your full name.
It's not
Check your
asking
battery
for my name.
backups and all. Any issues? Have you joined?
You'll get this. Enter your name.
See, enter your name. As you see there, here my name is entered. Even though I will be just as a demo.
That hasn't come. It just says waiting for next activity to begin.
Huh?
After I logged in, it just says,
Waiting for next activity to begin and wait. No, we are all waiting only. You have to reach the stage.
I'm
Please
saying
wait.
is I didn't get a message to enter my name. So
Yeah.
I think those who have logged in already or registered probably don't
What?
get.
Next activity begin. You entered your name. Waiting. That means your
Internet is slow.
All are waiting.
Come.
Ask the technical guy what is the problem there. Waiting for next activity.
This is what I'm getting on my screen.
What is the problem?
I can't get this.
Wait for the next activity to begin. Not Rapa? I think that this thing has not got loaded.
Yeah, Dr. Ankit has joined. Thanks, he has mentioned already. People are joining. What is the problem? Why they are waiting so much? You got it? Yeah.
Now it has come.
Now it has come.
That's because of the internet. I told no internet, slow internet, low battery, no options. Some people have said they're low batteries. I can't do anything for low batteries and all. We're done. Are we ready? Hello? Anybody still waiting? I have waited more than 10 minutes now. Done? All are ready? Yes. We'll go for the demo questions. In the hall, at least around 26 members are there. All are okay?
Yeah.
Anybody, any issues? Hello? Yeah, group discussion. Keep it, sit away, man. COVID is there and you say group discussion answering what is this? Sit away, go away.
Stay far away.
Far. Alternate seat should be empty. Hello? So many chairs are there. Go away. Come. Not allowed. Alternate seat. Go there. Anywhere you can sit and see.
Group discussions will be disqualified.
Yes, sir. Go away. Hello. Those two people
You may all be copying the wrong answer.
Yes.
Okay.
Distance you maintain. Hello.
Okay.
Yes. Demo questions we can start. Yeah, the first question, please check your mobile. Identify the city that houses this monument. I am not reading the answers. Be vigilant. 20 seconds, it goes to the next question.
Don't answer there. Dhyaneshwar Borde, you are not expected to answer that here.
Next question is, where is the world's deepest point located?
That's not coming. That's not coming in. There's a lag. It says you've completed now. Now it's come. There's a lag between. Yeah.
Transmission has to go to.
Transmission is slow.
Transmission is slow.
Yes. So I think if one of you has also logs in, then you will know exactly when, because your timer will have to start when the people receive the question.
No? Send me the. Send
you
me the
open
link.
on your phone so that you will also know when it's coming.
20 seconds. Can you, the technical team, can you focus here? Hello. You got the next question.
Yes, question 2 we got.
Yeah, 20 seconds. See, just go next. Satish, just check out the timings now. 20 seconds. Can we keep 20 seconds? I think is the ideal time. Hello.
20 seconds fine, but you have to know when they have received the question. You see, you may have transmitted it there, but there seems to be a lag between the time you transmit and we get it here. So if you take 20 seconds from your time, then it may not work.
Hello, you can't answer in the chat. Don't give answers in the chat box. It is invalid. You have to answer in this demo. You should give the answers there. Don't answer in the chat box. Chat box, I'm not going to see your answers there. Somebody started answering in the chat box. They have written Taj Mahal there. Don't do that.
Yeah, I told that boy not to do it.
Huh? Next question. Yeah, next question we're going. Third question, identify this bird.
Yeah, okay, it's come.
It depends on the internet. If the internet is slow, I told I can't help you. 20 seconds you have tested. You can sit anywhere you want. If signals comes outside, you can go and sit outside also, no problem.
Because you don't need this. The question
Because you don't need this. Everything comes in a laptop, in a mobile. Next question, which city houses this landmark place of worship? "20 seconds, technical team, 20 seconds goes to the next question. Yes. We have tested this 100 times, then only I have got it. We have sat in different rooms, checked, different halls, we checked. The next question, this building is a home for which Indian executive?
Please don't give the answer in the chat box.
Hey,
and,
somebody again wrote in the answer in the Amritsar
can
in the
you
chat box.
inactivate the chat box?
Just inactivate. Inactivate the chat box, please. You can't help you can't do like this. Don't type your answers in the chat box, please.
Where to answer? You have to answer in that Socrates software. If you have got the link and
You are able to answer no there. Are you able to put the you have to press that? Very simple. You have to press on the place where that's what this software is for.
No, this is somebody who has not logged into the software. Is
Oh, people who are not logged in for the registered, they can't do this. Even if you keep on writing in the chat box, it won't be valid. You had to register. I have been telling this the last almost the day quiz, the score as program has begun. We have told clearly what are the instructions. Mail has been sent.
But you should be able to know from your end how many people have logged into this system.
All have logged in, sir. 26 members seated here, 27 members all have logged in. No issue.
No, 27 there, but outside?
Outside?
81. 81, sir, 81.
81, okay. 81 out of 1 because 135 participants are there on logged into the Zoom. If they, I don't know whether they are actually physically present or they just logged in and left. So at least 81 is not a bad number.
But they have registered, sir.
Yeah.
Okay.
Here.
I think you should proceed with the quiz.
Those who will be answering in the chat box, they will be removed. Because they will be invalid, we can't do anything. We are going to disqualify the person who answers in the chat box. It adds on to our confusion and functionality. Are we ready? I think demo questions are clear. No confusion. It's very simple. That's why only youngsters we have kept, because youngsters are technically savvy. Elderly people will sit, see, and there should not be any confusion. I think all 27 members here are very smart, sir, who are sitting here. We'll start the question first. Be ready, be vigilant. That two ladies are sitting very close. Hello, move that. First of all, Corona is there and you are sitting close, and quiz also is there. Chalo, move. Yes. As I told clearly, the DigiQuiz is 75 questions, 20 seconds per question. Answers discussed will be at the end of 75 questions. Okay. Exactly 30 minutes. Be focused. Don't look, and if you look here and there also, you will be losing time. Are you ready? Hello? All are ready? We'll start with the first question. Identify this as an instrument. Pin drop silencer. I really appreciate that. Everybody using the brains. Kindly disqualify the person. Somebody has answered in the chat. Or Frazo, Prudence. Disqualify the person, please. Disqualify the person who answered just in the chat box. Next question. Identify this personality.
And let me tell you that a person answering may be giving the wrong answer.
Be careful, huh?
So don't fall for that trap.
For the person who answers in the chat box, Vinay, please look into that. Be ruthless. Which clinical trial explored the outcomes of PCI and CABG in the left main coronary artery disease? Question number 3. No negative markings. You can mark anything you want. Dr. Iyer, sir, are you getting all the questions, sir?
Yes, yes.
Yeah. 4th question. Identify the surgical procedure. 5th question. Which of the following is the direct branch of celiac trunk? 6th question. The course of this catheter in this angiogram is likely indicator of. People who have attended Dr. Prasanna must talk carefully today morning has the answer. 7th question. Which of the following structures would not lie external to the oblique pericardial sinus? Question number 8. If the incision in Nick's procedure were to be extended beyond the annulus, which chamber would you enter? Question number 9. Identify this device on which tubing you are likely to find it. Question number 10. Which of the following conduits for CABG have been described in literature? Question number 11. Ghost score was described by whom and for which condition? Question number 12. Which among the following contains a semi-rigid ring? Question number 13. According to DeBakey classification, dissection limited to the descending thoracic aorta can be classified as. Question number 14. Identify the condition. Question number 15. Identify this coronary pattern in TGA. Question number 16. Identify this valve repair technique. Question number 17. Identify the odd one out. Question number 18. Identify this prosthesis. Question number 19. Identify this assist device. Question number 20. Identify the structure taking shape of this catch shoot still. Question number 21. The artifact orange arrow on CT has Hounsfield unit of 950. What would it be possible be? Which of these techniques is employed for transaxillary first rib excision? Question number 23. An 81-year-old woman presented with NIHS class 3 with dyspnea of exertion and palpitation. A mid-diastolic rumble was heard over the apex. A chest X-ray of the patient revealed something unusual indicated by arrow. Identify it. Question number 24. Identify the peculiarity in this CTA. Question number 25. The remnants of the umbilical arteries would be. Question number 26. Who described the technique wherein the coronary sinus is diverted into the left atrium? Question number 27. You see these waves as you are closing the RA following the ostium secundum ASD closure. While still on complete bypass, identify the characteristic wave. Question number 28. A 10-year-old presents to you with this X-ray. Identify the defect. Question number 29. Identify this procedure. Question number 30. Which among these surgeons has also developed a procedure in orthopedics? Question number 31. Identify this legend who passed away in the year 2020. 31 has come already. Question number 32. Which of these trials sought to explore the superiority of BIMA over CIMA drafting? Bilateral IMA versus single IMA. Question number 33. If you are placing this device in a patient, then the patient is likely to be suffering from. Question number 34. By means of which clinical trial was the efficacy of endobronchial valves tested? Question number 35. As of 2020, fluorodesis is less aggressive approach in which of these circumstances? Question number 36. The theory behind a collapsed airway under tension pneumothorax in an adult is best explained by. Question number 37. This chest X-ray is a classical sign of. Question number 38. Identify this modality to preserve and treat lungs after harvest. Question number 39. Identify the most common form of congenital diaphragmatic herniation. Question number 40. The cervical esophagus is the extent between the vertebrae. Question number 41. The bronchial arteries and veins find, originate and drain to. Question number 42. Which of these structures forms a swinging loop around the distal arch? Question number 43. Identify the condition. Question number 44. Identify the underlying lesions in this barium swallow scab. Question number 45. Which among the following may not define margin of a malaligned VSD in top? If you attended Dr. Iyer's lecture, I think this is a very easy answer. Question number 46. This book is a biography of which pioneer of cardiovascular surgery? Question number 47. Identify the most commonly occurring and a stable coronary pattern as seen in TGA. Question number 48. Which of the following multicentric RCTs was conducted from India? Retrospective clinical trials.
Already discussed again in this.
Yeah. Question number 49. Which of the following best describes restricted leaflet opening for Carpenter's functional classification of mitral insufficiency? Question number 50. Which of these areas of the ventricular septum is most susceptible to rupture in post-MI VSR? Question number 51. Which among the following is not a second generation LVAD? Question number 52. Which among the following is a model of a pediatric LVAD? Dr. Balram Zaidat's talk had all these answers. Question number 53. Which of the following is an extracorporeal mechanical circulatory support modality? Question number 54. Who among the following coined the term bioprocesses? Kumar's talk, if you heard of the morning, I think this answer was there. Question number 55. The posterior annuloplasty of the tricuspid valve is an alternate name for which technique? Question number 56. Which of the following is an anatomically appropriate name for the posterior leaflet of the tricuspid valve? Question number 57. In the case of aortic root dilatation without valve insufficiency, if the diaphragm conduit is cut in this shape, the procedure most likely to be performed is. Question number 58. The book is an autobiography of which doyen of CT surgery from India? Question number 59. Which root enlargement procedure is most feasible in children with a very small aortic root? Question number 60. Identify this pioneer who was awarded the Nobel Prize in Medicine and Physiology for his work on vascular anastomosis.
Answer was already discussed. Yes.
This also discussed. 61. Question number. Which of these structures does not belong to the posterior mediastinum? Question number 62. The fixed principle establishes a direct relation between which of the following? Question number 63. Which of the following defects will most likely contain two distinct, a fast and a slow conduction pathway? Question number 64. This landmark picture indicates the heart belonging to. See the heart carefully. Question number 65. This procedure is best described as the. Question number 66. If you're at the Children's Hospital in Boston during the summer of 1938, watching a resident performing the first of its kind procedure, what would it be? This resident was then temporarily dismissed for doing so without the presence of his professor. The answer was given by the president of IACTS today morning. Question number 67. Which of these is not a root translocation procedure? Question number 68. Which of these structures is not visible from the aorta to RV view in top? Question number 69. The RAVE is synonymous with. The RAVE procedure is synonymous with. Preparation Letage ventricular is the RAVE procedure. Question number 70. Both pulmonary arteries arising from the posterior wall of the common arterial trunk is best described by Collett-Edwards classification as. Question number 71. The disc of TTK Chitra valve is made from. Question number 72. Caudal preservation of secondary chordae in the event of extensive rheumatic obliteration of subalveolar apparatus is possible with. Question number 73. Which of the following cannot be classified a functional single ventricle? Question number 74. Identify this pioneering surgeon. Question number 75. Identify the odd one out based on the analogy from the picture. The last question. Identify the odd one out based on the analog from the picture. Should know who he is.
Hiramad,
Yes, sir.
Hiramad, number 50 question answer, there is a flaw. 2 times posterior is getting repeated. Just verify on that. Question number 50, the answers.
Yeah.
2 times same thing is getting repeated. Posterior, posterior. Just verify that.
Sure, madam. Thank you, madam, for that.
Yeah.
Can we go ahead with the answer sheet, please? Yes. Let me tell all the people who are assembled here. Dinner has been arranged. Actually, dinner was not a part of the program. Seeing we are getting late. Dinner has been arranged. Kindly have dinner and then leave. After quiz, I have got another 15 minutes of program. Kindly stay back. Which is additional feedback, which we will give you and you have to give us. And the prize winners also will be informed. The best case presenter, the award winning for the quiz. Can we have the answers, please? As we have the answers, even the winners also will be decided. It hardly take 2 minutes. How much time it will take? Have all the residents returned all the instruments?
All instruments are returned. No? Last
Hello?
time some students just check.
All done? Nothing is missing? Oh. Last time I had missed 2 instruments. I had to pay for them. Can we have the answer sheet, please?
Results are tabulated.
Quiz questions are very easy. The residents here, hello. Very much easy. Somewhere basics, somewhere.
Time is less.
Time because you are internet savvy, you are masters in Googling and all that. Huh? Immediately you will start Google and you will find all the answers. Yes, that's why you are testing for a quiz. If you know only, you will answer. Yeah. Yeah, answers and discussions. I'll take less than 30 minutes for the answers and discussions. 30, 20 minutes. No much explanation I'm going to give. Okay. Identify this instrument. Traveler, I think everybody knows this. Next. Be fast. I've got a lot of work to be done now. Identify this personality. Dr. Adib, Professor Adib Jatain of Brazil is well known for his surgical technique and modification in arterial switch surgery for transposition. The answer for this question, PCI and CABG in left main coronary disease, is Excel trial. The trial compared the outcomes of second generation drug eluting stent with UpCab versus CABG. Identify the surgical procedure. It is the hemifontan, which is a non-penetrated IVC to RA PA patch. Next. Which is following direct branch of celiac trunk is common hepatic artery. The branches of the celiac trunk are the common hepatic, left gastric, and splenic arteries. The course of this catheter in the angiogram is likely indicator of PAPVC. Professor Simha with the diagram here explained in the morning. Cath course illustrates IVC, RA, SVC, the left brachiocephalic vertical vein, common Common venous chamber in the case of supracardiac TAPVC, total anomalous pulmonary connection. Next. Which of the following structures do not lie external to the oblique pericardial sinus? It's the LSUC. Next. Incision nicks, if it extends beyond the annulus, will enter the RA. The incision is in the aortic mount. Is likely to open into the right atrium and cause intercommunication. The device on which the tubing you are likely to find is flow sensors in the aortic valve, aortic tubing. Next, which of the following conduits for CABG have been described in literature? Right gastroparetic artery. It's a branch of splenic and has been largely utilized for in Oriental countries as a conduit for TAR. Go score was described for whom? Salamander for Epstein's great hormone state. Go stands for great hormone state, coined by Salamander, to determine the grade of utilized RV in Epstein's anomaly and associated feasibility of repair. Following contains semi-rigid ring is Carpenter-Edwards 2. Is an example for semi-rigid ring in situ. Question 13. DPK classification limited to descending aorta can be classified as type 3A. No mistakes in all classifications. 14. Identify the condition. It's double-chambered right ventricle. The ridges of trabeculation separating the apical and the trabecular components of the RV are clearly visible in the short axis cut in an MRI. Next. Identify the coronary pattern in TGA. It is 1CX2RL. Identify valve repair technique. It is brushless repair performed for suspending the excessive tissue that has collapsed up the aortic valve at the commissure level but projected through the aortic wall. Identify the odd one out. It's ROS. Remaining are root enlargement procedures. Identify these processes. It is Braunwald cutter valve. If you define this, it has two distinct features to identify a star-headed valve. Lack of fusion of the cage to form a closed apex. If it gets closed, it is star-Edwards. Lack of a hub at the sewing ring that can be found in most cage ball processes, including option C and B. The gadget was a bilipid process. Okay. Identify this assist device. This is Jarvik 2000. LVAD that has the classical appearance of a carburetor. You know, automobile carburetor, motorcycles. Yes, next. Identify the structure taking shape in this catch shoot still. It is coronary artery aneurysm. Distal runoff is very evident at 4 o'clock in this shoot. It indicates a flow through the lumen, aneurysm of left coronary artery. Somebody can confuse it as an orange cyst also if it is shown as to a noise. The artifact orange arrow on the CT has a Hounsfield unit of 950. That is air. See, gas has a Hounsfield unit. I hope CT scan you should be able to read what is the Hounsfield unit you should be knowing. Found in the LV resulting. What's happening? I lost my slides here. Hounsfield unit, I lost my slides. Please get back the slides. Yeah. So it is air found in the LV resulting from an iatrogenic esophageal LV fistula following an RFA. Can you see this? These are the Hounsfield units for air -1000, fat -70, pure water 0, CSF +8, white matter 30, gray matter 45, blood is +70, bone is highest +1000. Calcification and all. That in the exams also they ask when a CT scan is put forth. Which of these techniques is employed for transaxillary first strip excision? The Rose procedure. Transaxillary first strip excision for surgical treatment of thoracic outlet syndrome. Described by Clagett in the early 1960s. Next. Etienne one more old presented with what NYC class 3 with the dyspnea on exertion and palpitation. What is this? The arrow indicates what?
No, mitral annular calcification.
It is mitral annular calcification. Identify the peculiarity in this Citenjo. What is this? It's very interesting. It is a cervical arch. Can you see the arch going almost up the chin and coming down? Can you appreciate that? Arch of the aorta. Hello. Next. The remnants of the umbilical arteries would be what? It is superior vesical arteries. The proximal superior vesical arteries supply the bladder well. The distal ends enter into the medial umbilical ligament. Next. Who described the technique of coronary sinus diverted to the left atrium? Kirklin. LA is Kirklin. RA is Jakub. Which you see the waves which are closing the RA following an OHSD closure, which while still on complete bypass. What is the characteristic of this wave? It is J wave, also called as Osborne wave seen in hypothermia. It's an exam question. 10-year-old presents with this X-ray. Identify the defect. It's buccal hernia, herniation of the descending colon through the diaphragmatic eventration along the left posterior pleuroperitoneal fold. Identify this procedure. It's Cox-Maze 1. Which among the surgeons have also developed a procedure in orthopedics? It is William Mustard. For poliomyelitis is the namesake for the atrial switch procedure for transposition of great arteries. The legend who passed away in the year 2020 is William Norwood, who described pioneer in the concept of stage 1 surgical palliation for hyperplasic left heart. Which of these trials sought to explore the superiority of BIMA versus CMA grafting is the ART trial. It's a short randomized trial that compared bilateral with single internal thoracic artery grafting in CABG. It failed to show superiority of surgical bypass with the bilateral IMAs over a single IMA. If you are placing this device in a patient, then the patient is likely to be suffering from emphysema. Endobronchial valves are inserted into the branch bronchi in cases of restrictive emphysema to act as one-way valves in COPDs. By means of clinical trials, was an efficacy of endobronchial valves tested was VENT. The VENT trial, short for endobronchial valve for emphysema palliation trial, was a randomized study of endobronchial valves for advanced emphysema. As of 2020, pleurodesis is a less aggressive approach in which of these circumstances? Malignant pleural effusions. The theory behind a collapsed airway under tension pneumothorax in adult is best explained by. Hello.
Starling.
I lost the connection again.
Answer is Starling resistor.
Can you get the slide, please? Yeah. Malignant pleural effusions. Next. Theory behind collapsed airway under tension pneumothorax is best explained by Starling resistor. External pressure exceeding a threshold such that flow is no longer dependent on distal pressures is a classical example of Starling resistor. X-ray is classical sign of pulmonary lymphangiectasia. Chest X-ray demonstrates the bilateral subobal appearance of lymphangiectasia. It remains a formidable challenge to distinguish from CLE, that is congenital lobar emphysema, even in the 21st century also. Identify this modality to preserve the treat lungs after harvest. This is EVLP, that is short of ex vivo lung perfusion. Is a technique to perfuse lungs when with an organ care perfusion system. Identify the most common form of congenital diaphragmatic hernia. It is right Bostelac hernia. 36%. Remaining options have an estimated incidence of 2%, 1%, and less than 1% respectively. Cervical esophagus is the extent between the vertebrae T6 to T1. The bronchial arteries and veins originate and drain to descending thoracic aorta and accessory hemizygous vein. Each of these structures form a swinging loop around the distal arch. The left recurrent laryngeal nerve. The diagram shows it there. Next. Identify the condition. Esophageal atresia with esophageal fistula. Note the curved catheter and visible vascular markings in the lung pleats. A contraindication for tracheal atresia. Air is seen filling the intestinal loop. Hence, it is a case of esophageal atresia with tracheoesophageal fistula. Identify the underlying lesion in this barium swallow scan. It is diffuse esophageal spasm. Corkscrew sign seen in case of diffuse esophageal spasm. Which of the following may not be a margin of malaligned VSD in top? Bulboventricular foramen is a term used earlier to define a margin of the supraventricular crest of the LV side. It does not form a part of the rim of subaortic VSD. This book is a biography of which pioneer of cardiovascular surgery? It is Walter Nilay. I hope everybody has read this book. Identify the most commonly occurring and a stable pattern as seen in TGA. It is 1 LCX and 2R. A rather stable pattern of coronary origin of 2R exists in the most common form of TGA. with the aortic orifice in the right anterior position. Which of the following multicentric RCTs was conducted from India? The randomized control trial. It is promote patency trial. This prospective randomized comparison of off-pump versus on-pump multivessel coronary artery bypass surgical trial or promote patency trial, is called as for short, was an effort by Dr. Lokesha Rao Sajja, who is now the junior vice president of the association, and his team members, and that compared graft patency at 3 months after off-pump versus on-pump coronary artery bypass surgery. This is the first RCT trial in our country. You should know this.
RCT cardiac trial.
RCT cardiac trial, sorry. Which of the following best described restricted leaflet opening for Carpenter's functional classification of mitral insufficiency? It is type 3A. Question number 50. Which of these areas of the ventricular septum is most susceptible to rupture in the posterior MI-VSR? The answer is anterior component. We deliberately had kept 2 posterior components and 2 posterior components. The answer is anterior defect 50%, posterior defect is 30%, apical is 20%, pre and lateral wall is 26%. I hope Dr. Neelam, this is the answer question I have answered here, madam. Which of the among the following is not a second generation LVAD? HeartMate 1, yes, very good. HeartMate 1 is the first generation VAD that ran on the principle of pulsatile flow, as against the second generation VADs that did on the principle of continuous flow. Which among the following is a model of a pediatric LVAD? It's Berlin Heart, XCOR Berlin Heart from Germany, is a pulsatile pneumatically driven paracorporeal VAD. The rest are models of total artificial hearts. Which of the following is an extracorporeal mechanical support modality? The tandem heart is a paracorporeal continuous flow centrifugal pump, which the rest are intracorporeal MCS modalities. The tandem heart flows on centrifugal flow, whereas PHP and impeller do on an axial flow, while IAP is a counter pulsatile flow. Who among the following coined the term bioprosthesis? It is A.K. Senning. Professor Senning from Karolinska Institute in Sweden coined the term to indicate the material of the implant and the metallic housing used to harness the valve. The posterior anaplasty of the tricuspid valve is an alternate name for which technique? Yes, this case anaplasty. Next. Which of the following is the anatomically appropriate name for the posterior leaflet of tricuspid valve? Inferior. In the case of aortic root dilatation without valve insufficiency, if the diaphragm content is cut in this shape, the procedure most likely to be performed is Jacob's procedure, which avoids a commissional post, is a root remodeling technique, as against the David that does not see a trimming of the conduit, which is inside implanted end block with the commissional post in the internal surface of the graft. This book is an autobiography of which doyen of CT surgery from India? Dr. Sampath Kumar. He was there in morning with us. He has written the book. Next. Which root enlargement procedure is the most feasible in children with very small aortic root? It's the Kono procedure. The anti-root enlargement. Identify this pioneer who awarded the Nobel Prize, who was awarded in medicine and physiology for his work in vascular anastomosis. This is the MBBS question. Alex Carroll was a French surgeon and a biologist who was awarded the Nobel Prize in physiology and medicine in 1912 for pioneering vascular soothing anastomosis. Which of these structures does not belong to posterior mediastinum? It is the ascending aorta. Ascending aorta is a component of the middle mediastinum, inferior mediastinum, and corresponds to T4, T5 level. Fick's principle establishes a direct relation between which of the following? Oxygen consumption and cardiac output. Fick's principle. An invasive method of correlating oxygen demand and cardiac output by the following relations. Oxygen consumption is equal to cardiac output into arterial sats minus venous sats. Next. Which of the following defects will most likely contain 2 distinct fast and slow conducting pathway? It is corrected transposition. This landmark picture indicates the heart belonging to, anybody can answer this? Andrew Morrow. Why? Because extensionally hypertrophic. Can you appreciate that? Not showing the answer. Yeah, Andrew Morrow. Yeah, he is Andrew Morrow, the person who is in the picture. He has a family history. He's both kids and the present granddaughter who is still alive now. Today he has become. Next. The procedure is best described as the Yasui procedure. It's a combined Rasley and Norwood procedure which gives us the epitome of Norelli operation. Bouncer it was. If you are in children at hospital, Boston, I think this answer is very simplest answer, I think, if you listen to the research. Yes. Yes. Correct. Dr. Robert Goss, who will likely meet on that day, 16th April 1938. He may come in your dreams also very shortly. 16th April, okay. Which of these is not a root transduction procedure? Yes, Kawashima operation is an established surgical procedure to deal with bilateral issues. Next. Which of these structures was not visible from the aorta to RV view in TOF? Pulmonary valve. The pulmonary valve and tricuspid valve leaflets are not seen from this view. The Rave procedure is synonymous with Lecomte procedure. Yes. That's a diagram to explain it. Next. Both pulmonary arteries arising from the posterior wall of the common arterial trunk is best described by Collet-Edward classification as type 2. See the diagram. Can you see this? We have a specimen also for that one. The disc of TTK Chitra valve is made from, yes, ultra high molecular weight polymer. Can you see this is exam question? No mistakes in TTK Chitra and one bilateral valve, at least St. Jude. You should know in and out of these valves. Other valves are maybe pardonable because these are common valves used in the country. Caudal preservation of secondary chordae in the event of extensive rheumatic obliteration subpulmonary apparatus is possible with Monsari's technique. Monsari 1 and Monsari 2. Read about it. Which of the following cannot be classified as a functional single ventricle? Pulmonary atresia. Identify the spiraling surgeon. This is Norman Chamme. Identify the odd node based on the analogy from this picture. Anybody? Who is he? Huh? He's the grandson of Queen Elizabeth. Grandson of Queen Elizabeth Charleston. See this. It is.
Why is Dhaneshwar Borde giving answers?
Giancarlo was the first name of Rastrelli, while the rest had their first names as William. Whether it is William Glenn, William Raskin, William Norwood. Only Rastrelli was called as Giancarlo. The picture is Prince William Charles of Great Britain. I think you have completed 75 questions.
Results, pa?
Yeah, we'll show the results in 2 minutes. As the results come out, I have few things to be completed. I would like to invite 2 of the residents who have passed out in the first attempt, who have been working here with us amongst us, to just share the feedback till the results come. I call upon Dr. Tejdeep today, who was a final year CTVS resident 6 years course from our institute. This is the protocol what I do every year for the last 6-7 years when I'm conducting SCORE. Can you give a mic to him? Come here, friend, Tejdeep, or you can stand here.
Myself, Dr. Tejdeep. I have cleared DNV in first attempt. So I wanted to give 2-3 tips how to clear the exam. So this is like what we do when a case gets admitted in a pre-operative ward, seeing the ECGs, X-rays, discussing with seniors, juniors, colleagues, everyone, and post-operatively writing the operative notes and discussing with the surgeon why we have done this procedure. Post-operatively manage the situation. All this, it should be a daily routine so that it's, whenever anyone asks anything, we will ask it. It's a daily routine. We will answer whatever exams are. Today we saw the same or same thing has been asked by the professors and the teachers. So that will be useful. And diagrams and all everywhere, operative notes, diagrams, you need to practice diagrams, and that will in examination also, as time is less. It is like a 10-mark question, 10 questions will be there, as time is less. Everything make us short and sweet. like make it a flowchart, diagram basis, label the diagram. So that's the tip to clear the exam. So in practical, whatever as Sir said in the morning, diagnosis is wrong also, but the way how you approach towards the case, that will make you in the exam. Thank you. All the best to my colleagues.
Thank you. This is a training wherein SCORE program is conducted by the residents for the residents of the residents. With this concept we had started. This time he is the leader. We train them to become leaders also in organization CMEs. Even though this time it was technically challenging, we took help of technical assistants and all the stuff. He has played a vital role in helping us to organize this meeting. On behalf of the Indian Association, I would like to request Dr. Prasanna Simha, Chairman of SCORE Committee, to give him a membership. The next candidate. The next candidate, I would like to invite Dr. Harshavardhan, who has completed his MCH from All India Institute of Medical Sciences, and he has joined us as a junior consultant, clearing his MCH in first attempt. So we have tips for both MCH students and DNP students of how to approach the exam. Yeah, go to the Harshavardhan, please.
Good evening, everyone. Myself, Dr. Harshavardhan. I'm currently working as junior consultant at this institute. Actually, for a practical exam preparation, it is like completely a different ball game where most of your preparation is based on a case-to-case basis. And in the last 2 days, you have encountered various military exercises and the possible questions that you might face in your examination. So I think in these last 2 days, for each and every case, you people might have covered almost at least 85 to 90%, that I can assure, because last year I also, due to this COVID, I attended the SCORE program online. So where all possible examination cases covering both cardiac and also the thoracic surgery part have been discussed in detail by the examiner, who will maybe also your exam in your exams. So they have been discussed. But for a resident, as a friendly advice, your main preparation and all revolves only for your cases, whatever cases are there. Kindly for congenital part, read all those cases like ASD, PSD, PDA, coactation, RSOV, okay, and tetralogy. Line to line, you kindly read Kirkland, because you still have got at least, I think, minimum 4 to 5 months time for your upcoming practical exams. So it's a good time where you can study Kirkland. That is a must. Then after that, for the adult part, regarding valves and all, you kindly study Sabiston and Spencer, okay, including the CABG and heart failure part. That will cover the adult part. And once you have read these books thoroughly, please read Kurkar, because that is what had Satyasai, this practical examination question and answer book that will be released every year. So these two books are your, they will train you your mind how to face the means what kind of question you will be expecting. Instead of reading everything, you should be in a position to expect what the examiner might be asking. That has been already covered, but again you go through where many of these questions are again covered in those books. Knowing is different and presenting it in proper way in the examination is different. So where you not humble and that once you go through these books, the presentation in those books is in such a way that you can answer it in the same way rather than putting too much of your mind in how to present that. So that way you can impress your examiners and you can do well. Okay, so in the end, I just want to conclude it saying that whatever your degree you will earn, it is all just a license that will be given to you, and your actual learning will start once you earn your license to learn. This is just a license to learn. Okay. So your learning actually will start, because knowing is different, how much ever you know, but ultimately when you drive the needle through the tissue, that feel only when you feel, then you will emerge as an independent surgeon. Okay. Thank
Thank you, Dr.
your
Asher.
exams.
In fact, for all the residents here, we have in year 2020 and 21, about 4 junior consultants from all Institute of Medical Sciences joining Satya Sai Institute. He is one among them. In fact, I would like to thank Dr. Shiv Chaudhary and the entire team from All India Institute for sending such a good candidates who have come down. As he told, your learning starts. They got a license, but learning on how to do, they have found Satya Sai as the right platform. In fact, today I would like to thank Dr. Harshavardhan, who has helped in managing the SCORE program of 1. The most important is, ICU is running at present. We have got 6 cases in ICU. Last 48 hours, he is on duty, and the residents are here attending the SCORE program. I thank him once again for his showing his the way he encouraged the residents also, and on the single request from my end, he was ready to continue his duties for 48 hours. I request Chairman of SCORE, Dr. Porcine Bioprosthesis, to hand over a moment. Now I call upon 1 or 2 residents I want from outside Satya Sai to come and give their feedback. Are the SCORE results, the results ready? It needs 2 more minutes. Come forward. Anybody can come forward. Please come here. We need to give a feedback. Anybody is there? Out of Bangalore? From Care Hospitals? Hello? Come. What's the name? If you can't come, then I have to pick you up. Come. Come here. Next candidate. What is it? You come. Who is it? These are the outside family sector. Yeah, it's yours. The mic is on. Yeah. The camera is set. The camera. Please speak. 48 hours. What you learned, or what, not what you learned. What you felt about the program. Make a comment. How we can improve. Also, you can make a comment. Go ahead.
Was really helpful regarding the example preparation and how
You are from which institute? Kindly introduce the name and institute.
Now from Care Hospitals, Pulmonary in Septal. Regarding this program, I felt it was really helpful in the way of how the questions are asked and how to present the cases and how to
So the important tip what you got is how to slow down in your right. That's a major trick you got. Okay, thank you.
Good evening, sir. This is Dr. Srinivas from Chennai, Apollo. The program was very helpful in spite of all the toughness that we have during this pandemic. Still, you people took it challengingly and conducted the program very well. But we didn't feel any lack in what we learned because of the pandemic, whatever is going on. More than we showing the interest, your interest was more than our interest, and you picked us and you made us do all the things that was very helpful, sir. It was very helpful in all the practical aspects of what we learned, and then it was a nice training.
Thank you. I request once again all the members, the residents, to become associate members of the association. You should be proud to become a member of the association. That's how it is today. Okay. Are the results ready? Before we go with the results, I need some comments from the faculty who are sitting online on board, sir. At present, here only Dr. Prasanima and myself are there. Rest all faculty are left for the day. Be seated. We need 5 more minutes, please. I request our president, Dr. Krishna, to make a few comments. Sir, is there on board?
Yeah, thank you, Dr. Hiramat, and I must congratulate you and Dr. Prasanna Sinha for really conducting this in a spectacular way with the online challenges. Of course, you have learned quite a bit from conducting the national conference, so this must have been actually a piece of cake compared to what happened with the national conference. So, but congratulations anyway. I think there was a fairly active student participation, and because of the online activity, I'm sure more students would have been able to participate in them as compared to the physical score. Roughly how many students did you have in the regular score programs?
Regular score around 180 to 190, sir. This time it was 176.
Right. No, so 180, 190
That's a
came
mix of
physically?
CTVS, anesthesia, cardiology mix. It goes
Yeah,
up.
right. Okay. So anyway, congratulations. It was quite a enlightening experience.
Thank you. I think even transmission did not have problems, sir. Luckily, things went on well. Very good feedback response we have got. Thank you, sir. Thank you, sir. And I sincerely thank our president, being a senior pediatric cardiac surgeon of our country. He has spent almost last 48 hours amongst us. And he was very meticulous, following the program continuously. In fact, yesterday's quiz got postponed. He questioned me immediately, what are the issues? And we saw that the quiz was conducted. Thank you, sir. Thank you for being there. I request other faculty members who are there on board, Dr. Neelam Desai, Dr. Sushila Sripad, I request you to make a few comments, please.
Yeah, I think it was a brilliant endeavor on your part, Hiramat, with your team and the IACTS to conduct the program. The 2 days is a very successful program. But I think there are just few suggestions that this can become a 3-day program, because the topics which you cover are so exhaustive that I think it needs more time for even the students to sink in. I don't know how, even last year we had been discussing the same thing, but so far as it's not tiring for everybody, I think it's good. Otherwise, it can get extended into a 3-day program. That's what I feel. And I think everybody has put in their efforts, and congratulations to everybody for this. Yes.
Thank you, madam. The topic
Yes.
chosen was based on the feedback from the students in the last core program. Maybe next time I'll be go into more practical slowly. I think we can look at this one.
Yeah. I think few didactic lectures can be omitted because they can always learn that. And more practical orientation should go, I feel.
Sure,
That's what I
think
feel.
what has been decided in the executive committee is now to continue the master classes which have been held as a
Yeah.
form of teaching protocols
Yes, sir.
for the DNB students through the year long.
Yes.
So at least that will take care of those didactic lectures, and then the
Yes,
score
sir.
can focus on case presentations and
Practicals,
all
like
those
which we
practical
never get
aspects.
to. Yeah. Yes, sir.
So that's the plan going forward.
More case scenarios, more complications and instruments and things like that. Yeah.
So with the master classes, we'll cover all the theory part.
We'll cover all
the
the.
didactic lectures.
Yeah.
Yes, sir. Yes, sir.
Thank you, madam. Thank you for the input.
Yes.
I would request Dr. Sushila Sripad. She is one of the senior most cardiac surgeons of a fraternity from Kolkata. And she's kind enough spending almost last 48 hours amongst us. She's a very good teacher and always loves teaching. Even at the age of 75 plus, she's always with us. Please, madam, please go ahead.
First and foremost, hearty congratulations for a very well conducted score. And I think it has been exhaustive. I've got a feedback from my trainees here that they really learned a lot, but what's more they learned was they have to go into the depth and read really well. That was an eye-opener for them. We keep telling them, but this kind of, all India exposure did tell them that they have to focus a lot more and learn. One of the two things I would like to suggest, can we have some of the sessions, the practical sessions or demo sessions, little more focused without too much of exaggeration or, diversion, just focus on them. And the second thing is that I think didactic lecture, I would agree with Dr. Desai, we don't require too many of them. There are plenty already. I think what Dr. Iyer had done, focusing, and Dr. Sampath Kumar, focusing on a little bit of the history, which many of the students seem to ignore completely. That is very important. And the third comment I would make is, I think this is a very good opportunity to focus on the various aspects of Indian contributions, which we seem to neglect. We are always talking about the American contributions and these contributions and that. So I think there's plenty of work being done. They are presenting in the conferences, but I think in a consolidated way, if you could have a kind of presentation for the students. Thank you.
Thank you, madam. Any other faculty on board would like to share? Dr. Vinay Shukla is there. I think with that, we'll first announce the prize winner, which was the first of its kind prize in score what we have kept under the leadership of our President, Dr. Krishna Iyer, who readily announced to give one of the prizes for the best case presentation. Many criteria were taken into consideration based on all the feedback from all the examiners, and the final decision was by the chairperson of the IACTS SCORE committee, Dr. Prasanna Simha, and the winner for this case presentations is Dr. Vinay Malhotra from National Heart Institute, New Delhi. Is he there? Satish. Is he there, Vinay Malhotra? In fact, this is the first time where the association has taken initiative of giving a prize. And you know what prize we have kept this time? The operating loops with the headlight. It's first Make in India operating loop, which has come out just recently. Vinay Malhotra, and we will courier the loops to him. He left.
Congratulations to him.
Yeah.
And apart from this, the quiz, the online quiz prizes winners are
Can you have a projection of Dr. Vinay Malhotra?
Vinay Malhotra. He has left. His flight was at around 8 o'clock. I think he has left. He
don't have a. Okay.
He presented 2 cases, and there were other criteria where the chairman has taken this. Can you come forward, please? The technical team can help me to release the quiz winner. Yeah, feedback form is compulsory. It's been sent to you. Kindly send the feedback form for all the participants. It's an online form only. Once you give the feedback form, you will give given an option to download the certificate, e-certificate, where Karnataka Medical Council has sanctioned 2 credit hours for this program. Online programs, state government sanctions 1 credit hour for 1 day, irrespective of whatever program we have. That was the rules of the MCI and the Karnataka Medical Council. So we conducted 2 days, so we were sanctioned 2 days, 2 credit hours. And one more thing regarding the Satyasai notes, version 7, we are going to release shortly. I think in the next, within a week, we are going to share it with you, all the residents who are registered. Wherein version 7, we have included all trials this time, clinical trials. Every year we try to include one or the other. We are shortly planning to work on formatting a book on it, so e-book, so that all the residents it will help. So this year we have included the clinical trials. You can go through that. The link will be shared with you. No pen drives. We're trying to limit our electronic devices, and earlier we were giving CDs. We started then pen drives. Now we are just sharing the link. Slowly technology we're trying to imbibe as much as possible. That will release within a week. It's already ready. A few corrections, and immediately within a week you will get each whoever has registered will get the link.
Why are the results taking time? I thought this should be instantaneous.
Yes, sir. The technical team is working on it. Can you display the results? Vinay, at the outset, as till the results come, I would like to thank my entire team who have been functioning. I request our residents to come down stage, please. As I finish, yes, feedback form, entering feedback. What is this? Yeah, entering the feedback form is compulsory to receive participation certificates. You have to click this link for the feedback form, bit.ly/3rp4zeg. And it will be sent as email also. Yes, and the link also is there. You can write it down and get the feedback. Immediately get it. Our department residents, can you come forward here, please? Hello. Don't waste time. Come fast now. Utkarsh, Dinesh, Deepika, where are they? Please come forward. Harisha, Harshvardhan.
No, it is just stretching. It's just stretching. I'll keep listening on.
As they come.
So then it come away. To get him out. He's being very
Sir, give us 2-3 minutes. Huh? Where's he went? It's okay. Follow. The perfusion team, please come. Please come, please come. All of you, Mohan, you also come. This is the team who have been working for the last almost 2-3 months for the program. The entire perfusion department. Mohan, senior manager, Mohan, please come up. Come fast. Momita and the translators, both of you come, please. Don't waste time, please come. You can sit here for a photograph. After this, we'll have the national anthem and then we'll disperse. Feedback form is compulsory to receive participant certificate.
Madam, apart from the winners, you declare the one who got the maximum marks also. It can be a non-member or whatever.
Yeah, madam, we'll do that. Can we do that? Team, yes.
Whatever you want me to.
The results are ready. Dr. Prasanna Simha's mask, he never removes. Last 48 hours, I think, once he comes, he never removes the mask. He doesn't have water also, neither eats any food. Non-stop teaching. I keep telling you people, a lesson to learn in this COVID era is, I think, is the one person who never takes out his mask, the N95 mask. Yeah, can we announce the quiz, really? Dr. Iyer is there?
Yeah, I'm here.
Yeah, yes, sir. Thank you, sir. The results of the IACTS digital quiz is hearty congratulations to the winners. Winners are requested to reach the secretary. Yes. Oh, Dr. Utkarsh Sangu, he is a resident. We have 2 in-house and Srinivas and Tanusri Kar is New Delhi online, I think, correct? She is online, yeah, very good. Congratulations, Tanusri. Congratulations, Dr. Utkarsh and Dr. Srinivasa. And meantime, can you show who scored highest among the fellow members and life members? Can you show that? Dr. Iyer, sir, are we allowed to show that?
Yeah, sure.
Yeah, please. You can take 3 of them in the top 3. Can you do that? As that comes, sir, I would like to thank on behalf of the Indian Association of Cardiac and Vascular Surgeons and Sri Sathya Sai Institute of Higher Medical Sciences. I would like to thank our president and senior pediatric cardiac surgeon of our country, Dr. Krishna Iyer, for seeing that this program is conducted very well and standing like a rock beside me, supporting all my activities for education purpose. I would also like to thank our chairman, Dr. Prasimha Rao, whom last 48 hours he's been non-stop with us. And as you all know, as you all seen him, I keep telling him in every conference, he's just unstoppable. You ask him any question, he has an answer for it. So he was kind enough to spend 48 hours with us, amongst us. I thank you, sir, once again for being our sons, and we continue your support for the association in future also. At the same time, I'd like to thank all my team members who saw here. I would like to thank Dr. Shekhar Rao, Director of our institute, who was really cooperative and helping us in allowing me to function in this hall. I would like to thank Mr. Darshan and Satish and his entire team from Planetech, who have made it very helpful in transmissions. They are the ones who helped me in conducting the national conference. That was a huge challenge by itself. 7 halls plus elections was a major Herculean task which I underwent. The same team is amongst us with us today, and really the transmission was really excellent. I would also like to thank our senior manager, Mr. Mohan Kumar, who really has been struggling for the last 2-3 months to see that the program is a grand success. His entire team of proficient students who are all here amongst us. Apart from this, I would like to thank my ICU staff, the hospital staff of Satya Sai Institute, the director's PA, and all the senior managers who have really helped, the canteen staff who have taken care. Even at night 9 o'clock also, they have made arrangements for dinner. Finally, I thank the Indian Association of Cardiac Catheterization, the entire executive committee, who has stood beside me in conducting this program online. Are we there ready? Yeah. Sir, we are ready with the top 5 scores of our faculty and life members. Yeah, please go ahead. It's a surprise. Oh, the president of All India Association of Cardiac Catheterization.
Sir should be given a special prize.
Yes, I am.
They'll think it is rigged.
Sir, the mix is, oh, this is a mix.
Sir, you have scored even above the winner, sir. You deserve a special prize.
Pardon me?
Sir has scored even above Utkarsh.
Yes, sir. Yes, madam. Yes, madam.
So he gets a special prize.
Marks you are given, is it? No. Yeah, winners is Dr. K. Sir first. This is the right. This is the accordingly you are selected. Yeah. This comes in the computer itself by default. So
you'll be accused of rigging this.
Hey, Dr. Srikant Kasturi, who is the sir from Bangalore? He is the 4th winner, and Dr. Tanu Srikar. Fine. Yeah. Wow. Thank you, sir. Thank you all for joining online and offline, who are here, India and abroad. Look forward.
Well, I just joined for fun. It was quite fun, actually.
Yeah, nice.
We enjoyed. We put a lot of brains into this quiz program to make it more technical savvy, user friendly. And also, I was a little worried about the youngsters who are very much technically savvy of copying, and also I had kept 20 seconds only. So things are okay. We'll rise for the national anthem, sir.
भारत भाग्य विधाता
पंजाब सिंध गुजरात मराठा
द्राविड़ उत्कल बंगा
विंध्य हिमाचल यमुना गंगा
उच्छल जलधि तरंग तव शुभ नाम जागे तब शुभ आशीष मांगे गाहे तव जय गाथा
जन गण मंगलदायक जय हे
भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Dinner has been arranged. Quiz prize winners. The cash prize is, first prize is 10,000, second prize is 5,000, third prize is 3,000 rupees. Thank you once again.